Ladies and gentlemen, we now move on to our Day 1 Lunch Symposium with a lecture on LDL-C reduction and vascular outcomes post-stroke, updates from Sparkle and TST, presented by Professor Pierre Amarenco, Chair of the Department of Urology and Stroke Center, Bichat Hospital, Paris, France, investigator and steering committee member of numerous clinical trials and registries. Professor Amarenco has written more than 300 articles in peer-reviewed journals and more than 125 reviews and book chapters.
In a world that is perpetually changing, there is increasing need for steady leadership. Companies demonstrating the courage to address the world's emerging healthcare challenges with passion and compassion. Viatris is redefining the healthcare landscape. We are uniquely positioned to be a source of stability with the commitment, capability, and vision to meet the world's evolving patient needs. Viatris believes in healthcare not as it is, but as it should be. We know the way to provide access to a sustainable, affordable, and diverse portfolio of high-quality medicines, regardless of a patient's geography or circumstance. We are leading the way by providing a versatile, scalable platform that combines best-in-class manufacturing and supply capabilities with innovative solutions that span therapeutic areas. And as a partner of choice, we are pioneering a way to empower companies of any size to leverage our distinctive global healthcare gateway, so products from across the industry and around the world can rapidly and effectively reach patients where they live. We do so with a collective spirit of resilience, driving forward until each challenge is addressed and every opportunity embraced. We are inspired by this moment of shared purpose, because as Viatris, we know the way to empower people worldwide to live healthier at every stage of life.
Life has never been the same since na-heart attack ako. Buti na lang, I have a loving wife na matyaga akong tinutulungan at inaalagaan, and an understanding and caring son. I just hope I can fully recover soon, hindi magaya sa iba na nauulit ang atake. Para naman di mahirapan si Gina, and I can truly fulfill my role as the head of this family.
My mom taught me how to paint. Naman ako ang artistic talent niya, and I miss her dearly. My mom died when I was 12. The doctor said it was due to complications of her diabetes. Now I'm scared na matulad sa kanya, kasi naman ako rin ang diabetes niya. I don't want Bella to experience the same pain and sadness I went through with mom's loss. I want to be beside her as she works for her dreams and launches her own art exhibit.
Tomorrow is on every patient's mind, and they rely on your expertise and guidance when it comes to the long-term impact of treatment. That's why the choices you make for your patients matter. With atorvastatin Lipitor's unparalleled proven outcomes in reducing CV events across a wide range of patients, you can protect them from stroke, myocardial infarction, and other CV events that can shatter their hopes and dreams for their loved ones. There are many good reasons to choose atorvastatin Lipitor for your patients. Atorvastatin Lipitor remains to be the leading statin in the Philippines and has impacted the lives of millions of patients worldwide for over 20 years. What you choose for your patients matters. Make it count. Make it atorvastatin Lipitor.
I am Pierre Amarenco. I'm chair of the Department of Neurology and Stroke Center at Bichat Hospital, Paris University in Paris, France. My main interest is cerebrovascular disease, and I was involved in numbers of stroke prevention trials and stroke registries. So the goal of this webinar is to give you a comprehensive understanding of the relationship between LDL cholesterol and stroke risk, to review the SPARKLE study results and the cardiovascular outcomes, to review the latest SPARKLE recurrent events data, a very interesting new sub-study published recently, and to review the Treat Stroke to Target study analysis, which is important, as you will see, for demonstrating the necessity of reducing LDL cholesterol very low in the prevention of recurrent stroke, and to summarize current guidelines recommendation for statin therapy in the prevention of stroke. Stroke is an issue worldwide, and the rate of sex-adjusted and age-adjusted loss of disability adjusted life years, DALY, as a result of stroke is very high. So stroke is an issue worldwide, and we should do everything we can to prevent a first stroke and recurrent stroke. As you know, there are several underlying causes of stroke. Stroke are classically separated between hemorrhagic stroke and ischemic stroke. And among ischemic stroke, which represent more than 80% of all strokes, there are large artery disease stroke, atherosclerotic disease stroke, which is about 40%. And then we have cardioembolic stroke, small vessel disease, largely related to hypertensive disease, cryptogenic stroke, meaning stroke of unknown cause, but with underlying disease like atherosclerotic disease, and finally dissection. Among patients with large artery disease, we have patients with a local obstruction, for example, intracranial atherosclerotic disease is the site of rupture plaque and thrombosis occluding the intracranial artery, or embolism, for example, plaque in the carotid artery, extracranial carotid artery, or in the aortic arch rupture, and there is a thrombosis on top of these ruptures, plaque. And then a small emboli can go to the brain, occluding a distal brain artery. Among risk factors of stroke, dyslipidemia is one very important risk factor, and the INTERSTROKE case control study, which mirrored the INTERHEART case control study, showed that dyslipidemia is increased by almost 2 times the risk of stroke. You see that hypertension increased the risk by almost 3 times. Then we have cardiac disease and particularly atrial fibrillation. So what we want to avoid clearly is development of atherosclerotic disease since the age of 20. We have seen the global burden disease saying that at the age of 25, 1 in 4 will have a stroke in the rest of his life. So if we prevent very early atherosclerotic disease, then we will avoid complication of atherosclerotic disease. So to this end, we need to prevent the development of atherosclerotic disease by a better lifestyle, better diet, and we know that in our Western countries is a very important problem, but becoming also very important in Eastern countries, in Asia, etc. The primary prevention of atherosclerotic disease is control of risk factors. Control of risk factors again involves modification of diet, lifestyle management, and medications. In case of hypertension, we should treat hypertensive patients. We should treat patients with dyslipidemia, stop smoking, etc., to prevent the first occurrence of an atherosclerotic event. Secondary prevention is for patients who already had a stroke or a myocardial infarction or a symptomatic peripheral artery disease. It's very important to be very strict on the control of risk factors in our patients who had a previous vascular event. So coming to stroke and LDL cholesterol lowering, I start with this graph, which is a meta-regression of the risk, showing the risk of LDL cholesterol on the y-axis and the between group difference in clinical trials in LDL cholesterol. So, for example, if you reduce LDL cholesterol by 20%, you will have a reduction of stroke by almost 15%. If you reduce the risk, the LDL cholesterol by 40%, then you will have a reduction by almost 30%. So more you reduce LDL cholesterol, more you reduce the risk of stroke. And then on this graph, you have the Sparkle trial. The Sparkle trial was the only trial in secondary prevention dedicated to stroke. And for the Sparkle trial, we used atorvastatin, 80 milligrams per day, versus placebo. So here you have the overall result of the Sparkle trial. And here you have the Sparkle subgroup of patients with atherosclerotic disease. And you see that this group of patients clustered with all other trials addressing atherosclerotic cardiovascular disease. Those with atherosclerotic disease largely benefited from a reduction in LDL cholesterol. And this is evident on this graph. There have been a lot of mechanisms thought to be involved in this reduction of stroke incidence in patients on statin. But the main mechanism is LDL reduction. Second is plaque stabilization, the so-called pleiotropic effect of statins, interfering with inflammation, with oxidized LDL within the plaque. And very quickly, since we have studies showing that in 3 months, you immediately decrease inflammation within the plaque, the carotid plaque, and decrease also oxidized LDLs and a lot of other processes leading to the rupture plaque. We know also that on the right side of the slide that statins improve endothelial function, reduce platelet aggregation, and has a little antithrombotic effect. Also, we have evidence that statin reduce blood pressure. And this is very important because even if it is 2 or 3 millimeter mercury, it's a bonus to reduce stroke. Of course, it is not the reason for the effect of statin in stroke prevention, but this is one bonus, which is important. And finally, we have evidences in animal models that statins may be neuroprotective, particularly through upregulation of nitric oxide, improving cerebral blood flow, and reducing infarct size. So this is the total meta-regression analysis we saw before, and you see here that with all statin trials in primary prevention of stroke, you see that there was an 18% relative risk reduction, very consistent effect, with no heterogeneity between trials. Everything goes in the same direction. So very strong meta-analysis in favor of prescribing statin therapy in prevention of first stroke. As an illustration, you have here the ASCOT LLA trial. ASCOT was an hypertensive trial looking at modern strategy, antihypertensive strategy versus old, based on beta blocker and diuretics. And there was a factorial plan randomizing patients with normal total LDL cholesterol. And these patients with normal total cholesterol were re-randomized to either atorvastatin 10 milligram or placebo. And the trial was stopped earlier because the primary endpoint was significantly reduced after 3 years in this trial. And among the primary endpoint, there was the stroke, fatal or non-fatal. And this is what is represented on this graph. You see that there was a 27% relative risk reduction in stroke in this patient. This is the secondary prevention part of the meta-analysis we have seen before. You have here the SPARKLE trial, the HPS trial, but also the patients randomized in lipids and in care with cerebrovascular disease. And you see that everything goes in the same direction with a significant reduction in stroke in these patients. Of course, it was largely driven by the result of the SPARKLE trial. So, what was the SPARKLE trial? So again, SPARKLE was the only trial in secondary prevention dedicated to stroke patients. And what we wanted to prevent in SPARKLE was the first occurrence of a total, a fatal and non-fatal stroke. So the patient population was from sites worldwide. They had no history of coronary heart disease, because at that time, when we started SPARKLE, it was back in 1998, we had evidences from 3 trials that these patients should not be on placebo and should receive a statin. So we eliminated the patient who had a history of coronary artery disease. So how much does it represent in stroke patients? About 20%. So we at SPARKLE addressed the 80% remaining patients. And we randomized patients with an LDL cholesterol above 100 milligram and below 190 milligram per deciliter. So the patients, we randomized 4,731 patients to either atorvastatin 80 milligram or placebo. It was, of course, double-blind trials, and we were looking for 540 primary endpoints. You have here the baseline characteristics. You see that female sex represented about 40% of the patients. We included mostly patients with an ischemic stroke, but we had some patients with hemorrhagic stroke, about 2 to 3%. We had 30% of the patient with a TIA, and what is also important on this slide is to see that statin therapy, patients statin naive were about 60% in Sparkle. So a lot of patients who come to the hospital with a first stroke are statin naive. And it's important to think about this for the primary prevention. So here is the effect of atorvastatin 80 milligram versus placebo after 5 years, 4.9 years of follow-up. And you see that the primary endpoint was significantly reduced by 16%. Remember that we excluded patients with history of symptomatic coronary artery disease. So these patients, here in Sparkle, we addressed the silent coronary artery disease in our patients. And we know, as a stroke neurologist, that our patients will die mostly from myocardial infarction. And then in Sparkle, we showed that we have a 35% relative risk reduction in major coronary events. Here you have a variety of events. The primary endpoint here in patients with intense LDL lowerings. It is an analysis we've done in patients who achieved an LDL less than 70 milligram per deciliter. And you see that in this patient, we had a 31% relative risk reduction in fatal and non-fatal stroke. We had a strong reduction also in major coronary event, any coronary heart disease endpoints, and any revascularization procedures. So it's really a very important trial in terms of secondary prevention. The slide suggests that less than 70 milligram per deciliter may be the goal we should have in secondary prevention of stroke. We will see that later. How about patients randomized with diabetes in Sparkle? We had a 30% relative risk reduction in the primary endpoint, stroke and fatal and non, on atorvastatin 80 milligram. So diabetic patients is clearly a group to target in secondary prevention of stroke with intense statin therapy with atorvastatin 80 milligram. So on this slide, we see that in diabetic patients, the reduction of any coronary heart disease event was very strong, with a more than 50% reduction. Any revascularization procedure in diabetic patients was reduced by 64%. So diabetic patients is really a group to target after a stroke with atorvastatin 80 milligram to reduce the burden of vascular event. And then a very interesting sub-analysis that has been more recently performed in Sparkle was about evolution of renal function on atorvastatin and on placebo. On the top panel, you have in the y-axis the GFR, glomerular filtration rate, and the x-axis you have the time. And you remember that the trial lasted 5 years. So on blue, you have the atorvastatin group, and on gray or black, you have the placebo group. And you can see that there was a difference in the evolution of the GFR with a improvement on atorvastatin, and also an improvement on placebo, but less, significantly less statistically than on atorvastatin. And then on the lower panel, you have the diabetic patients. And in diabetic patients, on placebo, in black, you have a degradation over time of the renal function, which is expected. But on atorvastatin, in blue, you see that we did not see this degradation of renal function. We saw an improvement of renal function and over time, and it was sustained over time, and significant difference with placebo. So this is a very important observation. Atorvastatin 80 milligram is nephroprotective. So this is a summary of the SPARKLE trial. You have on the left part of the slide, the left panel, you see that this is a primary endpoint, stroke, which has been divided into hemorrhagic stroke in red, of course, and ischemic stroke in gray. And overall, there was a 16% relative risk reduction. There was a slight increase compared to placebo in hemorrhagic stroke among the primary endpoint. But overall, there was a stronger reduction in ischemic stroke, that overall there was a benefit of statin therapy, atorvastatin 80 milligram. The reason for this slight increase in hemorrhagic stroke is not really known, but the sub-analysis we've done in SPARKLE showed that it was clearly related to patients with uncontrolled hypertension. These patients had 6 times higher risk of having an hemorrhagic stroke than the patients with controlled hypertension. So the message of this sub-analysis was that when you are in secondary prevention and you start a statin therapy, you need to control blood pressure. On the right panel of the slide, you have the total first event analysis. You see that we have added to the preceding panel, we have added major coronary events, which were less than on atorvastatin 80 milligram than on placebo. And overall, you have a even more significant reduction. And you know that when you are in secondary prevention, you don't want to only reduce stroke recurrence, but you want also to reduce major coronary event. And this is what this right panel shows you. So another way to present this is to look at the reduction of these events, stroke, major coronary event, and all-cause death according to LDL cholesterol reduction. And you see that stroke incidence was reduced by 28% in patients who achieve an LDL cholesterol less than 70 milligram. Major coronary event was reduced by 36% in this group of patients. And all-cause death was also reduced, not quite reaching statistical significance. So clearly, this sub-analysis of the SPARKLE trial suggested that achieving less than 70 milligram after a stroke is really beneficial with atorvastatin 80 milligram. And this was the purpose, the demonstration of this was the purpose of the TST trial, Treat Stroke to Target trial, we will see later in this talk. We further analyzed SPARKLE recently, looking at total event analysis. Not only the first event, but the second, the third, the fourth event. You know that we have some patients who had multiple events, not only stroke, but also myocardial infarction, peripheral artery disease, and it may be the second, the first, the third, the fourth event. We wanted to see whether atorvastatin 80 milligram can decrease the global burden of atherosclerotic cardiovascular disease. So you have here on this slide the first event, as we saw on the previous slides. And then you have the subsequent event and the total event analysis. And you see that analysis of first event on the left panel represent less than half of the total event reduction with atorvastatin here. And you see the total event reduction, 390 fewer total events on atorvastatin compared to placebo. When we analyzed the first event, it was only 160 fewer first event. So atorvastatin 80 milligram not only reduced stroke, not only reduced first stroke and first major coronary event, but also the subsequent event, and even better, the subsequent event. Here is a first and subsequent event across a vascular territory, and you see that there was a strong reduction in stroke, and in stroke it was in orange, coronary artery disease it is in purple, and peripheral artery disease in green. Here is a first and subsequent fatal event across vascular territory. And again, for first, second, third, and fourth and subsequent event, you have a reduction of cerebrovascular event in orange and coronary event in purple. And it was true for all four categories. Here is a classic Kaplan-Meier curves for first and subsequent event. Clearly, we have a larger divergence of the curve for total event than for first event. And of course, very significant. Here is a forest plot to summarize this. You have the total event analysis on the top line. Very significant with a 32% relative risk reduction. Remember that in Sparkle, the primary endpoint was reduced. Time to first event was reduced by 16%. Here we speak about 32% relative risk reduction of total event. Total cerebrovascular disease was reduced by 22% in this total event analysis, not 16 like in first event analysis, but here 24% relative risk reduction. And the total coronary event was reduced by almost 50%, as were peripheral artery disease event. So I think this total event analysis is really interesting in terms of secondary prevention to give you what you are doing when you prescribe atorvastatin 80 milligram in your patient. So coming back to diabetic patients in this total event analysis, you see the spectacular reduction in patients with diabetes, 50% relative risk reduction in total event. And then the relationship of this total event reduction as regard to LDL cholesterol reduction. More you reduce LDL cholesterol in Sparkle, more you reduce total event. So this result is very strong and support the idea to really test the benefit of achieving an LDL cholesterol less than 70 milligram in patients with a stroke. So in conclusion of this total event analysis, the total number of vascular events prevented with atorvastatin was 2 times the number of first event prevented. First events decreased by 27% and total event by 32% in patients achieving LDL cholesterol reduction with atorvastatin 80 milligram per deciliter per day. First and subsequent events were reduced across all vascular territories, and total vascular events were reduced by 50% in diabetic patients. And we know that diabetes is something very important And at an LDL cholesterol less than 100 milligram per deciliter, the benefit is related to LDL cholesterol achieved, as we just saw on the graph. So total event reduction captures totality of atorvastatin efficacy in reducing disease burden after a stroke or TIA, and it's a very, very interesting result. So we now come to the second trial I wanted to speak with you. It was a treat stroke to target trial. I had the privilege to chair the executive committee of that trial, and it was really the follow-up of the Sparkle trial. Because, as you know, after Sparkle, all guidelines worldwide recommended intensive statin therapy after TIA or ischemic stroke, particularly in patients with atherosclerotic disease. But as you know, in practice, it is not clear to implement the Sparkle trial results because doctors should prescribe atorvastatin 80 milligram, and they all leave they are all discharged on atorvastatin 80 milligram in my department and in France and in many countries. But 3 months later, when you see the patients, frequently the dosage has been reduced by the general practitioner or the cardiologist or another doctor, or the patient stopped the statin, or another statin has been prescribed, less potent statin like pravastatin or simvastatin, etc. But yes, the dosage matter, and probably the goal, LDL cholesterol goal matter. If we can say to the general practitioners and other physicians that we must go below a certain number, 70 milligram per deciliter, then it will be easier for them to titrate statin treatment to that level. We decided to do the treat stroke to target trial to compare an LDL cholesterol less than 70 milligram to an LDL cholesterol between 90 and 110 milligram per deciliter after an ischemic stroke or TIA with atherosclerotic disease documented by imaging. And the investigator could use any statin he wanted, commercially available. Just he has to titrate the statin. Very importantly, we had a team in our trial office that called by telephone all patients after randomization to make sure that they are treated to that assigned target, less than 70 or 100 milligram. And if the assigned target was not met, then the research assistant sent an email to the local investigator to make sure that he will adapt the treatment to reach the target assigned to randomization. That was very important to achieve the result we had. TST trial design was a randomization of patients with an ischemic stroke or a TIA with evidence of atherosclerotic stenosis, and LDL. The patient were assigned to an LDL cholesterol 100 milligram plus minus 10 milligram or 2.5 millimole, or to an LDL cholesterol less than 70 milligram or 1.8 millimole per liter. The trial lasted on average 3.5 years. We had 61 centers in France, 16 centers in Korea. We had more than 5 years of follow-up in France on average. So the primary endpoint was a composite endpoint of non-fatal cerebral infarction or stroke of undetermined origin, non-fatal myocardial infarction, hospitalization for unstable angina followed by urgent coronary revascularization, TIA treated with urgent carotid revascularization, and finally cardiovascular death, including unexplained sudden death. So the baseline characteristics are presented here. You see the mean age of the patients, 66, 67. Males dominated the trial, 67% of the sample. What is interesting to note also is that the mean LDL cholesterol at baseline was around 135, which is about the same as in Sparkle trial. You have the number of patients with hypertension, 64%, 67%. Diabetes, 22% of the patients. Also, patients who were statin naive represented about 50%, 55% of the patients, like in Sparkle. Here is the LDL cholesterol achieved. And as you can see on this graph, we achieved the trial hypothesis. That is, a group assigned to a 100 milligram per deciliter had on average, an LDL cholesterol of 96 milligram per deciliter. And those assigned an LDL cholesterol less than 70 milligram had, on average, an LDL cholesterol of 65 milligram per deciliter. And to achieve this goal, in the higher target group, we use statin only in 92% of the patients. And in the lower target group, we use statin only in about 2/3 of the patients. The others needed an addition of ezetimibe. So this is a primary endpoint result with a clear divergence of the curve from the very beginning and a 22% relative risk reduction in the primary endpoint in the lower target group as compared to higher target group, which was significant. Of the results of the TST, the benefits of treatment to lower target were consistent across subgroups, including age, sex, and presence or absence of diabetes at baseline. Hazard ratios for all secondary endpoints were in same direction as the primary endpoint. And very important, in the lower target group, there was no increase in intracranial hemorrhage and newly diagnosed diabetes, which is another potential adverse event of statin treatment that have been brought up in recent years. There was no increase in newly diagnosed diabetes, no significant increase in newly diagnosed diabetes in the lower target group as compared to the higher target group. I want to strengthen this point of low LDL cholesterol and hemorrhagic stroke risk, which was not the case in TST trial at 75 milligram per deciliter on average. But you know that other trials with simvastatin and ezetimibe in IMPROVE-IT trial, in the PCSK9 inhibitor trials, Fourier and Odyssey outcome trials, there was no increase in hemorrhagic stroke despite a very low LDL cholesterol, like 30 milligram per deciliter in the Fourier trial, 40 milligram in the Odyssey trial. Then we did a sub-analysis of the TST trial in the French cohort. Why? Because we had more than 2,000 patients randomized in this subgroup in France. And in France, the follow-up lasted 5 years, 5.3 years, like in Sparkle. So it's a good comparison. So we found exactly the same average LDL cholesterol, 96 milligram per deciliter in the higher target group and 65 milligram per deciliter in the lower target group. Again, 2/3 of the patients were on statin only in the lower target group. And you see that we have the same kind of divergence of the curve even earlier and better with a 27% relative risk reduction of the primary endpoint in this cohort. So very consistent result with a SPARKLE analysis. I think TST trial set a new standard for secondary stroke prevention in patients with TIA and minor stroke or a stroke, atherosclerotic disease stroke, to show that these patients had a lower vascular event risk than in patients with a LDL cholesterol of 100 milligram. So that is something very, very important and should be implemented in guidelines soon. We did an ancillary study of the TST trial, which was called TST Plus, plus for plaque ultrasound study. We followed these patients with carotid ultrasonography, looking at carotid intermediate thickness in patients assigned to LDL cholesterol 100 milligram per deciliter and those assigned to less than 70 milligram per deciliter. So we had a visit until the year 5. And what you see on the right panel is the change of common carotid artery intermediate thickness. In blue, you have the 100 milligram per deciliter group, the higher target group, and in red, you have the lower target group. What you can see is that in the higher target group, you have a kind of stability of carotid atherosclerosis, a little reduction, but not quite significant. But in the lower target group, you have a clear regression of carotid atherosclerosis, which was very significant, and this paper is now online in circulation. So the conclusion is that after an ischemic stroke or TIA, reducing LDL cholesterol to less than 70 milligram per deciliter, that is 1.8 millimole per liter, significantly reduced subsequent cardiovascular events compared to its target range 90 to 110 milligram per deciliter, that is 2.3 to 2.8 millimole per liter. The benefit of lower LDL-C was consistent across most subgroups. This benefit was achieved without a significant increase in intracranial hemorrhage, very important data, or newly diagnosed diabetes. And LDL cholesterol less than 70 milligram, 1.8 millimole per liter, can be achieved with statin alone in almost 2/3 of the patients. So this is a busy slide to show you the incidence of adverse event by body system with atorvastatin in all trials. 44 trials gathered together, 16,000 patients. And this is the treatment-associated adverse events that were collected in atorvastatin and placebo groups. And you see no difference, including no difference in musculoskeletal adverse event. That is no more myopathy on atorvastatin 80, 10, 40 than on placebo. Of course, in real practice, we know that some patients have muscle pain, but even if myalgia in practice is more important, in a placebo-controlled trial, it was not evident. Almost what we can be sure is that the hard endpoint, which is myopathy, is not more frequent on atorvastatin 80 than on placebo. So coming now to the guidelines in secondary prevention of atherosclerotic cardiovascular event, including stroke. We had the recent ACC and American Heart Association guidelines recommending that we should target a 50%, more than 50% reduction from baseline in LDL cholesterol. In patients with an baseline LDL cholesterol above 70 milligram per deciliter. So, if the patient still have an LDL cholesterol above 70 milligram per deciliter on high-intensity statin treatment, then you may add a PCSK9 inhibitor or ezetimibe in high-risk patients. In the ESC, European Society of Cardiology guideline, is even more strong, is even stronger, because they recommend that high-intensity statin treatment be given in patients to target an LDL cholesterol less than 55 milligram when they are at high risk, that is in secondary prevention. So the TST trial in this context really showed to vascular neurologists that now we should forget about lower dosage of statin. What we want to do for our patients is to target an LDL cholesterol less than 70 milligram. But if we look at the global burden of atherosclerotic disease, the real target may be less than 55 milligram in our patient. And personally, in my practice, I'm now targeting less than 55 milligram per deciliter. So the other recommendations are really consistent with these two previous recommendations. In summary, high-intensity lipid-lowering therapy with atorvastatin is effective in secondary prevention of stroke and in patients with TIA, and we have the Sparkle and TST trial showing that. Intensive lipid-lowering therapy reduces events across multiple vascular beds, important to consider, and the benefit is related to the reduction in LDL cholesterol achieved. High-intensity lipid lowering has been well tolerated in a pooled analysis, and in particular in Sparkle. And guidelines recommend high-intensity statin therapy after an ischemic stroke or TIA, and I should add that the target should be less than 70 milligram in your patient with atherosclerotic stenosis on board.
We now proceed to the Q&A with Professor Amarenko. How soon after onset of ischemic stroke should a statin be introduced?
So this question has not really been addressed in randomized trial, but based on guidelines, recommendations from ESC, from AHA, one should start the statin as early as possible before hospital discharge. I think this is the most practical recommendation we can make. There is no reason to think that there will be harm to start a statin treatment early after the stroke. We had plenty of observational studies looking at the effect of statin at the acute phase of stroke, and there was no harm. So the best, for practical reason, is to start before discharge. In Sparkle, we started after 30 days, so we did not have this answer clearly. But in practice, it's better to start before discharge.
After a stroke or TIA, how long should the physician prescribe a high-intensity statin like atorvastatin based on Sparkle and treat stroke to target clinical trials?
It's lifelong, for life. There is no reason to think that after 5 years we have to stop the prevention. We need to continue, and we have seen in the total event analysis that the second, third, and fourth and subsequent events are even more prevented by high-intensity statin than placebo, more prevented than the first event. So to me, it's better to continue, because we may have the 6, 7, 8, 10 events after. So it's important to for the patient to understand that the treatment is for life, and that atherosclerotic disease is a silent process most of the time, and that we can interfere with this silent process with statin, and we have shown that in the TST trial. And sometimes it is not silent. This is the event, the second, third, and fourth event, and we want to prevent them also. So it's better to treat for life.
Which is more important, reaching a specific LDL-C goal or the % reduction from baseline?
I would say that the starting point is the AHA recommendation that we should reduce LDL cholesterol from baseline by 50%. But then we have to consider the goal. To me, it's easier to have a goal for practitioners rather than a % reduction. It's easier in practice. So a goal less than 55 milligram per deciliter or 1.4 millimole per liter, as recommended by ESC, is really something practical for high-risk patients, such as patients with a stroke. But what we want, it's almost a 50% reduction from baseline. It's a bit difficult to understand, but to me, the level is more practical.
In your personal experience, are there any differences in treating patients with atorvastatin versus other statins? Does intensity or dose make a difference?
Yes, we have shown in TST that the intensity, the dose, make the difference. Because, of course, to get to less than 70 milligram or 1.8 millimole per liter, you need the high dosage of statin, usually. So it is clear that the intensity of the statin treatment make the difference, and it is implemented in all guidelines. So now, are there differences between atorvastatin and other statins? So if we look at a new generation statin like atorvastatin and rosuvastatin, they are as powerful. For the higher dosage, it's about 55% reduction from baseline in LDL cholesterol. And we may expect that they have the same clinical effect. But the other statins reduce less LDL cholesterol from baseline. So probably the statin make the difference. Higher potent statin therapy with like atorvastatin and rosuvastatin is better than the others, probably. And remember that the lower the LDL, the lower the risk of recurrent stroke and other vascular events in our patients. And then we are left with only one trial that evaluated the effect of statin versus placebo, and this is a SPARKLE trial. In SPARKLE, we use atorvastatin 80 milligram. In the TST trial, we use any statin the investigator wanted to, and the statin which was most used was atorvastatin. But in practice, I think the target level of LDL cholesterol is the way to go.
How quickly can a statin be increased to the maximal dose?
In fact, we have to increase as quick as possible, and we have to consider the starting level of LDL cholesterol. If you have an LDL cholesterol of 160 milligram per deciliter, then you have to give a maximal dose of statin to expect a more than 50% reduction in LDL cholesterol. Of course, if we have an LDL cholesterol of 100 milligram or 110 milligram, that is about 2.6 millimole per deciliter, then you should give a statin with a lower dosage. That was a principle of the concept of the TST trial. We gave 10 or 40 milligram atorvastatin, and we looked at the LDL cholesterol 3 weeks after. And then we titrate, if needed, the dosage of the statin treatment. I think this is the best way to do, titrate the statin. And the patient appreciate that.
In the Treat Stroke to Target study, what % of patients were on statin monotherapy?
About 2/3 of the patients achieving an LDL cholesterol less than 70 milligram per deciliter or 1.8 millimole per liter, 2/3 of these patients were on statin monotherapy. Usually atorvastatin 80 milligram in most of the cases, and in 20% of cases on rosuvastatin 20 milligram. In the other patient, we had to add ezetimibe to go lower and to achieve the goal of less than 70 milligram per deciliter.
What are your criteria for adding a non-statin to lower LDL cholesterol?
It is very simple. Once you are on maximal dosage of statin, that is 80 milligram atorvastatin or 20 milligram rosuvastatin in my country, 40 milligram in the USA, and that the patient is still above 70 milligram per deciliter, then you have to add ezetimibe to reach the target of an LDL cholesterol less than 70 milligram per deciliter, or 1.8 millimole.
Good afternoon, dear doctors. Thank you for joining us this afternoon. And thank you, of course, to Professor Amarenko for the excellent presentation of the Treat Stroke to Target and the Sparkle post hoc analysis, and for addressing some frequently asked questions. Dear doctors, should you have further questions, please click on the question mark icon at the bottom of the screen and submit your questions, and we will address them in a while. At this point, we will be calling on an esteemed cardiologist, to share his reactions to the relevance and as to the relevance and impact of the outcomes from the Sparkle post hoc and TST studies to cardiology practice. He will also be addressing your other questions at the end of the presentation. He is head of the Diagnostic Division of St. Luke's HBC Heart and Vascular Institute, past chair, Council on Hypertension of the Philippine Heart Association, a director at the Philippine Lipid and Atherosclerosis Society, head of the Accreditation Committee of Specialty Board and Accreditation Committee of the Philippine Heart Association. Is a fellow of the Philippine College of Physicians and the Philippine College of Cardiology, and practices at St. Luke's Medical Center, QC and BGC, and at the Cardinal Santos Medical Center. Doctors, let us all welcome Dr. Frederick Cheng.
Yeah, thank you very much, Al, and good afternoon to you, and good afternoon to all those who are attending. And we're fortunate to be able to listen to the presentation of Professor Amarenko, knowing that Professor Amarenko is a leading investigator of a lot of stroke trials. And we know that being a primary investigator, they're the ones who conceptualize and try to recruit these patients, and they do have first-hand experience in the conduct of these trials. And eventually, they will be shaping the recommendations on the different guidelines that are coming out. So my role is basically to give a very brief reaction to the presentation of a professor, and moderate some of the questions that I may be encountering in the chat box. So first and foremost, well, we know that there's a clear relationship between LDL and stroke. So although we know that based initially from the InterHeart study in the prevention of myocardial infarction, the number one risk factor was actually lipids. There was another registry. This time, this is called InterStroke. They also identified lipids as one of the major risk factors, although it was fourth leading risk factor for stroke. The number one was still hypertension, but nevertheless, it's still a top leading risk factor for stroke. And we also learned that whether you're dealing with primary prevention or secondary prevention of stroke, the lowering of LDL will easily result to reduction of stroke events by as much as 12 to about 18%. So there's no debate that we need to lower down LDL levels in patients who have vascular disease, and of course, stroke is a vascular disease. Now, in the presentation of Professor Amarenko, he cited actually two relevant clinical trials. The first one was Sparkle, and the second one was TST. So I'll go to the Sparkle trial first because it's relevant because it's actually the only or the first secondary prevention trial wherein they identified the primary endpoint as stroke. Remember, most of the statin trials actually use cardiovascular endpoints. So this time they used stroke as their primary endpoint. The other highlight of Sparkle study is that these patients do not have any evidences of heart disease. Okay, so that's the unique feature of the Sparkle trial. So in this trial, they actually used atorvastatin 80 milligrams versus placebo. They included more than 4,000 patients. And what they noted is that at the end of about 5 years, there was about 16% reduction of stroke and about 35% reduction of major coronary events. But further analysis showed that there were two groups of patients that would further benefit with high-intensity atorvastatin. Number one, these are patients who have diabetes. There was even doubling in the risk reduction of the endpoints. And the other group of patients who benefited the most are those who were able to achieve an LDL of less than 70. Okay, so again, the overall population, yes, there was already a 16% reduction of stroke, but for those with diabetes and those who had achieved an LDL of less than 70, from 16%, the risk reduction will double to about 30%. Okay. And they also mentioned that there was improvement of renal function, and as far as adverse events, there were no significant adverse events, although they did mention there was a slight increase in hemorrhagic stroke. But apparently, what they noted in those patients who had hemorrhagic stroke are those patients whose blood pressure was not controlled. In those patients whose blood pressure was still elevated, the incidence of hemorrhagic stroke actually increased by 6 times. So I think that's another important message, that we're not just going to be dealing with lipids, but we also have to address the other risk factors. And one of the most predictive risk factor that would lead to events in a stroke patient would be blood pressure. Okay. There was a more recent sub-analysis of the Sparkle trial. No? Yes, we are interested in the first vascular event, but we also wanted to prevent subsequent vascular events. And that sub-analysis of the Sparkle trial showed that if you're able to maintain these patients on high-intensity statin, then you will be able to double the reduction of total vascular events. So again, the importance of making sure that we ask our patients to stay on therapy. Because if you just give it for 6 months, 1 year, you may be able to prevent one vascular event. But if you stop therapy, you will no longer be able to prevent subsequent vascular events. Okay. The other study or trial, which I think was also highlighted by Professor Amarenko, is called TST, Treating Stroke to Target. So actually, the TST is sort of like a follow-up of the Sparkle study. Okay? This time, they wanted to know, should I achieve an LDL of less than 70, or can I target an LDL of less than 100? These are patients, the patients included are actually patients who already had ischemic stroke or TIA, and they were able to follow these patients up to 5 years. No? So the countries involved here are France and Korea. Okay, some of the points that actually triggered my interest in this study is that, interestingly, upon the inclusion of these patients, 50% of these patients were statin naive. That means they were not on any statin therapy. Okay? And probably despite that, meaning to say that they are already at high risk for certain vascular events, but despite that, they are not on optimum therapy. No? So the results actually showed that there was 22% reduction of events. Okay? And actually the divergence of the two lines, no, was actually very evident. No? As early as few months, you already see the benefit of aggressive LDL lowering to less than 70 versus less than 100. Okay? Another important point is that we know that lowering LDL to less than 70 may be a bit of a challenge. No? And that's the reason why they said that to achieve less than 100 milligrams per deciliter of LDL, okay, 92% were on statins. So with statins, it's going to be easy to achieve an LDL of less than 100. Okay, but in order to achieve an LDL of less than 70, okay, they may need additional drugs. Okay, so for example, in that study, 60% were on statins and they needed a non-statin therapy in about 40% to achieve LDL reduction. Okay, and what is also notable in the TST study is that there were no increase in hemorrhagic events. And the other endpoint that we're also very particular, especially with statin therapy, is new onset diabetes, and there were no signals of increase in diabetes. Okay. Now, recently, there was a sub-study of the TCT, and they call it TCT Plus. And I'd like to also point that out because many years back, maybe a decade ago, we were saying that if we're able to give statins, we are able to stabilize the plaque. Because the earlier statin trials actually targeted less than 130, less than 100 milligrams per deciliter of LDL. But since now we do give high-intensity statins, okay, so we are now able to demonstrate regression, not only stabilization of the plaque, but regression of plaques. No? And that was shown in the TCT Plus or TCT plaque ultrasound study. Okay? It showed that if we're able to bring the LDL to less than 70, then the carotid atherosclerosis will cause some form of regression. Okay, so again, that's the added advantage of being able to achieve a lower LDL now. That is regression of atherosclerosis. Okay, so I think these are some of the important points that we were able to learn from the presentation of Professor Amarenko. And probably what I will do is just to continue with my reactions, because I did see that there were a good number of questions in the chat box. So that we will be able to address most of the questions from our audience. Okay, so the first one is in terms of monitoring, let's say, renal function. Okay. I think in the presentation, we noted that it's on the contrary. On the contrary, why? Because statins have been shown also to be renoprotective. Okay? There were reports that there was some proteinuria, but the proteinuria that were noted in the studies were actually tubular and not necessarily glomerular, leading to reduction of GFR. So to answer the question from one of our audiences, is there a need to monitor renal function? The answer is no. Okay. Well, corollary to that, probably some would also ask, is there a need to monitor liver function? Okay. Based on the FDA guidelines, they said that probably we just need to have a baseline liver function test just to make sure that their baseline liver function is okay before you initiate statin therapy. But in terms of regularly monitoring SGOT or even SGPT, it's not mandatory. Okay, but in real world, well, what we do is, since we're going to be repeating the lipid profile, we may also be repeating the sugar, we might as well include the SGPT, but that's not what the guidelines or the FDA recommends. Okay, there's a question in terms of, I think this is addressing the pleiotropic effects of statins. Okay, so the question is, what would be the positive effects in reducing the endpoints and cardiovascular events in patients with stroke? Okay, so the possible answer to that is, well, the first and the main driver of reduction of events, be it cardiovascular or cerebrovascular events, would be LDL reduction. So that's the greatest, I would say, the effect on the positive effect on reducing the endpoints. Okay, but there are also other endpoints which I alluded to earlier already, which is plaque stabilization. Okay, and not only plaque stabilization but also plaque regression. Okay, so again with high intensity statins, and there are other positive effects or what we call pleiotropic effects. No? We know that statins reduce inflammation, statins reduce or improves endothelial function. There are some antithrombotic effects also. There were some reports, although very small, that it also helps lower down blood pressure, and some neuro protective effects such as improvement of nitric oxide levels and improvement of cerebral blood flow. Okay, so those are some of the possible pleiotropic and positive pleiotropic effects with statins as we reduce LDL. Okay, I did mention earlier that we may need some non-statin therapies. No, so the question was, how long should I wait before adding a non-statin LDL if the LDL is not controlled? No, it was not very clear in the guidelines. So in fact, the guidelines would just say, well, you can repeat annually or earlier if needed. So, but in practical terms, in clinical practice, what we do is after 8 to 12 weeks of initiation of a statin, we would already repeat the lipid parameters. And from there, we would already be able to decide, did I give the right statin? Did I give the right dose of statin? And then adjust accordingly based on your targets. And then what are the targets? Well, we were saying that, we need to achieve a 50% reduction of LDL in these high-risk patients. 50%, okay? But it's very difficult to monitor, no? So that's the reason why the guidelines also did give us an absolute number to target. We did say less than 70 for high-risk individuals. For the very high-risk individuals, probably targeted to even lower. Maybe for stroke patients, probably I would target, or MI patients, no? MI and stroke patients, I would target it to less than 55. Okay? So once you have given the highest tolerable intensity of statin, then we maintain these patients. Commonly, we were being asked on how long. Well, we know that this is an atherosclerotic process, right? Atherosclerosis will never stop. As we age, as we acquire certain risk factors, atherosclerosis will continue. So we need to address the atherosclerotic process. Okay, so how long? It's a continuous taking of statins. Okay, the last question I think was already answered, no? So by Professor, that how soon after hospitalization. Okay, so the soonest time for stroke patients, no? So in fact, what the exact statement of Professor Amarenko was before discharge, no? Although interestingly, in the Sparkle study, they initiated it 30 days after. Okay, but if I'm dealing with MI patient, I would already have given high intensity statin right at the emergency room, upon presentation in the emergency room. Okay, so the answer to that is I would give it as early as possible, especially for ACS patient. No, for stroke, maybe you can just wait for a couple of days, make stabilize, and then give it upon discharge, before discharge. Okay, so I think those are very relevant questions raised by our audience. No? Thank you for that. No. Oh, by the way, there was one more. So probably I'll address this last one. So in case of increased transaminases, increase in SGOT, SGPT. First and foremost, the elevation of SGOT, SGPT is not an absolute contraindication unless the baseline is maybe more than 3 to 5 times. And I need to investigate why the SGOT, SGPT is elevated. Okay. Now, then we would see whether there are suggestive of liver dysfunction. Okay, and again, the magic number is 3 to 5 times elevated. Okay, and there's actually a one document just to address all of these issues. When should I reduce the dose? Can I give it 3 times a week? Should I give it even twice a week, and so on, and do some monitoring? Okay. Okay, so I think I did see a good number of questions, and I think we were able to answer those questions. So thank you for typing in your questions. So I think as a summary, I would say that stroke is a vascular disease, right? Just like myocardial infarction, just like peripheral arterial disease. And therefore, one of the most effective proven strategies in order to address atherosclerosis is to bring down LDL. Okay, lower down LDL. Okay, but the general recommendation is to give statins to be prescribed up to the highest tolerable doses. If they're able to tolerate these high dose, then you continue on. Okay, the target. Actually, there's no lower limit already. So the lower, the better. In fact, there are newer trials that are coming in, including PCSK9. They achieve LDL levels less than 30, and there were no signals of increased side effects. no increase in hemorrhagic stroke, no increase in diabetes, no increase in other side effects. And in fact, there was an additive reduction of event rates. So there's no lowering as far as targeting LDL. And based on the Sparkle and PST study, we did show that atorvastatin at 80 milligrams was able to reduce not only the first vascular event, but also the subsequent vascular events. So therefore, once you start statins, okay, make sure that you're able to achieve because we know that it's the lower the better, okay. But we also know that the earlier that we're able to initiate statins, that means they're staying on statin therapy for the longest possible time, and these are the patients who will achieve the greatest benefit. So with that, I'd like to end this very educational SIMPO, and I hope we were able to address all your concerns and your questions. Thank you very much.
Recent research has shown us that non-HDL cholesterol levels have been rising in Asian countries over the past 4 decades. This has been attributed to changes in diet and lower levels of exercise. Despite these changes, statin use remains low in Asian countries. We believe that you are an essential part of changing this. Now more than ever, each time you see a patient, it's an opportunity to make this issue personal, to be the one who truly makes an impact.
Hello, my name is Peter Lansberg, and I'm a lipidologist from the University of Groningen in the Netherlands. I've been told that in Chinese, if you want to write down risk, you need 2 characters. One character is danger, and one character is opportunity. And I really like that proactive approach in dealing with risk. So realize that you can make a difference. Simply follow the guidelines and prescribe high-dose, high-intensity statins in high-risk cardiovascular patients. If not you, who? And remember, opportunity seldom knocks twice. Thank you.
And the difference you make might be bigger than you think. Almost 4 million stroke and IHD deaths in 2017 were attributed to high non-HDL cholesterol. A recent analysis found Lipitor can reduce vascular events by 32%. You have the opportunity to impact your patients' lives by following best prescribing practices. Think about your current prescribing behavior when it comes to statins. When it comes to choosing a statin, Lipitor can help you make a difference with flexible dosing and proven safety in Asian patients. Think about how you prescribe and the impact you can make with each and every patient visit. Use every opportunity you can to be the one who makes an impact.
Ladies and gentlemen, please stand by for the next program session. While waiting, feel free to visit the following areas: the activity booth, where you can take a photo and have the option to download your photos to your device or to have it emailed to your registered account; the exhibit hall, where you will find the different booths of our generous industry partners. Thank you, and see you in the next session. Welcome back, doctors. We now move on to the research paper contest meta-analysis category. Please welcome your session chairman, Dr. Ricardo O. Havison, Fellowship in Adult Cardiology of the Philippine Heart Center, Masters in Business Administration, FEU Institute of Accounts, Business and Finance, Chairman of the Department of Internal Medicine, Metro Antipolo Hospital and Medical Center, Head of the Section of Cardiology, Commonwealth Hospital and Medical Center, and Chief of Medical Professionals at the Skyline Hospital and Medical Center. And Co-Chairman Dr. Walid A. Amil, Director of the Philippine Heart Association, Head of the Zamboanga Peninsula Heart Institute Catheterization Laboratory, Head of Coronary Care Unit, Department of Medicine, Zamboanga City Medical Center, President and Medical Director of the Hospital de Zamboanga, and Founding President of the PHA Zamboanga Peninsula Chapter.
Good afternoon, everyone. May I have the privilege of introducing our three distinguished panel of judges for today's meta-analysis oral presentation. Our first judge is an active consultant of the UST Hospital and De Los Santos Medical Center. She is also the assistant professor of the University of Santo Tomas, Faculty of Medicine and Surgery, Dr. Frances Marie Purino.
Good afternoon, everyone.
Our second judge is an associate professor of the Pamantasan ng Lungsod ng Manila, and he's the current chair of the research committee of the Philippine Heart Association, Dr. Imelda Cayo Leang. Good afternoon, Doctora. And our third judge is our current secretary and board of director of the Philippine Heart Association, and an assistant professor of the Ateneo School of Medicine and Public Health, and is a member of the TMC Institutional Review Board, Dr. Jude Eric Cinco.
Good afternoon, everyone.
Okay. Next slide.
Good afternoon. Thank you, Dr. Emil. Papers for the oral meta-analysis are ranked the top 5 of the 44 papers submitted, and they were reviewed by the PHA members as shown in your screen. Next. The presenters are only given 7 minutes to show their pre-recorded presentation. And take note, we will abruptly stop when it exceeded the allowed grace period. The second portion will be the Q&A. Will be allotted 3 minutes for the question and answer with the judges. And the audience can participate with their questions. However, they can only be entertained once all the judges have asked, and you still have the remaining time for the 3-minute grace period. Next. Here are the criteria for grading the meta-analysis. We have the introduction, the study design and methodology. We have the analysis and results, conclusions, and of course, the oral presentation and the ability to answer the questions. Total of 100%. Next. But wait, there's more. Each of them will be assured of 3,000 pesos. However, the second and third place will receive 12,000 and 9,000 accordingly. The first place will have a prize of 15,000 pesos. Next.
So at this point, we are presenting the sequence of the presentation for our 5 presenters for today's meta-analysis category. The first presenter is Dr. Ruth Agustin. She is from Philippine General Hospital. On the title of the research is The Prognostic Utility of Global Longitudinal Strain in Predictive Outcomes of Patients with Severe Primary Mitral Regurgitation Undergoing Mitral Valve Surgery, a Systemic Review and Meta-Analysis. She'll be followed by Dr. Oliver Rances from the Cardinal Santos Medical Center, Effectiveness of Thiamine Supplementation plus Optimal Medical Therapy as an Adjunct Treatment in Improving Cardiac Function among Patients with Heart Failure with Reduced Ejection Fraction, a Meta-Analysis. The third presenter is Dr. Chris Dianzen Grace Saroca from the St. Luke's Medical Center Global City on her meta-analysis entitled Trimetazidine as Adjunctive Therapy for Decreasing Major Adverse Cardiac Events in Coronary Artery Disease Patients Undergoing Reperfusion Strategy. And our fourth presenter is Dr. Glenn Sayat from St. Luke's Medical QC on his meta-analysis entitled Single Antiplatelet Therapy versus Dual Antiplatelet Therapy after Transcatheter Aortic Valve Replacement, a meta-analysis of our randomized controlled trials. And our last presenter is Dr. Ralph Yap from St. Luke's Medical Global City on his meta-analysis entitled Dual Antiplatelet versus Single Antiplatelet in Post-TAVI-TAVR for Stroke Prevention, a Systemic Review and Meta-Analysis. So let me turn you over to Dr. Ricky Havison.
Thank you, Doc Walid. So We now go to our contest proper. To start, we have Dr. Ruth Divine Agustin of UPPGH.
Good morning. I am Divine Agustin and I'm going to present our study entitled The Prognostic Utility of Global Longitudinal Strain or GLS in Predicting Outcomes of Patients with Severe Primary Mitral Regurgitation Undergoing Mitral Valve Surgery, a Systematic Review and Meta-Analysis. We have no conflicts of interest to disclose. As a review, primary MR results from a pathology of any component of the valve, including the annulus, the chordae, leaflets, or papillary muscles. And surgery is the treatment of choice for chronic severe primary mitral regurgitation among symptomatic patients. Among asymptomatic patients, surgery is recommended if left ventricular ejection fraction is less than or equal to 60% with an LVESD of greater than or equal to 45 millimeters according to the ESC guidelines, or LVE of 30 to 60% and or LVESD of greater than or equal to 40 millimeters according to the ACC-AHA guidelines. In terms of post-operative outcomes, the presence of symptoms, age, atrial fibrillation, preoperative left ventricular function, pulmonary hypertension, and valve repairability are included among the most important predictors. Preoperative myocardial contractility is one of the factors that determine risk of operative death, perioperative heart failure, and postoperative LV function in patients with severe MR. However, it has also been recognized that relying on EF alone as a determinant of LV function in chronic MR is insufficient, and low to normal EF may reflect impaired myocardial function, while moderately reduced EF signifies severe or irreversible myocardial impairment and leads to poor outcomes after mitral valve surgery. Recent studies have shown that GLS adds incremental value to standard measures of LV function such as LVEF, strain, has also been proven to be useful in predicting survival and heart failure development among post-MI patients and in assessing the cardiotoxic effects of cancer chemotherapy. PhD guidelines state that evaluating earlier markers of myocardial dysfunction such as strain imaging are still needed to help define the optimal timing of intervention since LV enlargement and dysfunction occur late in the course of the disease. Several published studies have recently explored the role of myocardial strain in predicting outcomes among patients with severe MR. Hence, our study aimed to determine the prognostic value of GLS in determining the prognosis of patients with severe MR in terms of postoperative mortality and LV dysfunction among patients who are undergoing mitral valve surgery. We performed this study in accordance with the MOOS guidelines in reporting meta-analysis of observational studies. Between June 2018 to July 2019, we conducted a systematic search of these databases with no language restrictions. We used the following search terms: mitral valve insufficiency, mitral regurgitation, and global longitudinal strain, and applied these inclusion criteria. The reference lists of the eligible articles and relevant links were manually reviewed to obtain additional articles, and 3 reviewers individually screened the studies for eligibility and obtained the full text of relevant articles. When only abstracts were available, we tried to contact the authors to obtain the full texts. The validity and quality of each study was assessed using the Newcastle-Ottawa Quality Assessment Scale, and disagreements were resolved by discussion and consensus. We used Revman version 5.3 for analysis. For dichotomous variables, we use odds ratio and hazard ratio at 95% confidence interval presented graphically as forest plots. We did not pull the ORs with HRs. And to account for the use of various cut-off values reported by the different studies, the prognostic performance of GLS-based dichotomization, which is worse GLS and better GLS, was summarized using inverse variance weighted random effects models with 95% confidence intervals. Our database resulted to the identification of 58 studies. We excluded 46 studies which are duplicates or have different study designs, interventions, or outcomes. And a total of 12 cohort studies published between 2011 to 2019, including 2,843 studies, were included in our qualitative synthesis, and 10 studies were included in our quantitative synthesis. For our qualitative synthesis, we reviewed 12 studies, including 7 prospective cohort and 5 retrospective cohort studies. The smallest cohort consisted of 42 patients. The largest cohort consisted of 593 patients. And 8 studies included both symptomatic and asymptomatic patients. Follow-up period varied between immediate post-operative period to 8.3 years, and the mean age of included patients ranged from 44 to 65 years. Mean baseline EF ranging from 57.3 to 67.7%, and baseline GLS ranging from negative 15.65 to negative 22.5%. This table shows our quality assessment of the included studies using the Newcastle-Ottawa Quality Assessment Scale. 11 studies were determined to be of good quality studies, while the study of Song et al. Was determined to be of poor quality due to the reasons specified in this table. In terms of the utility of LVGLS in predicting overall postoperative all-cause mortality, the summary hazards ratio for worse versus better preoperative GLS is 1.22 with an I-square of 95% as shown in figure 2. Publication bias was present based on the funnel plot we generated. There is significant heterogeneity between the included studies, and sensitivity analysis showed that it was the study of Mentias who contributed to heterogeneity. This was likely because their study included patients who underwent or who did not undergo mitral valve surgery. Excluding the study of Mentias, the hazards ratio for all-cause mortality as predicted by preoperative GLS was determined to be 1.11 with an I-square of 41%, as shown in figure 3. In terms of the utility of LVGLS in predicting overall postoperative LV dysfunction, the summary OR is 1.74 with significant heterogeneity, an I-square of 94%.
Okay. Hi, Dr. Ruth. Thank you for your meta-analysis. You were not able to finish your presentation. So maybe the first question to you will be, after doing this meta-analysis, what is your recommendation regarding GLS to a clinician like me? When should I request for it?
Yes, Doc. In terms of our meta-analysis, we had these results wherein there appears to be a prognostic value of GLS in predicting post-operative mortality and post-operative LV dysfunction. According to the guidelines, Doc, I reviewed the 2020 guidelines. They actually included GLS in the guidelines. So it's already class 2B. The level of recommendation is already class 2B. So I think it's clinicians should consider including this testing or this aspect of 2D echo in order to help prognosticate their patients.
But when should you request for it? So, diba, you will be seeing patients who will need mitral valve replacement. What specific ejection fraction, or do you request for it for all patients who are going to undergo mitral valve replacement based on your meta-analysis? And my other question will be, because the range of your GLS was very wide. Diba? It was minus 15 to minus 22, It is actually very wide. So, in which range did you do a sub-analysis on this? In which range of GLS is it associated with the poor post-op results?
Thank you, Doc. In terms of usage in actual practice, I think it would be good to use it on patients who already have severe primary mitral regurgitation, who still have preserved EF, because that's where the question of optimal timing is uncertain as of this time. And then for your second question, Doc, actually, when we examined these included studies, Doc, they did the ROC and AUC analysis, and they determined the median cutoffs for GLS when stratifying worse and better GLS, Doc. And for the included studies, the GLS, the median cutoff was negative 18.1 to negative 22, Doc. So that's the cutoff of the included studies, Doc.
All right. I have one more question for her, after which the others can ask. Okay. You determined that some studies actually of poor quality, right?
Yes, Doc.
Okay. Did you eliminate this from your meta-analysis?
We still included it in our qualitative analysis, Doc, but we were not able to integrate the results into our quantitative analysis, Doc. So it was not included in the computation or calculation of the odds ratio and the hazards ratio.
Okay, thank you.
Thank you, Doc.
I have no more questions.
Have time for
We still have time, so for another question, go ahead, Doctora.
Okay. My question is the reason behind the performance of the meta-analysis. It was not clear in the written report.
Yes, Doc. So as a bit of background, when we do our research and we discuss our patient outcomes, Doc, we look at how we can predict outcomes of these patients who already have severe primary mitral regurgitation. And upon reading of Braunwald and review of literature, actually there's a question of when to optimally intervene for patients who have severe primary mitral regurgitation but who still have preserved EF. Because in chronic...
time is up.
Thank you.
Sorry, the 3 minutes is already done. So thank you, Dr. Agustin.
Thank you.
So we can now have our second presenter, Dr. Oliver Rances from Cardinal Santos Medical Center. So Dr. Rances, you can now proceed once you're ready.
Effectiveness of thiamine supplementation plus optimal medical therapy is an adjunct treatment in improving cardiac function among patients with heart failure with reduced ejection fraction, a meta-analysis. Heart failure is a global pandemic affecting at least 26 million people worldwide and is increasing in prevalence. Despite the significant advances in therapies and prevention, mortality and morbidity are still high and quality of life is still poor. Thiamine is a water-soluble vitamin that is required for macronutrient oxidation as well as for the production of ATP that fuels myocardial contraction. Reductions in ATP production may limit the energy available for myocyte contraction, thereby contributing to myocardial dysfunction and a low cardiac output. However, the role of thiamine in heart failure is not yet well established. Recent studies have been conducted with conflicting results. In a study by Schonenberger in 2005, oral thiamine supplementation increased the EF of patients with heart failure. In a study done by Mosavi in 2017, thiamine supplementation did not show an increase in EF in patients with heart failure. So does thiamine supplementation plus optimal medical therapy help improve cardiac function among patients with heart failure with reduced ejection fraction? Due to the presence of conflicting results, a quantitative analysis is needed to increase the power and provide more precise estimates of the effects of thiamine than those derived from the individual studies included within the review. If proven to have substantial improvement in cardiac function, thiamine may be a cost-effective adjuvant therapy in heart failure, especially in developing countries. Thiamine-deficient heart disease is characterized by sodium and water retention, peripheral vasodilation, and myocardial failure. As a result, thiamine deficiency is presumed to worsen symptoms in the setting of established heart failure. Inhibition of pyruvate dehydrogenase complex is the presumed mechanism by which thiamine deficiency exacerbates heart failure. Inhibition of pyruvate dehydrogenase complex have been postulated to decrease the efficiency of ATP, cellular acidosis, and increased fatty acid levels. The improvements in EF after thiamine replacement has been consistently demonstrated in other studies. The objective of this study is to determine the effects of thiamine supplementation on cardiac function among patients with HFrEF receiving optimal medical therapy versus optimal medical therapy alone, specifically its effects on EF and functional capacity. This meta-analysis includes studies that are randomized, double-blind, placebo-controlled trials in patients with HFrEF. Patients from the experimental group received thiamine as an adjunct to optimal medical treatment. Patients in the control group received placebo plus optimal medical treatment, and the outcome measured was improvement in ejection fraction. The search was performed for literature published up to 2019. The following mesh terms were used, yielding 296 results. 125 results remained after duplicates were removed. 25 studies remained after screening by abstract and excluding non-English animal studies and studies using other macronutrients. And finally, 5 studies remained after records that did not do a randomized placebo-controlled trial were excluded. The outcome measure was combined and analyzed using a random effects model. Mean difference and its corresponding 95% confidence interval were computed. Review Manager version 5.3 was utilized for the analysis. Heterogeneity can be interpreted as a total variation between studies that is attributable to heterogeneity rather than to chance. I-squared was used to assess the degree of heterogeneity wherein more than 50% suggests significant degree of heterogeneity. The study of Shimon used both IV and oral route with 200 milligrams thiamine, which showed an improvement in EF after 49 days of treatment. The study of Schonenberger utilized only the oral form with 300 milligrams dose per day, which showed an improvement in EF and functional capacity after 28 days of treatment. The study of Sophie used a lower dose of oral 100 milligrams per day, which also showed an improvement in EF and functional capacity after 30 days of treatment. The study of Musavi used the same dose as Schonenberger, 300 milligrams via oral route, showed no significant change in EF after 30 days of treatment. And finally, the most recent study by Iqbal in 2019 utilized both the IV and the oral route with 200 milligrams dose, which showed an improvement in EF after 49 days of treatment. The pooled analysis on the effects of thiamine in supplementation among patients with heart failure showed a mean difference of 1.9 with a p-value of 0.04. The I-squared is 40%, which means that the data set is homogeneous. The pooled results showed that the change in EF favors placebo. Other outcomes that were measured in the studies were functional capacity. The studies by Shimon, Musavi, and Iqbal reported an improvement in the NIHA classification. However, no objective measure were used to quantify the outcome. The last 2 studies by Schonenberger and Sophie done in 2001 and 2015 measured functional capacity using the 6-minute walk test. Only the studies by Schonenberger and Sophie were included in the pooled analysis. The pooled analysis on the effect of thiamine supplementation in functional class among patients with heart failure showed mean difference of 21.52 with a p-value of 0.04. The I-squared is 72%, which means that 72% of the variability is due to heterogeneity of studies. The pooled results showed that the change in functional capacity favors placebo. Thiamine intake is less in heart failure patients because early satiety due to splanchnic congestion and cardiac affection. Some dietary thiamine sources may also be high in sodium content and thus are generally avoided by heart failure patients. In addition, heart failure patients have increased thiamine requirements as a result of the chronic diuretic use, which may promote renal wasting. This study is limited by a number of factors. The studies were relatively small scale with a participant averaging only to 25 subjects, and the administration and duration of thiamine was also varied. Based on this limited group of studies, there is insufficient information to suggest that thiamine supplementation has a positive effect on EF in heart failure patients. Large-scale, multicenter, randomized, placebo-controlled clinical trials should be conducted to obtain stronger, statistically significant evidence in the efficacy of thiamine in patients with heart failure. The optimum dose, duration, and the route for thiamine to be effective should also be determined. Thank you.
Congratulations, Dr. Rances, for your presentation. May I, what would explanation why 4 of the 5 studies that you have utilized for the meta uh, reveal that thiamine improve EF. But why is it that when you pull them all together, there was no significant effect?
In this meta-analysis, we were able to include 5 studies with a total of 170 patients to assess the effect of thiamine plus OMT in improving cardiac function. Inspecting the forest plot shows a trend towards placebo. This trend may be attributable to a small sample size of the selected studies, the duration of the studies, and the different dosages of thiamine used in the different studies.
Don't you think, just a follow-up question, why is it that you did not perform sensitivity analysis when you recognize those variables that can affect the result of the study?
A sensitivity analysis was performed, Doc, with no change in the outcome of the pooled analysis. It still included the studies in the entire meta-analysis. Sensitivity analysis and the duration was performed.
Thank you.
We still have time for another question.
Do you want to ask a question, Dr. Ang or Kunwan?
Okay na ako, sir.
Okay. Okay, congratulations, Dr. Rances, for your paper. I enjoyed reading that. Congrats for being in top 5. Just a quick question. Could you explain the methodological rigor that you applied in searching for your studies? Please explain to us the search criteria you used to find the papers. Thank you.
We performed a systematic search for published and unpublished materials up to 2019 using the following database: PubMed, Google Scholar, and Cochrane Library. Using medical subjects, using the search terms heart failure, thiamine supplementation, vitamin B supplementation, HFrEF, reduced ejection fraction, and combination of all these terms. Indexing and text terms were also used, and languages were restricted to English. Gray literature such as books and journal articles, unpublished, completed, and ongoing studies, national and international trials, and as with ongoing trials, formal letters were sent to authors of papers currently ongoing trials.
Thank you. I appreciate your answer. It's just that if you use the more search terms you use and the more general the search terms you will use, the greater the probability that you will prime more trials. So the expression heart failure with reduced EF is relatively new. Some people might call it systolic heart failure. And in fact, this judge performed a search term. My search term was systolic heart failure, thiamine, and vitamin B deficiency or thiamine deficiency. And I found a paper by Dr. Hain published in 2015. And the title of the paper is basically Determining the Role of Thiamine Deficiency in Systolic Heart Failure, a Meta-Analysis and Systematic Review. In this paper, they identified several RCT, something that you could have found if you broaden your search term. Did you find this meta-analysis when you were reviewing, Dr. Rances?
Not sure, I wasn't able to.
Sorry to interrupt. Your 3-minute grace period for Q&A is ready.
Anyway,
over.
Dr.
Thank you,
Rances,
Dr. Rances.
congratulations for your paper. Congratulations.
Thank you, sir.
Good afternoon, fellow colleagues and respected adjudicators of the PHA. Today, I present trimetazidine as adjunctive therapy for decreasing major adverse cardiac events in coronary artery disease patients undergoing reperfusion strategy, a meta-analysis of randomized controlled trials. In coronary artery disease, trimetazidine, an anti-anginal agent that selectively inhibits long-chain 3-ketoacyl-CoA thiolase activity, reduces fatty acid oxidation, and stimulates anaerobic glucose oxidation, improving myocardial energy phosphate levels and increasing myocardial ischemic tolerance, allowing it to be combined with conventional pharmacotherapy for coronary artery disease. previous studies have shown trimetazidine as support in cardioischemic patients, causing decreased hospitalization, improved cardiac function, lowered stable anginal attacks, with improved exercise duration, as well as improved diastolic function, even in patients who underwent PCI. However, conflicting results have been reported on its effect on major adverse cardiac events and cardiac mortality. In 2016, a meta-analysis by Yong Lee et al. Showed a beneficial effect on total MACE in acute MI patients, but with no difference in all-cause mortality, recurrent non-fatal MI, or in-hospital adverse events in patients who underwent thrombolysis and PCI. Despite this, there has been significant reduction of weekly anginal attacks, higher total work, and longer exercise duration in patients with trimetazidine. Thus, the Class 2A recommendation by the ESC in 2019 of trimetazidine as a second-line drug in patients with chronic coronary syndromes whose symptoms are not adequately controlled by existing medicines. However, in contrast to the meta-analysis, the recent large ATPCI study showed no significant difference in pooled cardiovascular outcomes. More data is needed thus in showing the safety of trimetazidine in reducing hard cardiovascular endpoints. Our objective is thus to compare the efficacy of trimetazidine versus placebo for the reduction of cardiac mortality and major adverse cardiac events in patients with coronary artery disease who underwent reperfusion strategies defined as either percutaneous coronary intervention or thrombolysis as studied in randomized clinical trials. Articles were limited to studies involving humans and randomized controlled trials in the last 20 years in the English language with the following mesh or keyword terms. Our study included those, regardless of age or sex, who were given trimetazidine of any administration route with the following primary and secondary outcomes. Our Prisma flow diagram narrowed down the studies to 5 randomized controlled trials that were included in this meta-analysis. Studies that did not meet the previously stated criteria were excluded, as well as duplicate publications. For analysis of data, we used Review Manager version 5.1.7 using fixed effects or random effects accordingly with a 95% confidence interval. And for the studies included, patients were 18 years old and above with documented coronary artery disease undergoing either PCI or thrombolysis with trimetazidine at 20 milligrams to 70 milligrams and the mean duration of intervention from 6 to 47.5 months. For our assessment of quality, random sequence generation was adequate for all studies, and allocation sequence was adequate in 4 studies, while the remaining study by Chen was unclear. Follow-up was also adequate in all studies, as well as intention to treat analysis. Cardiac mortality was reduced in the trimetazidine group, but this was not statistically significant and with no significant heterogeneity. For combined major adverse cardiac events, using the fixed effects model had significant heterogeneity, hence a random effects model was generated, however still with significant heterogeneity, despite the funnel plots done revealing no significant publication bias. So we did a subgroup analysis excluding Shehata, which only treated for less than 1 year, or at least 1 year. However, despite this, the studies became homogeneous, but overall reduction in combined MACE was not statistically significant. Again, there was no difference in repeat revascularization with no significant heterogeneity, and there was a non-significant trend in the reduction of heart failure after perfusion, but in stent restenosis, it was significantly less as compared to placebo. However, the 2 studies were heterogeneous. There was a non-significant trend in the reduction of recurrent angina, and the pooled analysis did not show a significant reduction in infarction. For this, we see that trimetazidine was not associated with a significant reduction in cardiac mortality, revascularization, heart failure, recurrence of angina, and reinfarction as compared to placebo for patients with CAD undergoing reperfusion. Results were similar to the meta-analysis by Lee et al. On cardiovascular mortality, but not on their findings on significantly lowered angina and decreased hospitalization for heart failure. They included patients with acute MI only until 6 months. However, we included trials with longer follow-up in patients who had chronic coronary syndrome with elective PCI, which might have affected the effects of the study. So the ATPCI trial, which is a large event-driven trial, included a well-treated and relatively young population with mostly single-vessel coronary artery disease, both acute and chronic, with following successful PCI. Any potential benefit of trimetazidine might have been attenuated because the study population was already routinely treated with guideline-mediated therapy. And in the MIP-FR group, trimetazidine was given for only 48 hours, not achieving probably the steady state needed to achieve an effect. So both studies had large study populations, giving much power to our pooled analysis. Peculiar is the effect on its stent restenosis to be significantly reduced. Again, trimetazidine has been shown to have an inhibitory effect on vascular smooth muscle cell proliferation and migration, as well as an antioxidant effect, which could explain this phenomenon. But further studies are needed to explore this. So in conclusion, trimetazidine, in addition to optimal medical therapy, does not significantly reduce cardiac mortality, repeat revascularization, heart failure, recurrence of angina, pre-infarction, or total MACE in patients with coronary artery disease post-intervention, but there was an observed significant reduction of stent restenosis with trimetazidine compared to placebo. Further studies may be warranted to study the efficacy of trimetazidine in more vulnerable populations, such as CAD patients who are still symptomatic despite reperfusion, or in those with I-8.
Congratulations on your paper. I enjoyed reading it. Could you just explain to the audience why you include, when you search for revascularization, you did not include coronary artery bypass graft surgery? Thank you.
I think, doctor, it would be better to compare patients who underwent revascularization because they more or less would have more similar outcomes in terms of considering patients who underwent thrombolysis versus PCI versus I think the outcomes for the patients with cabbage would be far off and would be heterogeneous po, doctor. Baka po, it might be less possible to compare the populations po. I mean, in terms of heterogeneity po of the baseline characteristics and
I understand. So in your paper, when you define revascularization, it's not cabbage.
Yes po, doctor. It just included the percutaneous coronary intervention patients and thrombolysis. More of the immediate revascularization strategies po.
Speaking of immediate revascularization strategies, thrombolysis is done in the acute period, while in some of the papers, it was done in the elective period. Is that correct? Could you justify combining the results of papers doing trimetazidine in thrombolysis, which is an acute period, then combining that result with trimetazidine in both emergent PCI and elective PCI, please? Thank you. That's all.
Okay. I think the purpose of the meta-analysis was not only to compare the immediate outcomes of those patients, but also since the studies also included those who had follow-up after they were given trimetazidine on whether, despite the presence of the thrombolysis or PCI at whatever time point they were done, if it would still improve their complaints of recurrence of angina and the other clinical endpoints after a prolonged observation period, given that they were administered trimetazidine on top of the current guideline-mediated therapy. Because I think what the study or the researchers wanted to find out was whether or not the outcomes, clinical outcomes, especially the recurrence of angina and MACE, would be improved by trimetazidine therapy even after those definitive therapies were already given. More of on its effect on the follow-up period for the patients po.
Thank you. No further questions. How about
Thank
the other
you.
judges?
Yeah. We only have 10 seconds. Okay, our time is up. So thank you, Dr. Saroka. And we can now go to our fourth presenter, Dr. Glenn Sayat.
research is all about moving forward and changing the status quo. Today, I urge all of you to be engaged because after today, what you may have known about antithrombosis for post-TAVR patient may change. I have nothing to disclose. Recent technological advances and refinement in transcatheter aortic valve replacement techniques have resulted in improved procedural outcomes. Antithrombotic regimen after successful TAVI is of the utmost importance to prevent ischemic events. Not only ischemic, but also bleeding events in the peri-procedural period and months after TAVI remain a relevant concern to be faced with optimized antithrombotic therapy. This is the summary of recommendations from different scientific bodies regarding anticoagulation after TAVI, none of which has a strong class 1 recommendation for any regimen. According to ACC-AHA, the antiplatelet recommendation is aspirin indefinitely plus clopidogrel for 6 months. For ESC, option between aspirin or clopidogrel indefinitely and aspirin plus clopidogrel early after TAVI. For ACCP, it is recommended that aspirin indefinitely with secondary antiplatelet clopidogrel for shorter duration of 3 months. Because of bleeding risk and related mortality implications, doubts have emerged with respect to the risk and benefit assessment of combination antithrombotic regimens after TAVI. This issue triggered to explore on the recommendation to use single-agent regimen post-TAVI. Different positions from renowned guideline formulating bodies as far as this issue is concerned is observed. Given these diverse position statements, we perform a meta-analysis on this particular topic. Ladies and gentlemen, presenting single antiplatelet therapy versus dual antiplatelet therapy after transcatheter aortic valve replacement, a meta-analysis of randomized controlled trials. Here are the criteria for considering the studies based on the type of study, participants, and interventions. Primary outcome measure in this study is the development of thromboembolic events which were defined in the included trials as stroke and myocardial infarction. Secondary outcome measures include all-cause mortality and major bleeding. Major bleeding was defined as being life-threatening and or requiring blood transfusion, as well as any episode of major internal or external bleeding that causes death, hospitalization, or permanent injury. Here is the summary of our search method. We identified 3 references through electronic searches of PubMed, Cochrane Library, and Medline up to October 2020. The incidence of thromboembolic events, all-cause mortality, and major bleeding in the SAPT and DAPT group were recorded. The odds ratio and the 95% confidence interval were calculated using Review Manager version 5.4. Here is the tabulation of the studies included in this meta-analysis as to the number of participants, intervention, mean age, gender, and follow-up duration. A total of 1,086 patients were included in the final analysis from the 4 randomized controlled trials. For the analysis of stroke events, there were 23 stroke events versus 25 in the DAPT group. However, pooled analysis showed no statistically significant benefit of anticoagulation using DAPT over SAPT in the prevention of stroke with an odds ratio of 0.94. This forest plot in the stroke event showed equal odds between the 2 groups. For the analysis of major MI events, there were 5 MI events that occurred in the SAPT versus 11 in the DAPT group. However, pooled analysis showed no statistically significant benefit of anticoagulation using DAPT over SAPT in the prevention of MI, with an odds ratio of 0.50. This forest plot in MI events showed equal odds between the two groups. For the analysis of all-cause mortality, there is no statistically significant difference in terms of mortality benefit of using DAPT versus SAPT with an odds ratio of 1.01. This forest plot in all-cause mortality events showed equal odds between the two groups. For the analysis of major bleeding events, pooled analysis from the four studies showed higher incidence of major bleeding in the DAPT group versus that of SAPT, which was statistically significant with an odds ratio of 0.44 and p-value of 0.61. This forest plot in all bleeding events favors single antiplatelet therapy. Here are the possible sources of heterogeneity among the studies. Among studies who underwent TAVI, we therefore conclude that SAPT compared to DAPT had similar rates of stroke, myocardial infarction, or all-cause mortality. Moreover, single antiplatelet therapy had lower rates of significant bleeding as compared to DAPT. Due to lower rates of major bleeding, we recommend single antiplatelet therapy over dual antiplatelet therapy after TAVI. Giving excellent preventive treatment has become a priority for all healthcare providers with the overall objective of achieving good quality of care for our patients. We always want to give optimal medical management by giving more medications, more management for our patient. But sometimes we need to pause. So now, I end my presentation by telling you this. Sometimes, doing less is actually more. Thank you.
Okay, Dr. Glenn Sayat, congratulations on your meta-analysis. And tatakbo ka ba? Parang pwede kang maging, anyway. Alright, so I noticed when you did your literature search, you excluded one meta-analysis. You were able to find one meta-analysis, right? Because that's in your methodology. Did you review this meta-analysis?
Yes, Doc. In fact, it is the meta-analysis of Reheja et al. In 2018. And my findings is in parallel to what is concluded by this study.
So why did you, how is your meta-analysis now different from the one that you excluded?
So as I said, we have parallel findings, study of Reheja et al. And this meta-analysis. But the meta-analysis of Reheja is composed of only about 400 patients, while in this meta-analysis, I incorporated the study of the 2020 study, the cohort study of popular TAVI, which is composed of more than 600 patients. So with more subjects or participants in this study, so I was able to give a more concrete evidence of my findings, which is giving single antiplatelet versus.
So what you're trying to tell us is you actually updated the meta-analysis that you saw before, right? You made maybe more patients were now included so that the conclusion will now be more robust compared to the 2018 meta-analysis, right?
Exactly, Doc. Yes, Doc.
Okay. My other question will be, I noticed that in the results of the trials, the confidence intervals were all very wide, diba? Did you see that in your results? Most of them have very wide confidence interval. Will this make a difference in the results of your meta-analysis?
Actually, among the studies, they have differences when it comes to the duration of the treatment, the follow-up, the dosages. So that will cause a difference. But computing the I-squared or the level of heterogeneity, it is 0. So there is a low level of heterogeneity among the studies.
All right. Thank you very much.
We have a few seconds left for maybe one question.
Yes, sir.
If there is none, thank you, Dr. Sayat, for your presentation. We now proceed with the last, or the fifth presenter for today's meta-analysis. We have Dr. Ralph Yap of St. Luke's Medical Center, Global City.
Good afternoon, everyone. I'm here to present a meta-analysis on dual antiplatelet versus single antiplatelet therapy in post-TAVR patients for stroke prevention. I'm Dr. Ralph Yap. I have nothing to disclose. In post-TAVR patients, there is around 1.7 to 4% risk of stroke in the first year of implantation. Antiplatelet therapy in post-TAVR patients are based on expert consensus and limited RCT data. Hence, there is ambiguity in antiplatelet therapy in the prevention of stroke in post-TAVR patients. This study aims to determine the effectiveness of dual antiplatelet therapy versus single antiplatelet therapy in cerebrovascular stroke prevention, and to examine the safety data of dual versus single antiplatelet therapy with regards to major and life-threatening bleeding. For the inclusion and exclusion criteria, only randomized controlled clinical trials were included, and those who have clinical indication of TAVR, and it should be single versus dual antiplatelet therapy. We excluded studies with any indication for anticoagulation. A systematic literature search was conducted through PubMed, Embase, clinicaltrials.gov, Verdin.ph, Cochrane, Medline, and the WHO International Clinical Registry from its inception until November of 2019. And the following search terms were used. Those journals that were randomized controlled clinical trials, published, and those who are in English language, and those who have full text that were available were included. So for the primary outcome, stroke and all-cause mortality at 30 days and at 6 months. For the secondary outcome would be major and life-threatening bleeding. This image shows the study flow diagram. A total of 8 records were identified after the search, and after duplicates were removed, a total of 5 studies remain. 4 records were screened, and 1 was excluded, which was an ongoing clinical trial by Najunis et al. At the time of the search, no partial results were available for review. A total of 3 studies were included in the quantitative meta-analysis. This table shows the description of the included studies. All of the studies were randomized clinical trials. All of the studies are open label, which has its risk of bias. Total population of the 3 studies was 421. The study with the most population is from Rideau Cabal in 2017, with a total of 222 patients. All of the studies had dual versus single antiplatelet. 1 study utilized ticlopidine as an alternative to aspirin. So for the primary outcome, the incidence of stroke in single antiplatelet therapy was higher at 4.7% compared with 1.9% in the dual antiplatelet therapy group. However, the p-value is not significant, with a p-value of 0.12. No significant heterogeneity was observed in all of the 3 studies. For all-cause mortality at 30 days, single antiplatelet therapy is lower at 3.8 compared with 4.7 in the dual antiplatelet therapy. P-value is not significant at 0.64. Again, no significant heterogeneity was observed. For the all-cause mortality at 3 to 6 months, it was lower in the single antiplatelet therapy at 5.7% compared with 6.6% in the dual antiplatelet therapy group. Again, p-value is not significant at 0.70. No significant heterogeneity was observed. For the life-threatening bleeding, it was lower in the single antiplatelet therapy group at 2.8% compared with the 6.1% in the dual antiplatelet therapy group. P-value is not significant at 0.11. For major bleeding, it is lower in the single antiplatelet therapy group at 2.8% compared with 4.2% in the dual antiplatelet therapy group. P-value is not significant again at 0.43. No significant heterogeneity was observed. For the conclusion, no significant difference in the all-cause mortality at 30 days and at 6 months, but there is a trend towards lower all-cause mortality in single antiplatelet therapy group. No significant difference in stroke prevention between the two groups, but there is a trend towards lower incidence of stroke in the dual antiplatelet group. And no significant difference in major and life-threatening bleeding between the two groups. However, there is a lower incidence of major and life-threatening bleeding in the single antiplatelet therapy group. So for the applicability of evidence, all of the studies included had a small sample size. All of the findings were not statistically significant. And based on limited data, dual versus single antiplatelet therapy in post-TAVR patients should be based on bleeding, thrombotic, and embolic risk of the patient. Randomized controlled clinical trials are needed with proper blinding to have a more robust clinical recommendation. Thank you.
Open for questions.
Congratulations, Dr. Yap.
Thank you.
Do you have, did you take note of the mean age of the population included?
As the mean age of the population was 75.
Yes. I asked that because in your inclusion and exclusion criteria, you only said that you included post TAVR patients.
Yes.
How will you exclude patients who have indications for dual antiplatelet therapy? Because these patients are elderly.
Yes.
They, uh, they have comorbidities needing dual antiplatelet therapy.
For this study, if there are any other indications for dual antiplatelet therapy, the dual antiplatelet therapy should be based on that indication only. For example, if the patient had recent ACS, so since dual antiplatelet therapy is indicated, so the patient should be on dual antiplatelet therapy for 1 year. So any other indication for dual antiplatelet should be included.
Okay, so the meta-analysis will not be that beneficial, not significant in doing the meta-analysis because you need the DAPT anyway because of that indication.
Yes.
I think it's important to put a probable exclusion criteria.
Criteria, yes po.
That's all.
We still have time for more questions.
Congratulations, Dr. Yap, on your paper for belonging to the top 5 out of 44. Could you just explain the methodological rigor that you used when you were doing your meta-analysis? Specifically, did you find the meta-analysis of Sidamseti and Mace in 2018? The titles are Meta-analysis comparing single versus dual antiplatelet therapy following catheter transaortic valve implantation when you were doing your review of literature? Thank you.
I was not able to find that study, doctor. In that was 2018. The methodologies done were only randomized controlled clinical trials, and also the I specified a primary outcome, which is stroke and all-cause mortality, and also bleeding.
And then the studies were from PubMed, Embase, clinicaltrials.gov, and herdin.ph. And
I
then,
understand, Dr. Yap.
yes,
Just because if you find a prior existing meta-analysis to your area of interest, if you found it, it's okay to cite it and then say, my meta-analysis is better than these two 2018 meta-analysis because there's another paper that came out. My rigor is better than theirs. So something like that. You can still do an updated meta when there are already published meta. But the question is the rigor by which you did the literature search.
Okay. It's the main reason was I wanted to know whether there's benefit between single versus dual antiplatelet therapy. That was the primary goal, whether which one is better in stroke prevention.
Thank you.
Thank you.
Congratulations.
Thank you, Dr. Yap. Thank you.
Congratulations to all.
Thank you.
So you have heard and seen our presenters for the meta-analysis. Let me turn you over to Dr. Emil.
Yeah, thank you. And congratulations to our top 5 finalists for this meta-analysis oral presentation. Likewise, thank you to our judges for their valuable inputs and questions during the Q&A portion. At this point, on behalf of the Philippine Heart Association, let me present the certificates of appreciation to our distinguished judges. Let me read the certificate. It says the PHA presents the certificate of appreciation to Doctors Francis Marie Corino, Imelda Cayoleang, and Jude Eric Cinco in recognition and acknowledgement of their invaluable contribution as research contest judges in the meta-analysis category in the PHA 51st Annual Convention and Scientific Meeting given this May 26, 2021, signed by Dr. Ronald Cuico, Chair of the Scientific Committee, Dr. Jude Eric Cinco, Overall Chair, and Dr. Orlando Bugarin, President of the Philippine Heart Association. So the scores are now being tallied, but the winners will be announced during the closing ceremony on May 28, 2021. So let me again encourage and remind especially all our presenters to watch and attend the closing ceremony. And likewise to our judges, may we invite you to also attend and listen to our closing ceremonies. That's all. Thank you. Back to you, Dr. Ricky.
Yeah, thank you. And that was an exciting session. And with
Yes.
that, I call the session to end. Thank you very much for joining us and enjoy the rest of the convention. Have a great day, everyone.
Ladies and gentlemen, the time has come to meet the experts with a lecture on Heart Shots CV imaging, presented by Dr. Simonet Christine Sawit Rodrigo, Chair of the PHA Council on Cardiovascular Imaging, Head of Advanced Cardiac Imaging, MRI or CT, Director of the Heart Failure Clinical Care Program of the Medical City, Staff at the Department of Medicine, Division of Cardiology, Makati Medical Center, Fellow of the Philippine College of Physicians and the Philippine College of Cardiology. For this session, our panelists are Dr. Edward Benji L. Magsombol, Head, Section of Nuclear Cardiology, St. Luke's Medical Center Heart Institute, Quezon City and Bonifacio Global City, Past Chair of the PHA Council on Cardiovascular Imaging, Consultant, Extracorporeal Shockwave Myocardial Revascularization or ESMR, Head of the Homobono B. Calleja Heart and Vascular Institute, St. Luke's Medical Center, Quezon City, Diplomat of the American Society of Nuclear Cardiology, Fellow of the Philippine College of Physicians and the Philippine College of Cardiology, Dr. Oliver D. Alix, Adult Clinical and Nuclear Cardiology, Multimodality Non-Invasive CV Imaging at St. Luke's Medical Center, Global City, and the University of Perpetual Help Delta Medical Center, Faculty, Department of Internal Medicine, College of Medicine of San Beda College. Member of the PHA Council on PHA-CV Imaging. Dr. Christian Michael H. Pawai, Fellowship in Adult Cardiology and Nuclear Cardiology at St. Luke's Medical Center, Quezon City. Fellowship in Cardiac CT and Cardiac MRI, Saitama Cardiovascular and Respiratory Center, Japan. Affiliated with St. Luke's Medical Center, the National Kidney and Transplant Institute, and VRP Medical Center. Fellow of the Philippine College of Physicians and the Philippine College of Cardiology. This session is moderated by Chairman Dr. Juan Dionisio Marcelino L. Foronda, completed Adult Cardiology Fellowship at Makati Medical Center, trained in Nuclear Cardiology as a visiting scholar at the University of California, San Francisco, USA, active consultant at the Makati Medical Center and Asian Hospital and Medical Center, member of the PHA Council on Cardiac Imaging, Fellow of the Philippine College of Physicians, the Philippine College of Cardiology, the Philippine Society of Echocardiography, and the Philippine Society of Nuclear Medicine. With co-chairman Dr. Maria Helga F. Santa Maria. Completed Clinical Research Fellowship in Echocardiography at the Heart Institute of St. Luke's Medical Center. Completed fellowship training in cardiac MRI and cardiac CT at the Washington Hospital Center, Georgetown University Affiliated Hospital in Washington, D.C., USA. Head of the cardiac MRI and CT at the Heart Institute of St. Luke's Medical Center, Global City. Head of the cardiac imaging of the Heart and Vascular Institute, University of Perpetual Help and Medical Center, Las Piñas City. Member of the PHA Council on Cardiovascular Imaging. We would like to inform everyone that questions will be entertained when the lecture has been delivered. Kindly use the chat box to convey your questions for the speaker. Thank you.
Good day, everyone, and thank you to the PHA for allowing the Council Cardiovascular sharing their knowledge and experience through this Meet the Experts session. Each case presented will be followed by a panel discussion. We encourage the audience to type in your questions. So let's begin with case number 1. This is a 31-year-old male admitted for chest pain. He has no known comorbidities, an unremarkable family history, and he's a non-smoker. He actually bikes to and from work. His BMI, blood pressure, heart rate, and oxygen levels are as follows. The rest of his PE is unremarkable. His 12-lead ECG shows sinus bradycardia. His troponin levels were normal, and the 2D echo was unremarkable. So the first question is, which imaging modality will you do next? A coronary CT angiography, conventional coronary angiography, a cardiac MRI, or a myocardial perfusion imaging? Coronary CT angiography was done. Curved MPR of the LAD, the LCX, and the RCA are all shown here, all of which appear patent. Eggshell view of the heart from superior to inferior shows the following. You can see here, let's wait for it. So you can see here that the origin of the RCA is anomalous. These images show the origin and the course of the RCA pointed in blue. The RCA takes off with an acute angle, approximately 0.31 cm above the left sinotubular junction. It has a shared ostia with the left coronary artery, and it courses between the aorta and the pulmonary artery. The patient is now symptom-free. What will be your next step in terms of management? Would you refer to the TCVS for surgical correction? Would you refer to interventional cardiology for percutaneous coronary intervention? Will you evaluate the patient for myocardial ischemia? Or no need for further workup? The patient actually refused any intervention. He opted for discharge and workup for myocardial ischemia as outpatient. However, during dobutamine thallium MPI, The patient had chest pain, prompting termination of the study. He subsequently underwent coronary angiography, and the findings were consistent with the coronary CT angiography. The question now is, what will be your next step for this patient? A treadmill exercise stress thallium MPI was done. The patient exercised for 12 minutes and 58 seconds. Baseline blood pressure was 120 over 80. BP at peak exercise was 180 over 100. His resting heart rate was 78 beats per minute, and the heart rate at peak exercise was 160 beats per minute. Post stress and rest SPECT images of the LV showed homogeneous uptake in all its segments. Gated SPECT imaging post stress showed good wall motion and adequate systolic wall thickening. Post stress global LV ejection fraction was normal, calculated at more than 70%. The attending physician then referred the patient for cardiac MRI to evaluate for myocardial fibrosis. As you can see in the image on the left, there was normal biventricular size and systolic function. And you can see in the image on the right, which is a four-chamber post-contrast late gadolinium enhancement imaging, there is no evidence of LGE or myocardial fibrosis. Again, on these views, there is no evidence of myocardial LGE or fibrosis. Updates for this patient: no surgical correction was done. The patient remains symptom free. He is able to resume biking to and from work and currently has no maintenance medications. Let us now proceed with the panel discussion. And I invite you to ask questions. You can type this in the chat box. All right, let's proceed with case number 2. This is a 32-year-old male who presents to the emergency room with what started as left shoulder pain for 2 days prior to admission and now has anterior chest pain waking him up from sleep. He has no other symptoms. He has no known comorbidities, an unremarkable family history, and he is a non-smoker. Blood pressure and heart rate are as follows. The rest of the physical exam is unremarkable. 12-lead ECG showed a regular sinus rhythm with non-specific ST abnormality. The high sensitivity troponin I was elevated at 7,695. A point of care ultrasound was done at the emergency room, which showed mild global hypokinesia. SARS-CoV-2 RT-PCR nasopharyngeal swab was done, and this result was negative. This is the patient's ECG. Okay, so what would you do next? A coronary CT angiography, a coronary angiography, a cardiac MRI, or medical therapy only? So a coronary angiography was performed, which showed no significant disease in the LAD, no significant disease in the LCX, no significant disease in the left main artery, as well as no significant disease in the RCA. All right, so what would you do next? Medical therapy only, a 2D echocardiography with global longitudinal strain, or a cardiac MRI? So a cardiac MRI was performed 4 days later, showing normal biventricular size and systolic function. LV ejection fraction was at 54%. On post-contrast imaging, there is diffuse late gadolinium enhancement, or what we call LGE, in a subepicardial pattern, pointed out in yellow, involving the basal and mid-anterolateral segments, as well as the apical lateral segments. LGE represents the presence of myocardial fibrosis. There was also diffuse subepicardial LGE, pointed in yellow, involving the basal, mid, and apical anterior segments, as well as the basal, mid, and apical inferior segments. There was also diffuse subepicardial LGE in the basal and mid inferolateral segments, as well as the apical lateral segment pointed in yellow. Pointed in orange is a mid-wall pattern of LGE involving the basal anterior septum. Post-contrast LGE imaging in the short axis view at the base, mid, and apical views is consistent with the presence, location, and pattern of LGE that were shown in the previous slides. The yellow arrows point to the diffuse subepicardial LGE, and the orange arrow points to the mid-wall LGE. On T2 weighted imaging, or what we call edema sequence, there is increased signal intensity in the basal anterolateral, mid anterolateral, mid inferolateral, and apicolateral segments, suggestive of myocardial edema or inflammation. Findings of myocardial edema and myocardial LGE in a subepicardial or mid-wall pattern, and these are non-ischemic patterns, are suggestive of acute myocarditis. The CMR findings prompted further testing for COVID-19, which showed reactive total and IgG antibodies. The patient was eventually discharged improved with a diagnosis of acute myocarditis, likely from COVID-19. All right, so now let's discuss the case. All right, let's proceed with case 3. Okay, this is a 56-year-old female with atypical chest pain. She's hypertensive with a strong family history of premature CAD and an ex-smoker. Vital signs are as follows, and PE was unremarkable. Her 12-lead ECG was regular sinus rhythm and considered septal infarct, age undetermined. So the question is, what would you do next? Coronary CT angiography, coronary angiography, myocardial perfusion imaging, or a stress cardiac MRI. The patient underwent a MEBI treadmill MPI, which showed normal LV wall thickness, normal LV cavity at rest without transient ischemic dilatation at stress. TID index was 0.78. There was a small, mild, partially reversible defect in the apical to mid-ventricular anterior wall. The remaining LV segments had no evidence of myocardial perfusion defects. By gated SPECT imaging, post-stress global LV ejection fraction was normal, calculated at 71%. LV systolic wall motion and thickening were normal in all of the visualized LV segments. So what would you do next? Cardiac MRI, a CT coronary artery calcium score, a coronary CT angiography, or a coronary angiography. So CT coronary artery calcium score was done, which showed calcifications in the left anterior descending artery and a score of 113. CT angiography showed the following. On the left panel is a 3D volume rendered reconstruction of the heart and the coronary arteries. Pointed in yellow is a calcified plaque followed by narrowing of the mid-LAD after the second diagonal artery. The center panel shows a curved multiplanar reconstruction of the LAD. The lesion in the mid-LAD is seen in a longitudinal axis represented by the yellow line, as well as in a lumen view represented by the yellow box. You can appreciate the calcified plaques followed by a soft or non-calcified plaque. The image on the right is a short axis view, mid-ventricular level, showing a lumen view of the same lesion. This lesion is a low attenuation plaque measuring 23 Hounsfield unit that also exhibits positive remodeling, both of which are considered high-risk plaque features, causing 50 to 70% stenosis of the mid-LAD after the second diagonal artery. The LCX and the RCA had no significant disease. A coronary angiography was done and showed a sequential 40 to 50% and a 60 to 70% mid-segment stenosis of the LAD. An IVUS was done. Unfortunately, I do not have the images, but this showed focal areas of eccentric plaques, eccentric mixed plaques at the lesion area with a minimal luminal area of 3.9 millimeters square and a distance reference area of 8.0 millimeters square. Successful IVUS guided PCI of the LAD was done, and the patient improved with relief of symptoms. All right, let's now proceed with a panel discussion for this particular case number 3. Okay, let's proceed with case number 4. This is a 60-year-old male with progressive dyspnea on exertion and some chest discomfort. He has hypertension. He has a history of a myocardial infarction in 2017. A prior stress test was positive for exercise-induced myocardial ischemia, as evidenced by anterolateral and inferior wall ST depression. A recent 2D echo showed a dilated LV with global hypokinesia and an LV ejection fraction of 26%. So what will you do next for this patient? A coronary CT angiography, a coronary angiography, a cardiac MRI, or a myocardial perfusion imaging. A rest or redistribution thallium myocardial perfusion imaging was done, and this showed a large area of inhomogeneous uptake in the mid to apical anterior septum, apical lateral wall, and basal to apical inferior wall, with note of absent apical uptake in the apical cap at rest, and improvement in the said walls in the redistribution images, except for the apical cap and the apical septal wall, which remained the same. The left ventricle is dilated with dyskinesia of the inferior and inferoseptal segments, while the rest of the segments were hypokinetic. The lung-heart ratio is 1.4. A coronary angiography was subsequently performed, and this are the images, the LAO caudal view, the RAO caudal view, the RAO cranial view, the LAO cranial view, the LAO straight view, the LAO cranial view. So the question now is, what is your recommendation for this patient? Revascularization via cabbage was recommended. However, the patient opted for medical management only. So now let's discuss the case.
Thank you, Dr. Simonet Christine Sawit Rodrigo, Dr. Edward Benji L. Magsumbol, Dr. Oliver D. Alex, and Dr. Christian Michael H. Pawai. Doctors, the floor is now open for your questions. For those who have not sent in their questions, please do so now using the chat box. Our speakers and moderators will now field the questions already sent. Thank you.
Are we on?
Good afternoon.
JD.
Good afternoon, everyone. Welcome to our hot chat sessions. We have 4 interesting cases, and the objectives of this session is to highlight the different imaging modalities in investigating different clinical situations, the appropriateness of using such techniques, and we'll be discussing each case. For the first case, as a recap, we are presented with a young male presenting with chest pain, who's obese, mildly hypertensive, but with good functional capacity, whose initial workup with an ECG, echo, and troponin were normal. So, as the first question posed, would we have done the same and requested for a coronary CT angiogram right away? Or would we have done at the minimum an exercise stress test with or without imaging? Can we ask our panelists? Dr. Magsumbol, would you?
Sige, thank you, JD. Normally, I would do a treadmill test on this patient kasi young lang siya, and at the same time, he has a very good functional that's a problem pala dito with this patient kasi if you do a treadmill, you know that he has a very good functional capacity and he has no chest pain even when biking to work at 40 kilometers per day. So chances are treadmill would be negative anyway, especially symptom-wise. So maybe a cardiac imaging modality would be better for this case to delineate the chest pain if it's cardiac or not.
Thank you, Doctor. Now, this patient had a coronary CT angiogram, and it was lucky that we were able to identify anomalous origins of the coronary arteries, and as well as we were able to identify a malignant course, and this, of course, will matter in terms of management. Can we ask Dr. Sawi to point out again the images that were pertinent to these findings and to comment on the risks of finding such in an individual?
Sure. So JD and to the audience, so here you can see a 3D reconstruction of the heart. And as you can see, this is the right coronary artery pointed in blue, and this is the left coronary artery, and they share an ostium. In fact, for this particular case, the origin of the coronary artery, there's this shared ostium here, is above the left sinotubular junction rather than the left coronary cusp. And when we're looking at coronary, anomalous coronaries, you want to look at where they're originating from. So this is an RCA origin originating from the opposite sinus of Valsalva. And you also want to see the course of the anomalous coronary artery. For example, here, so there's a shared ostia between the right coronary artery and the left coronary artery, and you can see here pointed in yellow that the course of the coronary artery passes between the aorta and the pulmonary artery, and you can this is an interarterial course or malignant course, because of course when the person exercises, these two great vessels, they squeeze the proximal segment of the RCA. And in this third image over here, you can see that the takeoff is there's a little bit of an acute angle takeoff of the right coronary artery, the proximal segment. So it's a little bit, there's like a tapering over here, So these are the things that we look for. We look for high-risk features of anomalous coronary arteries, The origin, we look for acute takeoff. We also look for a slit-like ostium. When we say slit-like ostium, it means that the configuration of the ostium rather than a circle becomes slit-like or like a slit. We don't see that in this particular patient. We also look for the course of the coronary artery, whether it's it's passing between the great vessels. We also want to see, more importantly, if this proximal segment of the anomalous coronary artery is intramural or going within the wall of the aorta, which it is not in this case. So these are the things that we look for. So these are high risk features. So the more high risk features of our anomalous coronary arteries, the higher the chance of sudden cardiac death. So these are the things that we look for on coronary CTA, and this can help in the management of the patients moving forward if they need revascularization because of their risk for sudden cardiac death. But not all of them present as sudden cardiac death.
Right. So, Simonette, the invasive coronary angiogram was done, and this is a better technique in terms of identifying intramural cores, right?
Well, not necessarily. It really depends on there are different types of anomalous origins kasi. So for this one, this is above the left sinotubular junction. The others, they come from the coronary cusp. And then there are others also that have their own ostium separate from the other coronary. This one has a shared ostia with the left coronary artery. So it's a little bit above lang the sinotubular junction. It would be very difficult to see an intramural course of the coronary artery on our conventional angiogram. Coronary CT angiography will still be the better choice in order to see that. And you can see here on the angiogram, you can see already the origin. You can see the shared ostia. You can see the ostium of the left coronary artery, and you can see the ostium also of the right coronary artery. And the proximal segment is not tapered. A tapering would suggest acute takeoff or even compression during exercise. But again, coronary CT angiography would still be the better choice to look for intramural cores and interarterial cores.
Okay, so also the perfusion scan was done in this patient, and considering the age bracket of our patient, he is potentially at risk of sudden cardiac death if he goes back to his athletic work, right? And how good is a perfusion scan in actually determining myocardial ischemia in this population? Any of the guys, so they're experts in myocardial perfusion imaging, can answer.
Alex? Oh, okay, I'll take it. Myocardial perfusion imaging is really primarily for the diagnosis of myocardial ischemia. The sensitivity goes as high as 92 to 94%, depending on the stress that you're going to use. So for this particular case, they did a treadmill exercise test. So I'm assuming there's no replication of the chest pain during the entire procedure, right? So no replication of the chest pain during the entire procedure. That's a low risk feature, right? Taking a look at the scan. So since it's thallium, of course, some image quality will suffer, right? But taking a look at the stress images, that's the one on top, compared to the redistribution images, the one at the bottom, we see that the post-stress images are relatively more homogeneous, right? They are brighter when compared to the redistribution images at the bottom. And so if I'm going to take a look at this, here we have the polar map on the right. So it's relatively homogeneous, very nice images. And taking a look at the volume, it's acceptable, 116, 120, and with good ejection fraction, post-stress and at rest with 72 and 71%. So overall, this is it will be signed out as a normal perfusion imaging. And in terms of overall cardiovascular risk, this will still be considered as a low risk individual.
But then we have to correlate with the findings on the CT angiogram on why we have a normal perfusion imaging despite the findings on the CT angiogram.
Okay, so Simonette mentioned about eliminating the high-risk features, which are acute angulation of the origin, a slit-like ostrum, which was also not found, right, Simonette? And
Right.
then we also did not identify an intramural course, which was bolstered by the invasive coronary angiogram as well as absence of potentially small vessel diseases. No? And we also, but there is that interarterial course, which did not seem to be significant as far as the myocardial perfusion imaging is concerned. So a cardiac MRI was also done in this case. Sometimes there can be vasospasm in the interarterial course, and we were perhaps looking for any chance of LGE in this case, Simonette, whether it is ischemic in origin or non-ischemic in origin. And what did we find in the cardiac MRI?
So there was no evidence of myocardial fibrosis or scarring.
Right.
Here we go. So the four-chamber view shows over here no bright areas in the myocardium that would suggest the presence of LGE or myocardial scarring or fibrosis. So this is the four-chamber view, the two-chamber view, and the three-chamber view.
Okay, so it means that this patient, we are projecting a 99% survival rate over the next 5 years.
Benign course.
Yeah, benign course because of the absence of LGE. And to be clear, this patient go back to exercise as an athlete. I give the floor to the chair.
Oh, can I add one more thing? So, one important aspect of the stress testing for this patient is the type of stressor that they use during the nuclear scan. Because for patients with malignant course of these anomalous coronary arteries, it is important to do exercise stress as opposed to a pharmacologic stress, which will not yield the same effect in terms of determining ischemia.
Mm-hmm. And that also adds to giving prognosis to our patient that he's all right to do an extraordinary kind of work. No?
Yes.
Okay. I think it's a very good case.
Thank you, Doctor. So I guess the take-home message for this case is coronary CT coronary angiogram is a good diagnostic tool in identifying congenital abnormalities in the coronary arteries, particularly in this case, an anomalous origin of the right coronary. And just to point out, the features of a malignant course would be an interarterial course, meaning the coronary artery courses between the pulmonary artery and the aorta. And supplementary testing like nuclear stress test and cardiac MR add additional input into prognosis, especially in this young individual who aims to be athletic. Thank you. Now for the second case, we're going to discuss. To recap again, we are presented with another young male presenting with the typical chest pain, but this time with diffuse non-specific STT wave changes on the EKG and markedly elevated troponin levels. As posed by the first question in the slides, a coronary angiogram was done with the intent of doing coronary revascularization, just in case there was a stenosis seen, which was not seen in the patient. Cardiac MRI was performed afterwards. Maybe hear a comment from the panelists, and especially from our co-chair, as to the appropriateness criteria for these situations.
I'll take it, JD. So I think that this patient, a young patient, presenting with very high troponin, signals acute myocardial injury, and which is not due to the presence of a significant epicardial coronary artery stenosis. And so we don't know the diagnosis. This is potentially a myocardial infarction in non-obstructive coronary arteries. And so the diagnosis has to be established, number one. Number two, we need to be able to guide therapy in identifying the cause of the acute myocardial injury. And third is prognosticate. And I think because of the very powerful capability of cardiac MRI to tissue characterize, that a cardiac MRI is an appropriate imaging technique in this case. First, to identify the cause of MINOCA, to see whether the extent, if there's an injury, what is the extent of the injury? And so we're looking for presence of LGE in more than two segments, and that will signal that this patient is at a higher risk compared to just one segment. And if the EF also absolute quantification of volumes and function, I think is very important. And then the location of the LG is also quite important when we are trying to identify patients with inflammation or myocarditis. And the presence of this LGE in the interventricular septum is a signal that this patient is at a higher risk, contrast to if we find it in the lateral wall or other segments.
Thank you, Dr. Helga. Dr. Sawi, can you just point out for the audience again where we found the late gadolinium enhancements, which is in this case in a COVID patient, which is I guess an ever evolving disease. So,
Okay, so this patient, before proceeding with the coronary angiography, had a negative RT-PCR for COVID. So they proceeded with that. And since that was negative, and then they proceeded with the angiogram that was negative also. And so the cardiac MRI was done to rule out other causes of myocardial injury, including myocarditis. Of course, when the cardiac MRI was done, we did not know that this patient has or had a prior infection with COVID. And so the things that we look for in myocarditis would be mid-wall scarring, mid-wall fibrosis, or mid-wall LGE. As you can see in the basal anterior septum, we have some mid-wall scarring over here. But more impressive would be the presence of diffuse subepicardial LGE or enhancement in the base, mid, and apical lateral walls, as well as the diffuse subepicardial enhancement in the base, mid, and apical inferior and inferolateral segments. So these are atypical findings in myocarditis. And when I saw these images, I pushed for additional COVID testing, and that's the reason why this patient had, aside from that, there was evidence of myocardial edema, which tells you that there is evidence of some myocardial inflammation. So we pushed for further assessment. We did the antibodies for COVID, and we do not have the IgM antibodies, but he was reactive for total and IgG antibodies for COVID. So there's a prior infection here. And whether it's a recent infection, we don't know that. But this presentation, this patient is a young guy with no comorbidities, comes in with acute chest pain, and he does not have any symptoms that he can recall that would suggest the presence of COVID.
So, Simonette, can we go back to the LGE picture? Prior to COVID, when you see LGE in the interventricular septum, these are usually patients with rather lower EF, right? Because of the prediction that it is due to human herpes simplex virus affectation, right? Or a combined human herpes simplex virus and parvovirus. But now with COVID, you see that there is that LGE in the interventricular septum and the lateral wall also. But the motion seems to be all right, except when it is somewhat the florid type of LGE, which you can see in very bad myocarditis that we see prior to COVID, or in the first few CMRI in COVID, no, yun parang lahat puti, which is a bit scary.
Fulminant myocarditis.
Yeah, fulminant myocarditis. Yeah. So this imaging technique, if we are just to satisfy the Lake-Lewis criteria in predicting adverse cardiac events, this image actually satisfied presence of LGE in the anterior interventricular septum and more than 2 segments, which is more than 10% of the LV mass. Those are predictors of adverse cardiac events later on in non-COVID myocarditis. We will see. We don't know yet what happens to COVID. We don't have predictors of adverse events in COVID and for how long this LGEs actually stay in the myocardium. In your experience, how long does it stay? I've had 8 months. It's still there.
7 months for me.
Okay,
7 months.
so compass it out. 7 months, 8 months. Maybe later we can still follow up our patients and we'll just continue to report on what we see in COVID.
Yeah, so it's been 4 months since this guy was admitted, and he's actually doing well. He's doing well, asymptomatic.
Right.
Thank you, Dr. Sawit and Dr. Santamaria. So I guess the take-home message for this case is cardiac MRI is a very useful tool in tissue characterization, especially in demonstrating late gadolinium enhancements and tissue edema using T2-weighted sequences, which can be used to diagnose and as well as prognosticate long-term complications in COVID patients. So as the case demonstrates, myocardial injury can occur in COVID patients regardless of severity, as you may say, and may require long-term follow-up. Now, for the third case, we're presented now with a middle-aged hypertensive male, previous smoker.
Female, sorry.
Female. Previous smoker and with a strong family history of coronary artery disease, comes in for atypical chest pain. She has at least an intermediate pretest probability for CAD, and a myocardial perfusion imaging would be appropriate at this point. May we ask Dr. Magsumbol, Alex, and Paway to comment on the MPI findings? There's a small reversible defect. Would you agree?
The myocardial perfusion imaging here shows a small defect in the anterior wall. So you can see that in the anterior wall there, and it's mostly reversible. So that shows a small inducible myocardial ischemia. It seems relatively mild. So it's a small, mild inducible myocardial ischemia in the anterior wall. The polar map didn't even show it. Just a darker shade there in the anterior wall. The black shade in the inferoseptal wall is not significant. So it's not part of the information that we need. So only in the anterior wall, small, mild.
Sir, with the small reversible defect, would you have gone straight for a coronary angiogram instead of proceeding with the CT coronary angiogram as in this case?
For most cases, small mild inducible ischemia with a clinically stable patient, not persistent chest pain, and controlled with medical management. We will usually just stay with medical management. That's what the guidelines say.
But she presented with persistent chest pain, no, or recurrent chest pain.
But is the question I'd like to ask there is the patient already on maximum or optimal medical therapy? So if not, based on the CCS guidelines, you would want to maximize it first, the anti-anginal medications. But if the patient's already maximized and still symptomatic, then we go for invasive coronary angio with the intent to revascularize them.
This patient was lucky to undergo a CT coronary angiogram, and we invite Dr. Sawit to share again her slides and comment on the features of the plaques of the vulnerable.
Sure.
So this is the patient's choice, no, to do a CT angio instead of going straight to coronary angiogram. I think we needed to emphasize that she didn't want to have to go straight to coronary angiogram despite the recommendations.
Correct. That's correct. So I think the choice of the patient we have to consider when we tell them the options of like, do we do a conventional angiogram or CT coronary angiogram? And her decision was to proceed with a CT coronary angiogram. So here you see this is a calcium score, and anything that's but of course, a positive calcium score is not good, especially if the calcium score is above 100. So the higher the calcium score, the higher the chance of getting obstructive coronary artery disease are in their evaluation. The rest of the coronaries did not have any calcifications. See, so okay, so if you can see here, no, I'll go straight to the meat. This is the left coronary artery, LAD, and you see diagonal, first diagonal, second diagonal. You see this calcified plaque over here that probably represents the calcium score that you see over the calcified plaque that you see here. And after that, all of a sudden there's a tapering after the calcium score. And you can see that there's this dark area over here. And if you notice, if you measure the vessel diameter proximally and the vessel diameter at the lesion, no, you would get, this is what we call positive remodeling. So basically the diameter here, the ratio between the diameter proximally and at the lesion, a positive remodeling index of more than 1.1, no, is that, so that is evidence of high-risk feature of positive remodeling. And more importantly is that this area over here is very, very dark. It tells you that it's a very soft plaque. And these very soft plaques or very dark plaques have a tendency to rupture and cause ACS. No? And if you measure the Hounsfield unit from that soft plaque, low attenuation plaques are measure less than 30 Hounsfield units. So this patient has, although the degree of stenosis is only 58%, so moderate lesion at this mid-LAD, the patient has the presence of positive remodeling as well as low attenuation plaque. So high-risk features despite the moderate stenosis of the mid-LAD. And of course here, the CIRC and the RCA had no significant disease.
Dr. Sawit, is it possible to identify vulnerable plaques by just a plain coronary artery calcium score? Because some people, just for prognosticating, they just have a calcium score without proceeding with the CT angiogram. Is it possible to identify with just with the images from a calcium score?
Yes, unfortunately, the hard plaques or the calcified plaques are seen on calcium scoring. However, the high-risk plaques, the ones that are soft, the ones with low attenuation, are not detected on the calcium score. You would need the contrast enhancement or proceed with CT angiography.
But JD, you can use the calcium score as to decide whether you can actually proceed with the coronary CT angiogram to reap the maximum benefits, to optimize the benefits of a coronary CT angiogram. And so if you see that there's so much calcification, it will decrease the specificity of the scan and you better go straight to a coronary angiogram.
Correct. That's a good point.
JD, another thing that I could add for the CT angiogram is if you have a high calcium score, and then usually it's more than 400, a study has shown one way to approach it also is to see if there's a ischemic burden there. So a high calcium score would warrant now, especially if it's above 400, investigation for possible ischemia. If there's no ischemia, then patient can go ahead with just medical management. If the ischemia is significant, especially in the high plaque areas, then that's the time that we can go for invasive management.
It's also used to augment the pretest probability to arrive at the clinical likelihood, whether intermediate, low, or high clinical likelihood for CAD.
Yes, and may I just add that in the other things that we look for would be myocardial scarring or fibrosis on a CT scan. And that would, because when you have a myocardial infarction, eventually the myocardium develops fatty tissue, and that would appear as dark areas in the subendocardial areas of the myocardium. I don't have all the images here, but you can see in the short axis view in the mid-ventricle, you don't see any dark area suggestive of subendocardial infarct. No, so maybe whatever was seen on the previous perfusion imaging study, very, very small, but we did not see that on the CT scan.
What makes I'd like to highlight also that what makes this a high risk plaque, the soft plaque, is really not the severity of stenosis, right? But it's
Correct.
the nature of it is to rupture easily, and that makes it high risk. And studies have shown also that patients put on high dose statins in these cases will help the plaque to become more stable.
Right.
It's a very good point.
Very
Are there any questions from the floor?
Comments from Dr. Ollie or Chris?
Jernan, this case was very interesting and very useful in the concept of the unstable plaque. So the take-home message is CT coronary angiogram is a very useful tool in identifying the vulnerable plaque that goes beyond the utility of a plain coronary calcium score. It help identify and determine which segments will require revascularization and PCI, especially in lesions where it would be labeled otherwise as intermediate in degree of stenosis. So again, the take-home message, in one segment, 100 and above is considered high risk, 400 for the entire calcium score. And for the vulnerable plaque, as pointed out by Dr. Sawit, positive remodeling, Hounsfield units of less than 30, which would constitute a very soft plaque. And I guess that's it. Now, for the fourth and final case, we have a 60-year-old male, hypertensive with a previous myocardial infarction, who presents with dyspnea and chest discomfort with a previously positive stress test and low EF. Now, he underwent a resting thallium scan with a 4 and 24-hour redistribution. Anyone in the panel would have requested for a stress, myocardial perfusion imaging, pharmacologic one perhaps. Any inputs from the panel? Dr. Paway?
Chris?
Oli or Chris?
If you want to, if the purpose of the test is just to look for viability, a resting scan or a rest distribution or fusion scan would suffice. If there's still doubt that the cause of the cardiomyopathy or the decreased ejection fraction or systolic function of that patient is ischemic or not, then you can proceed to a stress perfusion scan. So I think in this case, it is already established that the patient has coronary artery disease. So, and the purpose of the test is to determine whether or not the viability of the myocardium is sufficient to warrant revascularization. So, for this patient, the rest of the distribution scan is enough.
Thank you, Doctor.
Although let me add that in my practice for doing stress thallium in cases like this where it's obvious that it's ischemic cardiomyopathy, if the patient can tolerate a stress, any form of stress, whether it's pharmacologic, it also gives you the baseline ischemia burden, and that will help you in the follow-up of these patients after you do revascularization. So the information that you can get when you introduce stress, like a pharmacologic stress in this case, probably the patient cannot do a treadmill test because of the low EF. A pharmacologic test will give you a ischemia burden baseline, and that will help you in the follow-up. Aside from the hibernating myocardium, it will help you in the viable myocardium. So it will help you in the follow-up of these patients later after revascularization.
Makes you want to consider regadenoson, right? Although it's still not available.
But it really depends on if the patient can tolerate the stress procedure. If the patient is unstable, easily congested, then I agree with Chris that we should just do a resting viability study in order to help the patient, to guide the surgeon on where to revascularize.
In terms of technique, the patient had a 24-hour redistribution scan. Would it be, say, it should be standard, or 4-hour redistribution should be sufficient in assessing viability?
It depends on the patient's ability to tolerate the stress. if the patient can tolerate the stress in my practice, I will still do a stress, even if it's just a pharmacologic stress. But if the patient cannot, then just do the resting viability.
Uh, Dr. Chris, would you mind pointing out to the audience which segments would we actually be invisible and hibernating from the thallium images and perhaps the thallium scan? And would we be able to like get the percentage of viable myocardium from the mapping? And would it matter in terms of deciding if we should send the patient through a revascularization procedure or not?
Okay, for this case, this was signed out as having an evidence of a moderate or a 12% area of hibernating or viable myocardium. Just for the information of the other cardiologists who may be watching, hibernating myocardium is assessed by redistribution of the perfusion defect that is seen at the 4th and the 24th hour delayed rest scan. So it showed here that there is hibernating myocardium in the mid to apical, anteroseptal, and the apical lateral wall and the basal to apical inferior wall. So that means there is some redistribution noted on these areas during the 4th and the 24th hour delayed rest scan. Now, those areas or the LV segments that did not show any redistribution in the 24-hour delayed rest scan is deemed infarcted or scar tissue already, and that's just a small percentage, about 5% in this scan. So mostly the infarcted area is in the apical cap and the apical septal wall. So about 12% of the LV myocardium is hibernating in this case, and about 5% infarct. The rest of the LV segments, as can be seen, are also viable, those with perfusion on the scan. And literature has shown that about 20% functional viability is still warrant or it has benefit in revascularization in terms of cardiomyopathy. So for this case, I think we are able to establish the higher percentage of viability for the entire LV that can have some benefit in revascularization.
Dr. Alex, would you care to comment on
Sure.
the appropriateness of attempting revascularization also?
Okay, so prior to revascularization, the amount of viable myocardium is very important to know reversibility of the reversibility of the hibernating myocardium. At the same time, it also correlates with survival. So other than myocardial hibernation, which is the live myocardium, the amount of scar is also important. There have been studies showing that if you have a scar that's more than 20% of the entire LV, and then you revascularize, then you can reverse the ischemic burden, and yet you may not reverse the LV remodeling because it will still persist because of the very large scar. Other issues, if we're going to take a look at the ejection fraction for this particular patient, I think it's very low, severe, right? And so probably the concept that comes to mind would be myocardial reserve, right? And so I was thinking of, since they did already a 24-hour delay, why not do a low dose dobutamine at the 24 hours? Then there are studies showing such procedures coming out of Singapore and coming out of the South American institutes. They do low dose dobutamine in a 24-hour scan to show if there's improvement in left ventricular ejection fraction and a wall thickening, which gives them a better gauge on improvement
in overall function after revascularization.
All right, well said. So it was a great discussion. Thank you for the cases, Simonette, and to the panels. Mr. Chair,
Thank you, our co-chair and commentator, Dr. Helga. Thank you for your very valuable inputs. So we will now end the session by presenting certificates of appreciations to Dr. Simonette Sawit, Dr. Helga Santa Maria, Dr. Edward Benji Magsambol, Dr. Oliver Alex, and Dr. Christian Power for in recognition and acknowledgement for their invaluable contributions as presenters and panelists in the PHA 51st Annual Convention and Scientific Meeting given this day, the 26th of May 2020, signed by Dr. Ronald Puico, Chair of the Scientific Committee, Dr. Jude Eric Cinco, Overall Chair, and Dr. Orlando Bugarin, President of the PHA. Thank you and congratulations to everyone.
thank you.
Thank you.
Thank you.
Thanks,
Thank you.
everyone.
Stay safe, guys.
Stay safe.
Thank you, doctors, for your questions. Thank you, Dr. Simonette Christine Sawit Rodrigo, Dr. Edward Benji L. Magsombol, Dr. Oliver D. Alex, Dr. Christian Michael H. Pawai, Chairman Dr. Juan Dionisio L. Foronda, and Co-Chairman Dr. Maria Helga F. Santa Maria. We now move on to snippets from our partner Servier with a lecture on patient-tailored treatment of chronic coronary syndrome in and out of hospital setting, presented by Dr. John C. Añanuevo, Professor and Chairman of the Department of Medicine of UPPGH, past Chief of the Division of Cardiovascular Medicine of UPPGH, past Chairman of the Departmental and Medical Center. The lecture is moderated by Chairman Dr. Eugenio B. Reyes, Chief of the Division of Cardiovascular Medicine of UPPGH, Associate Professor of Medicine, UP College of Medicine, Philippine General Hospital, Scientific Advisory Board Member of APSC, past Zone 2 Vice President of the Asian Pacific Society of Cardiology, past Governor of American College of Cardiology Chapter Philippines, and past President of the Philippine Heart Association.
This scientific session is brought to you by Servier Philippines. The title of the session is Patient-Tailored Treatment of Chronic Coronary Syndrome in and Out of Hospital Setting. It is an honor to have as our speaker, Dr. John C. Añanuevo. He is an interventional cardiologist, a professor in UP College of Medicine, and the chairman of the Department of Medicine in UPPGH. He is also the former chief of section of cardiology, Department of Medicine, UPPGH. Let us welcome Dr. John C. Añanuevo.
I will talk to you about one of the most common yet challenging syndromes that we see as cardiologists and internists, both in and out of the hospital. These are my disclosures, and this is the outline of my talk. As cardiologists and as internists, we see the multiple phases of angina in our clinics. Angina that is triggered by exercise at a predictable threshold and relieved by nitrates is very suggestive of an epicardial coronary artery narrowing. We also see some forms of angina that is triggered by exercise at variable thresholds and sometimes at rest also, but poorly responsive to nitrates, especially in women, and this is usually associated with microvascular angina. And lastly, we see angina that occurs at rest, relief of nitrates, and it's likely due to coronary vasospasm. Today, however, the current pathophysiology of ischemic heart disease and angina is almost always related to obstructive coronary artery disease. And having said that, management is always directed to revascularization in the form of either angioplasty or coronary artery bypass surgery. Evidence, however, has shown already that angina, ischemic heart disease, can occur in the absence of obstructive epicardial coronary artery disease. And this is exactly the reason why a multifactorial origin of ischemic heart disease is already the new paradigm. Ischemic heart disease or angina can occur in patients with microvascular dysfunction, endothelial impairment, those patients with vasospasm, or even intramyocardial bridging. Of course, the most common cause of ischemic heart disease and angina would still be your narrowing of your epicardial coronary arteries. So now we have already accepted the idea that angina, though is a single clinical entity, has multiple etiologies that requires a very comprehensive approach. It can involve the large coronary vessels, as we see when we refer patients for coronary angiography. You can have a flow-limiting stenosis, you can have vasospasm or intramyocardial bridging, but we also know that microvascular disease is a common cause of angina. Things like microembolization and also endothelial dysfunction as well as inflammation. But one of the player that we probably have not identified before that can cause angina is the role of myocardial cell in the development of ischemic heart disease and angina. Impaired energy metabolism, defective cellular oxygen transport, mitochondrial dysfunction, as well as the production of the reactive oxygen species, are problems that are related to myocardial cells that can cause ischemic heart disease and angina. And probably the multifactorial origin of ischemic heart disease would explain the findings from so many years ago up to now that revascularization, PCI, or CABG has really no prognostic impact in stable chronic ischemic patients. And you can see here the list of trials that did not show any benefit in terms of mortality or prevention of myocardial infarction. Although it's a fact also that revascularization, specifically angioplasty and intracoronary stenting, has been associated with a transient improvement in terms of reduction of angina, leading to improvement of quality of life in most of the trials. However, this is short-lived, and we know that at the onset of 3 years, going into 4 and 5 years post-PCI, most of these patients will now complain of recurrent angina. Just to show you some major studies that have been done to compare the role of optimal medical therapy and revascularization, PCI plus OMT, in terms of hard endpoints. If you remember back in 2004, that's almost close to 17 years ago, where the COURAGE trial documented non-superiority of PCI plus optimal medical therapy compared to optimal medical therapy. And they followed up majority of these patients, and even an extended follow-up study cohort of this initial population of the COURAGE trial documented no difference in terms of the probability of survival in those patients who were given optimal medical therapy plus PCI compared to optimal medical therapy alone. And in the most recent trial, which is the ischemia trial, as you can see here, this is again about 5,000 patients with moderate to severe ischemia. Also documented no difference in terms of those patients who were randomized to early invasive strategy versus those who were in the conservative group. And another trial that compared PCI versus optimal medical therapy. This is the Orbita trial, which is a multi-center randomized trial of patients, smaller number of patients. These are patients with severe 70% single vessel stenosis. They were optimized first to medical therapy before being randomized to PCI versus placebo. This is like having a sham procedure. And again, with triple conventional treatment, those patients who actually had the PCI, 50% of them remained symptomatic in 6 to 12 weeks of follow-up. Those findings will also be related to a study that was done in about 5,000 post-MI patients from 31 US hospitals. And though angina was quite common baseline in those patients who have obstructive compared to non-obstructive coronary artery disease, you can see here that the incidence of angina actually is so much higher in those patients who had non-obstructive CAD compared to the patients who had obstructive CAD. Another problem that we see in the management of our patients with chronic coronary syndrome is that most of our patients are undermanaged. And the problem with that is what we call the physician's inertia. This is a registry from 25 US sites with patients having frequent angina, which is defined as a daily or weekly angina. And you can see that close to 50% of these patients who are having frequent angina, daily, weekly angina, are on suboptimal therapy. 5.2% with no anti-anginal medications at all, and 38.5% with a single drug. And another issue that we look at the possibility of treatment gaps in the management of CCS is non-adherence. And this is the RICH registry, probably one of the biggest, if not the biggest registry on patients with atherosclerosis. You can see that in Asia, close to 70% of our patients with significant atherosclerotic cardiovascular disease had non-adherence to their cardiovascular medications. So let me review then the most recent 2019 guidelines on the diagnosis and management of CCS. And you can see now that from 2013 guidelines to 2019, you can see the change in terms of the terminology that is associated in patients with chronic ischemic heart disease and stable angina. From the stable coronary artery disease, now it has become a syndrome. So there's an acknowledgement of the multifactorial origin of ischemic heart disease from disease to a syndrome. And in that guideline also, optimal medical treatment was defined as a treatment that satisfactorily controls symptoms and prevents cardiac events associated with chronic coronary syndrome with maximal patient adherence and minimal adverse events. But you have to remember that that should be based on the patient's characteristics and preferences. Also, in the guidelines, there's already a recommendation for using initial therapy consisting of 1 or 2 anginal drugs as necessary, plus, of course, the drugs that we use for secondary prevention of cardiovascular disease. The guidelines, 2019 CCS guidelines, fostered a patient-tailored approach through early combination of first and second line anti-anginal drugs. And this is one slide that I think all of us should know in terms of how we manage our patients with chronic coronary syndrome. You have your disease-modifying therapy, your aspirin, your statins, your RAS blockers, beta blockers, specifically post-MI patients, as well as, of course, your drugs that are responsible for lowering your cholesterol, and of course the new drugs for diabetes that have been found to reduce major adverse cardiovascular events. But on the other part of this slide are the medications that we use for symptomatic treatment for angina. And it's still classified as first line, as second line in the guidelines, first line being beta blockers, calcium channel blockers, as well as nitrates, and second line, trimetazidine, ranolazine, ibarbadine, and nicorandil. But there's a major argument already, major discussion about using the terminology of first and second line, because the study that was done by Ferrari, wherein a systematic review covering 50 years of medical treatment, wherein they look at all the randomized controlled trials comparing anti-anginals for stable angina, there's really a paucity of big RCTs that prove superiority of this first line of drugs that we use for angina versus the second line. And there's actually no evidence to support the use of first and second line treatments for the management of angina, but rather, as I have mentioned earlier, the medical therapy of angina should be personalized and tailored towards the individual with understanding of the likely pathophysiological mechanism and comorbidities. The stepwise algorithm that was presented in the article of CCS guidelines speak of a patient-oriented algorithm. And I think this is for the first time they classified the anginal patients in terms of those having high heart rate, low heart rate, low blood pressure, and LV dysfunction. But as you can see, this is still based on hemodynamics. No? You talk about heart rate and blood pressure. And you can use now a combination of beta blockers plus ivabradine in patients with high heart rate. And in those patients with low blood pressure, second step already is actually the use of these drugs, ranolazine, ivabradine, and of course, trimetazidine. But you have to remember that this proposed stepwise approach should always be adapted to each patient. And as again, I have discussed earlier, given the limited evidence for various combination in different clinical scenarios, the proposed options, as you can see in this algorithm, actually may not represent a formal recommendation. But what is important, I guess, in this new guidelines is that the combination of a beta blocker and a calcium channel blocker now with what was termed a second-line drug may now be considered as first-line therapy according to the heart rate, the blood pressure, and the tolerance of our patients with angina. This is just to review the 2019 guidelines in comparison to the 2013. And what is new here is that, as I have mentioned, the combination of beta blocker with calcium channel blocker is already considered as a first-line treatment. And of course, the upgrade of ivabradine and trimetazidine for second-line treatment from 2B, it is now a 2A recommendation in terms of its usage for patients with angina. So let's go now specifically and discuss the role of trimetazidine and ivabradine in our patients with angina. So for me, I always discuss the biochemical, pathophysiological aspects of why metabolic drugs are important in the management of ischemic heart disease and patients with angina. The overview of myocardial energy substrate utilization start with discussing the source of our myocardial energy. And basically, we have two major sources, the fatty acids and the glucose. These two substrates are oxidized to acetyl-CoA, and eventually the chemical energy from these substrates are transformed into mechanical energy, which is your ATP. And ATP is needed for your myocardial contraction. It is important to remember that a preferential increase of activity in the glucose or the fatty acid oxidation can result in imbalances in substrate uptake as well as utilization of the mitochondria. Now, in a normal cell, in a normal myocardial cell, in a patient who probably has no problem with ischemia, whose oxygen supply is not a problem, there's no issue about which pathway is important. But in patients with sustained periods of ischemia, especially those with severe ischemia, what happens is that paradoxically, there is an increase in fatty acid oxidation. And because of the increase in the fatty acid oxidation, there is more acetyl coenzyme A, and because of that, there is inhibition of glucose oxidation. And because of the inhibition of glucose oxidation to acetyl-CoA, most of these are now converted to lactate, and there is increase in the hydrogen ions, there's acidosis, there is increased intracellular calcium and sodium, and this acidosis is actually responsible for the production of the reactive oxygen species that can lead to alterations in the morphology, structural, and functional parts of your myocardium. And metabolic modulation with optimization of the energy is quite important in these patients who have problems with oxygen supply. And I'm saying that because if you look at the difference between glucose oxidation and beta oxidation, though glucose oxidation provides a smaller amount or source of energy, it is a more oxygen efficient pathway compared to beta oxidation that consumes more oxygen in the production of ATP. And as you can see here, this is increase in glucose oxidation, and there's reduction of fatty acid oxidation with the use of trimetazidine. Trimetazidine, because of its action on the 3-ketoacyl thiolase enzyme, which is the enzyme that is used in the beta oxidation, leading to the oxidation of your fatty acid, is inhibited by trimetazidine, making a preferential shift to glucose oxidation and reduction of your fatty oxidation, producing more ATP, leading to less consumption of oxygen and making the myocardium more efficient. And that's basically how trimetazidine acts. It acts by acting on the core of ischemia, bypassing the potential hemodynamic mechanisms that your beta blockers, your calcium channel blockers, and nitrates act on. These are some of the major I would say, studies that documented the benefit of using trimetazidine. This is a large-scale, multi-center, 6 months, open-label observational study on close to 900 patients with stable angina. They were on baseline beta blockers plus calcium channel blockers, baseline beta blockers plus nitrates, and the combination of the 3 drugs. And they were given trimetazidine for 2 weeks. And you can see the significant reduction of angina after 2 weeks of trimetazidine, regardless of the background therapy. Furthermore, these patients also had an improvement of exercise capacity as early as 2 weeks of treatment. And also, the effects were sustained. You can see here that there is a significant improvement in 2 weeks, and it improved much more. And at the end of 6 months, 82% of patients from baseline has reduction of angina already. The study Ethalon was done to look at the difference in terms of the effects of a generic trimetazidine versus the innovator trimetazidine. Patients who had angina, who were unresponsive, who remained symptomatic with a generic trimetazidine, were shifted to the innovator trimetazidine, which is of course your Vastorel. And after a few weeks of follow-up, there was a reduction of the number of angina attacks per week, as well as the number of nitroglycerin tablets that were consumed per week. And it was also a study on pharmacoeconomics, and you can see here that based on the Ethalon study, the trimetazidine preparation Vastorel MR is the most cost-effective trimetazidine versus the generics, as you can see here. Now, let's go to the second part of the management of patients with chronic coronary syndrome. We've talked about metabolic modulation, and now we're looking at the role of heart rate as a risk factor in patients with CCS. You can see here in the beautiful study, those patients who were given placebo, they have a higher incidence of cardiovascular death, a higher incidence of hospitalization for heart failure, for myocardial infarction, and revascularization. Ibabradine is a special drug. It acts selectively in the IF current in the sinus node. It actually reduces the diastolic depolarization phase, causing a heart rate reduction. And you can see here the significant effects on the baseline, on the heart rate after the usage of ibabradine in those patients with variable heart rates. Not only does ibabradine able to effectively decrease the heart rate, but also a lot of laboratory studies documented improvement of myocardial perfusion, either by, of course, the prolongation of your diastolic perfusion time by 41%, by improvement of your coronary flow reserve, and also improvement of your collateral function. And I'm sure you're familiar with one of the biggest trials on ivabradine. This is the Beautiful trial. I'm just sharing with you the pre-specified sub-study in terms of those patients who had stable angina on maximal therapy already, whose heart rate remains at 70 beats per minute, more than 70 beats per minute. The use of ivabradine on top of the guideline directed medical therapy for these patients with heart rate of more than 70 beats per minute, stable CAD, led to a less hospitalization for fatal and non-fatal MI, as well as less risk for revascularization. And this will actually be one of the reasons why in the current CCS guidelines, the recommendation now is to bring down your heart rate to as low as 55 to 60 beats per minute. Early combination of ivabradine and beta blocker also led to a lower anginal events, and this is compared to up titrating your beta blockers. And you can see here, compared to up titration of beta blockers, the combination of beta blockers with ivabradine led to a higher proportion of patients without angina. But only not the efficacy is improved by combining two drugs rather than up titrating the beta blockers. We're all familiar, we're all aware as cardiologists and again internists that beta blockers have quite a number of side effects. We're talking about hypotension, fatigue, dyspnea, and bradycardia. And you can see here that there is a significant reduction when you combine early on beta blocker with ivabradine rather than up titrating your beta blockers. And in a meta-analysis of 5 RCTs using various doses rather of ivabradine from 5, 7.5, and 10, there is a consistent anti-anginal efficacy in various groups of patients with angina, patients who have diabetes, previous bypass surgery, previous angioplasty, and those patients who had previous MI. And ivabradine is actually included in the recommendation of the 2020 American Heart Association guidelines in patients with diabetes. Let me just share with you a study that compared the fixed dose combination. Now we're talking about two drugs, the beta blocker and ivabradine in one formulation, compared to the free combination, which is ivabradine plus metoprolol. This is the treatment of stable angina with the new fixed dose combination of ivabradine and metoprolol. And again, the combination of the two drugs in one pill, the fixed dose combination, led to a 6 times fewer number of patients suffering from angina attacks with a heart rate reduction of 10 beats per minute. Also, there is a significant improvement in physical activity from patients. There's reduction now of patients who are classified as CCS3 from 19% down to 5%, and an increase in the number of those patients who have CCS1, wherein ordinary physical activity does not cause angina, in those patients who were given the fixed dose combination of ivabradine and metoprolol. And the most important explanation for those findings is actually, again, going back to the major issue of adherence. The less number of drugs a patient take, the better the adherence, and eventually leading to better efficacy for our patients who are taking a lot of drugs. And if you combine them, I'm sure they will be able to take their drugs better. So there is a better adherence in those patients who were, again, given the combination as a fixed dose tablet compared to the free combination. So in summary, I've talked to you about ischemic heart disease as being a multifactorial disease. It can be related to a lot of pathophysiological entities, could be secondary to epicardial CAD, it can be secondary to microvascular dysfunction or vasospasm, or most recently, the idea of problems in the myocardial cell, specifically mitochondrial dysfunction. A patient-tailored approach to treat coronary syndrome is very important. You have to look at the patient in totality, their comorbidities. As I have mentioned, their presumed pathophysiology causing the angina is very important to identify. The originator, innovator, trimetazidine, offers a great advantage as an anti-anginal agent right from the start of patients having angina and ischemia. And ivabradine is a very effective therapy It specifically lowers the heart rate, but in addition to that, it improves myocardial perfusion that will lead to less angina, improvement of quality of life, less hospitalization due to myocardial infarction, and less risk for revascularization to our patients with CCS. And lastly, emerging evidence that early combination of your ibabradine with beta blocker is an effective, safe, and it is a better option in many patients compared to just up titrating your beta blockers. Thank you very much.
Thank you, Dr. Año for an enlightening presentation. Now, we would like to introduce our esteemed moderator, Dr. Eugenio B. Reyes. He is the Chief of the Division of Cardiovascular Medicine, Department of Medicine of the UP Philippine General Hospital, and he is an Associate Professor of the Department of Medicine of the University of the Philippines College of Medicine. Dr. Reyes is the head of the Heart Care Services of the Manila Doctors Hospital, and he is a Scientific Advisory Board member of the Asia Pacific Society of Cardiology. Dr. Reyes is the past president of the Philippine Heart Association. Let us welcome our moderator, Dr. Eugenio B. Reyes.
Thank you very much, Dr. John Anunuevo, for that great and terrific lecture. I really learned a lot, and hopefully the listeners learned a lot as well. We have a couple of minutes for discussion and perhaps entertain question. But before that, I'm pretty sure there are a lot of audience in the audience who may not be a cardiologist, and maybe you can a little bit expound on chronic coronary syndrome instead of using stable ischemic heart disease, because in all of the clinical trials that you have presented, you mentioned it's stable ischemic heart disease or stable CAD. Perhaps you can clarify now what is chronic coronary syndrome so that some of the audience may be able to digest them.
Okay, so the chronic coronary syndrome terminology was actually came out in the most recent ESC guidelines 2019. And I think there were some reasons why they did so. And I guess the major reasons were, one, if you look at the course of a patient with coronary disease, coronary artery disease, there are episodes where patients become stable, and there are episodes where patients becomes unstable. So in order to, I guess I will use the word synchronize the term of acute coronary syndromes and chronic coronary syndromes, they decided to shift the terminology. Remember, it used to be stable coronary artery disease, stable ischemic heart disease, and then finally chronic coronary syndrome. Just to pick patients who are out of the acute stage of their disease and have stabilized a little. But remember, any of these patients who are in the chronic coronary syndrome path may eventually have episodes of ACS. And the other major reason, I think, is that the multiple or multifactorial causes of ischemia that can cause chronic coronary syndromes have been identified. As I have said, this used to be stable coronary artery disease, and then eventually stable ischemic heart disease and CCS. And the fact that there are other causes of ischemia other than coronary artery involvement per se, the epicardial coronary artery, then the terminology CCS have included a lot of other disease entities that is out of the usual syndrome of epicardial coronary artery disease. So I think those are the two major reasons.
Right, that's good. Nice to know that. But has chronic coronary syndrome, is the term adopted internationally right now? I mean,
Yeah.
are you using it right now in the Philippines for the CD classification?
Yes,
Or not yet?
yes, I am using it in my notes already. In my referrals, I use the word chronic coronary syndrome and have shied away from using already stable ischemic heart disease or even stable coronary artery disease. And I think that's very important that although globally, I think, and you can probably share your opinion also, globally, I don't think this is still at this point in time being followed. As I have mentioned, this was coined by European Society of Cardiology.
Right.
But personally, I do. I've
Yeah.
started
Yeah.
and even have discussed this very well with residents and fellows.
Yeah, the only problem with that is that there's another CCS, Canadian, what's this? Canadian Cardiac Society, right? And there's a classification for angina CCS 1, 2, 3, and 4. And I think that's one. There's a question in the chat box. And I think this is a question to you. Would you recommend the use of, well, specifically Vasteral MR that's before and after PCI?
Okay. Great question. Let's tackle first the pre-PCI. Okay. Again, these are based on not RCTs, okay, but there have been quite a number of studies that have used the troponin as a marker of what we call acute reperfusion injury. There was a study that documented reduction of the increase in the levels of troponin post PCI in those patients who were given trimetazidine a few hours or right before PCI. And the troponin level was used as a marker of reperfusion injury. And I think that's one of the possible mechanisms of the reduction of cardiovascular events post PCI. Now, also, there have been actually two meta-analyses done by our cardiology fellows and residents about the value of using trimetazidine to reduce contrast-induced nephropathy in those patients undergoing PCI. And both were positive in favor of the use of trimetazidine compared to placebo. Yes.
Dr. John, do you practice it? I mean, do you give trimetazidine before PCI and then continue it after?
I have given, I would not say I give it for all, but I have given patients post pre-PCI with trimetazidine. And of course, as I have said, we don't have RCTs to prove that, but the measure of troponin levels was a measure of reduced reperfusion injury related to PCI.
Right. For the audience, we are shifting from one topic to another, but this is all about angina, and there are many anti-anginal drugs in the market. There's a question here. Based on the data or from registries, it showed that the beta blockers are not being utilized or optimized. Would there be any advantage if you combine ivabradine with beta blocker early instead of up titrating it?
Yes, I think that's the last part of my lecture, where early combination of ivabradine with a beta blocker led to a reduction of anginal attacks and reduction of the number of use of nitrates in patients with chronic coronary syndrome. The reason for that is, of course, Well, especially, no, especially if you use the fixed dose, no, let me just put it in there because before I forget, the use of fixed dose combination, which is deemed to be early because you combine ivabradine and beta blocker very on, metoprolol, for instance, is that you improve compliance of the patient. We are already aware, all studies have documented the lesser number of tablets you ask the patient to take, the better the compliance, and compliance has been equated to efficacy. Second is the reduction of adverse events. The major reason why we cannot up-titrate beta blockers, and I'm sure everyone here has experienced the adverse events related to increasing doses of beta blockers. Your blood pressure might go down, even non-hemodynamic parameters like fatigue, depression. I have had patients who had depression with beta blockers. So you might be able to decrease the incidence of those adverse events if you combine it very early on with a drug that might achieve the same goal of reduction of heart rate.
Yeah, that's good. Um, uh, it's clear. Before we proceed, I'd like to greet Dr. Joel Abanilla. He's in the audience right now. There's another question here, which is kind of interesting. What are the benefits of, well, they keep on using the word visceral MR among heart failure patients. But before you answer that, you showed a study on the innovator versus generic. What is it in the innovator that makes it superior over the generic?
That's the Etalon study that documented. This is a small study. I mean, there were 112 patients who were on the generic trimetazidine, remained symptomatic, and when they were shifted to the innovator drug, they had, again, the endpoints were not hard endpoints, but there was significant reduction in the number of anginal attacks and significant number of nitrates. I will not be able to offer you a definite
answer.
I wish you can help me with that.
I'm still wondering.
But one of the things that probably might be beneficial to our audience is the cost and efficacy ratio of that study. Really documented that the usage of the innovator drug led to a better cost efficacy ratio.
Maybe it's the formulation, or
most probably it would.
Most probably.
Yeah.
So there's a question here. What about for heart failure? What are the benefits of trimetazidine in patients with heart failure?
Okay, again, great question. If you look at the most recent recommendation in heart failure, I'll start with that. If your patient has significant angina, diagnosed to have heart failure, I'm talking about HFrEF, okay? Actually, trimetazidine has already been part of the guidelines. Although it's a class 2B recommendation in heart failure, patients who persist to have angina, trimetazidine may be added in your armamentarium. Now, outside of those patients who remain symptomatic, again, in several meta-analyses, trimetazidine has been proven to improve LV systolic function, to improve ejection fraction, reduction of our end diastolic volumes. That will definitely help our patients. And the reasons for this are multifactorial. You talk about myocardial energetics, you talk about reduction of apoptosis, LV remodeling. So it's a multifactorial thing. Unfortunately, again, the evidences are based on meta-analysis, and we're used to having RCTs as our gold standard for using evidence.
Correct.
But you have to realize that good meta-analysis, and you are an epidemiologist, Dr. Eugene, but I think good RCTs are as good as good meta-analysis can be used as good evidences also for use of some of our drugs.
There is an interesting question here. Again, I think you have to expound on this because Dr. Gomez is asking uh, if an asymptomatic patient is diagnosed with ischemia on routine screening, would you use trimetazidine?
Okay.
Oh, no angina, but there is evidence on ischemia on testing. Perhaps maybe a positive stress test. So would you use trimetazidine? Do we have, I'm sure you have experience on this,
Yeah.
but there's no angina this time.
Okay. That's a very good and difficult question. Is that
Yeah,
Dr. Lynn Gomez? No.
No, Dr. Cherise
Okay.
Camarote Gomez.
That's a very good yet difficult question, Dr. Gomez. Okay, let me take it from my perspective. I have been lecturing on on the paradigm shift with regards to the multifactorial causes of ischemia. Let me start with that. So not all patients with ischemia would have significant coronary artery disease, meaning to say that if your phenotype of the patient that you have ischemia despite absence of angina, if you're talking about a female patient who, sige, sabihin na natin na angiogram na, okay, normal coronaries, persist to have ischemia. So you might be talking about other causes which are non-epicardial. So what do you talk about? You talk about the microvascular component. You talk even about down in the center, the myocardial cell. Remember that ischemia now can be generated by large coronary artery or epicardial coronary problems, by our coronary microvasculature, which you don't see in your coronary angiography, and even down further by a myocardial cell dysfunction, the mitochondrial dysfunction. So if you have maximized your workup and you don't find problems with your epicardial, it's very hard to diagnose coronary microvascular disease. But if you're there and even the possibility of mitochondrial dysfunction, trimetazidine has a role, or metabolic agents have roles in this. Now, but the thing is, you have to remember that trimetazidine is actually prescribed for patients with angina. Okay, that's the indication. Your patient should be symptomatic. But I am not eliminating the possibility that in that particular patient that you mentioned, asymptomatic but persists to have evidence of ischemia in some tests, and you ruled out epicardial coronary, a young female possible microvascular dysfunction, I would probably consider giving these drugs.
Wow. That's nice. Reassuring somehow that our minds somehow, uh, agree. But there's a question here. I think this is very important. Undeniably, we know that we have no hard endpoints on trimetazidine, and he is asking, is there a study that showed significant reduction in mortality and morbidity? And I think I'm sure you will answer no.
Yeah.
But I think the better question is quality of life more important than hard endpoints of death? For me, everybody will die, but the quality of life while you're alive is something very important. What is your take on this? Is there ongoing clinical trials for tazidine to prove its efficacy in reducing mortality or um, you know
Yeah. I think you mentioned already the very important, I think, point when we manage patients. At this point in time, there are a lot of studies that do not only look at the hard endpoints, which you have mentioned, but look at the quality of life, the changes in terms of functionality of your patient, the symptoms, no? I would say they are as important. Of course, you will mention death yun yung hard endpoints. But I think quality of life, I would say, would probably as important as those. Having said that, the question is, of course, and you mentioned it already, there at this point in time, there is no large RCTs that have proven reduction of hard endpoints, cardiovascular hard endpoints with regards to the usage of trimetazidine in patients with CCS. Now, it might as well be important for us to put in the most recent study, I would say the largest RCT of trimetazidine, the ATPCI trial. This came out in the last ESC. Am I right? The last ESC trial, the last ESC. ATPCI, again, was a study that was done in patients post-PCI. Post-PCI. Stable patients post-PCI, they were randomized 30 days, within 30 days post the intervention. Patients were enrolled either with acute coronary events or with stable CAD. And unfortunately, again, the results were negative in terms of the usage of trimetazidine. But there were a lot of, I might as well continue about the one of the reasons, no, not that we are trying to explain why it was negative, but one of the major reasons that were used to why the results came out to be was that the patients that were enrolled in the trial were really low risk patients. Why? They're all post PCI, successful PCI. You cannot be enrolled if you did not have a successful PCI. The annual event rate that they expected for this group of patients that were enrolled in this trial was 40% lower than what they expected. So the event rate was very, very low, both for the placebo and both for the trimetazidine. What was the reason for that? 90% of the patients were already on maximal anti-anginal therapy. So if you think about it, they were post-PCI patients, successful PCI, they were already on numerous anti-anginal therapy, and of course, disease-modifying therapy drugs. You know, I will not run down on it already, but you know already. So they are already maximally treated. So that's probably one reason why it fared not as superior to placebo in those group of patients.
Right. No more room for reduction somehow. There's a question here as a comment. Yeah, he's asking for your comment. There are some interventionalists who discontinue beta blocker pre-procedure, accordingly, because it can bring about diffuse coronary vasoconstriction. Is that true?
Personally, I don't do it unless, well, of course, I don't. I mean, if I'm considering atherosclerosis as the cause, no. Unless you're thinking about vasospasm as a possible cause, then that's a possibility of discontinuing it. But if it is atherosclerotic, I don't think it should be a problem.
Well, another topic on COVID-19. There is such a thing post-COVID. They say it's post-orthostatic tachycardia symptoms. can we use ivabradine?
I think you have an answer for that, Eugene. Okay. Post-orthostatic tachycardia. Wow. The role of ibabradine, I'm sorry, but at this point in time, I don't think we have enough evidence, enough experience, I would say, in the usage of ibabradine in those group of patients. Eugene, do you have any?
No, the only thing I know where they use is inappropriate tachycardia.
Yeah, but not
I mean,
COVID related,
not
right?
not COVID,
Yeah.
right? And there is a text from the audience. The generic copies had different dissolution profiles, kinetics, dynamics, and he's informing that may be the explanation for the ethanol
Thank you.
study. Thank you for that. So it's the formulation itself. And last but not the least is, can you start trimetazidine right away to patients with, I think he's mentioning about CAD and diabetes. Perhaps many diabetic patients have silent angina, you know,
Okay.
and so would you routinely use it?
Yeah. Again, if you look at the one of my slides actually documented that very early on it can be used as a combination, combining it with either beta blockers or calcium channel antagonists.
Yeah.
So you can use it very early on in combination with those two drugs that I have mentioned. So the answer is yes.
Right. Thank you. And we're down to the last, I think, 3 minutes. And I think there's ultimately what you have presented is that in people with angina, ultimately we will be using combination therapy.
Yes.
And you're recommending combine it right away so as to impact quality of life. And at this point, I'd like to say and congratulate Dr. John Anunuevo for that very nice and remarkably stimulating discussion
Thank you,
on
Eugene.
anti-anginal agents, specifically with trimetazidine and ivabradine. So I would like to present to you this certificate. The Philippine Heart Association presents this certificate of appreciation to Dr. John C. Anunuevo in recognition and acknowledgement of your invaluable contribution in the PHA 51st Annual Convention and Scientific Meeting, given this May 26, signed by Dr. Ronald Cuico as the chair of the Scientific Committee and Dr. Jude Eric Cinco, overall chair, and Orlando Bugarin as the president. Thank you very much, Dr. John Anunuevo, and congratulations. And I would like to say thank you to the sponsor, the industry sponsor for this event. Thank you very much, and enjoy the rest of the sessions.
Thank you, Dr. John Añonuevo and Chairman Dr. Eugenio B. Reyes. We now move on to our afternoon lecture session on coronary heart disease. Lecture 1 presents Under Surveillance, Under Treatment of Angina Among Filipinos, Result of a Nationwide Opportunistic Screening. Delivered by Dr. Felix Eduardo Punzalan, Associate Professor 4 at the University of the Philippines College of Medicine, Department of Medicine, Training Officer and Research Committee Member of the Division of Cardiovascular Medicine, Department of Medicine of UPPGH, Member Specialty Board Adult Cardiology Committee on Core Curriculum, Active Adult Cardiology Medical Staff at Philippine General Hospital, Manila Doctors Hospital, and Medical Center, Manila. Lecture 2 discusses cardiac metabolic pathways, A Role in Ischemic Management, presented by Dr. Eugenio B. Reyes, Chief, Division of Cardiovascular Medicine of UP-PGH. Associate Professor of Medicine of the UP College of Medicine Philippine General Hospital, Scientific Advisory Board Member of APSC, past Zone 2 Vice President of the Asian Pacific Society of Cardiology, past Governor of American College of Cardiology Chapter Philippines, and past President of the Philippine Heart Association. Lecture 3 presents the use of colchicine in patients with chronic coronary disease, delivered by Dr. Nelson S. Abelardo, Professor of Medicine and Cardiology of the University of the Philippines College of Medicine and the Philippine General Hospital, Fellow of the Philippine College of Physicians and the Philippine College of Cardiology. This session is moderated by Chairman Dr. Iris M. Garcia, Medical Specialist 2, Department of Ambulatory, Emergency and Critical Care of the Philippine Heart Center, Chair of the PHA Council on Coronary Artery Disease, Active Consultant of the Philippine Heart Center, Capital Medical Center, Commonwealth Hospital and Medical Center, Fellow of the Philippine College of Physicians, the Philippine College of Cardiology, and the Philippine Society of Echocardiography. With co-chairman Dr. Carl Fernand D. Franco, completed fellowship in adult cardiology at the Cardiology Division of the Philippine Heart Center, subspecialty fellowship in interventional cardiology at the Philippine Heart Center, president of the PHA Davao Southern Mindanao Chapter, fellow of the Philippine College of Physicians and the Philippine College of Cardiology. Once again, we would like to remind everyone that questions will be entertained after all the lectures have been delivered. Thank you.
For this topic, I will discuss under-recognition of angina, leading to its under-treatment and its implication. I will also present the Angina Awareness Initiative program led by the Philippine Heart Association and the survey done during its conduct. This is my disclosure related to this topic. Angina is an important and common manifestation of ischemic heart disease. It is described based on three features. First, it is the characteristic discomfort, usually located in the chest, often described as pressure, tightness, or heaviness related to myocardial ischemia. Second, an important characteristic is the relationship to physical activity, classically appearing or becoming more severe with exertion. And third, the discomfort disappears with rest or sublingual nitrates. If the patient's symptom meets three criteria, it is considered typical angina. Based on the description, careful history is the cornerstone of the diagnosis of angina. Its presence triggers diagnostic process, looking into comorbidities, risk factors, risk stratifications, which is key to further testing for obstructive coronary artery disease, and ultimately, treatment for symptom relief and modification of prognosis. Therefore, the key to the whole process is recognition of angina. Considering its clinical importance, it is among the clinical conditions that the National Nutrition and Health Surveys monitored and has collected data in terms of prevalence. These periodic surveys were conducted by the Food and Nutrition Research Institute of the Department of Science and Technology. The most recent available data with regards to angina prevalence are from 2008 and 2013 survey. The 2013 survey showed the prevalence of angina among adult Filipinos is 25.4%, showing that a substantial number of the population has this condition. The tool used by the survey is a questionnaire developed through the Philippine Heart Association, which consists of questions regarding presence of chest pain or discomfort, whether discomfort is associated with physical exertion, and relief with rest or sublingual nitrates. This is officially referred to as the Philippine Heart Association Angina Questionnaire. We also have some data from Philippine Heart Association Acute Coronary Syndrome Registry, as reported in 2017, showing a 31.9% prevalence of previous history of angina among those who were admitted for acute coronary syndrome. The information on pre-hospital treatment is available. Many are on beta blocker and some are on calcium channel blocker. But we are not sure if the indication is hypertension since majority, that 75% of the acute coronary syndrome patients are hypertensive. Extrapolating from the data on treatment, looking at previous medications specifically for angina, and assuming that these are given among the 1,072 patients with angina, only 54% were on nitrates, 20% on trimetazidine, and 1% on nicorandil. They are the only ones with data. Possible reasons could be that the angina attacks are infrequent in many patients and not needing maintenance therapy or intensification of regimen, or the angina may be under-recognized and treatment was not instituted or adjusted. We have a more recent study on patients admitted for ST elevation MI done on June to December 2019. Dr. K. Evangelista led this study, and it showed 38.9% of patients admitted for ST elevation MI had previous history of angina. There was no data about previous treatment on the report. However, interestingly, the time of onset of latest angina attack to hospital arrival was 11 hours, ranging from 30 minutes to 3 days, indicating that there's still room for improvement for this time interval so that the management can be instituted earlier. Possible reasons could be logistics going to the hospital, but another reason could be that the angina may be under-recognized and treatment was not sought right away, leading to delay in the management. Why is it important to have data about angina? From epidemiologic standpoint, it is important to collect data about angina since it helps identify the burden of illness as a manifestation of coronary heart disease for guidance in the prioritization of programs. On the other hand, from clinical standpoint, it helps in risk stratification and subsequent management for control of symptoms, improvement of quality of life, and timely identification of need for more intensive treatment and improvement of prognosis. Prospective cohort study among patients at the outpatient clinics had shown that angina frequency was predictive of hospitalization for acute coronary syndrome as well as all-cause mortality. Those with severe angina, defined as angina several times per day, and moderate angina, which means having symptoms several times per week to every day, are twice likely to have acute coronary syndrome compared to those with minimal angina, defined as less than once a week or not at all. Angina frequency was also marginally associated with increased mortality at 1 year, but was significantly associated with mortality at 2 years. This study showed that severity of angina is independently associated with acute coronary syndrome and mortality among outpatients with coronary disease and may serve a valuable role in the risk stratification of such patients and in guiding treatment. More importantly, in order to select the appropriate treatment, the patient and the physician must first appropriately recognize the patient's angina burden. Again, the key to the whole process is recognition of angina. This concern about under-recognition of angina is highlighted in the study APPEAR, Angina Prevalence and Provider Evaluation of Angina Relief Study. This study was a cross-sectional, multi-center survey investigating the burden and management of angina among patients with chronic coronary artery disease in outpatient cardiology clinics. A peer study involved 1,257 patients from 25 outpatient clinics who had documented history of coronary artery disease defined as prior acute coronary syndrome, prior coronary revascularization procedure, or diagnosis of angina with chronic coronary syndrome. The prevalence of angina was assessed using a questionnaire given prior to their clinic visit. 32.7% reported at least one episode of angina over the 4 weeks prior to their visit. Among those reporting angina, 23.3% reported frequent angina with symptoms occurring on the daily or weekly basis, whereas the remainder had monthly angina. Interestingly, among patients with frequent angina, the ones with daily, weekly angina, only 56.3% are on optimal anti-anginal therapy, or more than 2 anti-anginal medications. Many, that's 38.5%, are on one medication only, and 5.2% are even not receiving any anti-anginal medication. This multicenter study of outpatient cardiology practice found that a third of outpatients with coronary artery disease reported angina in the months prior to the clinic visit. And among patients with frequent angina, many were on suboptimal anti-anginal pharmacologic therapy, highlighting that angina is common in the clinic setting, and there is a need to further improve recognition and optimization of treatment. This study shows that one potential means to improve treatment of angina would be to systematically quantify patients' angina at each clinic visit. Due to inherent limitations of history taking, with selective reporting of patients, especially with those with multiple comorbidities and different concerns, including the factor of time constraint of patients as well as physicians, appropriate recognition of angina can sometimes be challenging. If under-recognition of angina is possible, how does it affect treatment? This study evaluated whether under-recognition is associated with less treatment escalation to control angina and potential underuse of treatment. Since if angina is under-recognized, intensification of anti-anginal treatment would be less likely. More than 1,000 patients with coronary artery disease were asked prior to their clinic visit regarding angina and its frequency. The attending cardiologist blinded to the patient's pre-checkup response, then independently quantified patient's angina after clinic encounter. They were asked whether the patient had any chest pain in the prior month, and if so, how often the chest pain occurred, daily, weekly, or monthly. Under-recognition was defined as the physician reporting lower category of angina frequency than the patient. Attending physicians were also asked at the end of the study to specify their coronary artery disease treatment plan based on this particular visit. Any of the following were considered treatment escalation. 1, intensification of anti-anginal medication. 2, ordering a stress test, angiography, or revascularization, or hospitalization. Among 1,257 patients with coronary artery disease, 1/3 reported angina in the past month, of whom 43.3%, almost half, were under-recognized. What is more remarkable is the significant discrepancy in the rate of treatment escalation between the two groups. Patients whose angina was under-recognized were less likely to be referred for diagnostic or invasive testing, or have their anti-anginal medications intensified, compared with patients whose angina was appropriately recognized. This study demonstrated that under-recognition of angina in outpatient setting is associated with less treatment adjustment and may lead to failure to improve patients' health and underutilization of potentially beneficial therapies. Moreover, standardizing clinical recognition of angina using patient-centered tools could address under-recognition of angina, facilitate treatment, and potentially improve outcomes. In addition to under-recognition in the clinical setting, some people with angina do not necessarily seek medical care. It could be due to poor health-seeking behavior or failure to recognize the significance or importance of the symptoms. These situations may affect overall health. With regards to prognosis, in case angina is not identified, prospective cohort study already investigated the prognosis of angina among patients with and without diagnosis by a doctor. Participants were followed up with periodic survey, checking for angina and ECG care of the study, independent of clinical encounter. Their clinical records were also reviewed for diagnosis and outcome. The study asked the question, among patients with undiagnosed angina, what is the probability of 5-year mortality? About 11% of the participants developed angina. Some had no evidence of diagnosis by doctor, while some had. Compared with study participants who did not have angina nor myocardial infarction, there is a significant 2.4-fold risk of mortality among those who have undiagnosed angina with abnormal study ECG. This is higher than the risk of those with angina diagnosed by their attending physician. Even among the group without abnormal test, those with undiagnosed angina have a relatively higher point estimate of risk of dying compared to those with the doctor's diagnosis. This data highlights that undiagnosed angina was common and had an adverse impact on prognosis. All of the aforementioned information points to the importance of awareness. Awareness offers opportunities to improve health status through education about the disease and recognition of symptoms, about progression of the disease, and counseling about lifestyle modification and use of potentially beneficial treatment and intervention. And since angina is a symptom experienced by the patient and best reported by the patient, advocacy program to supplement efforts by individual doctors in the clinic setting to improve awareness and recognition is important. In 2018, the Philippine Heart Association, through the Council on Coronary Artery Disease, launched Angina Awareness Initiative. This was conceptualized by the European Society of Cardiology Working Group in 2017 and launched during the International Congress on Innovation on Coronary Artery Disease. The aim of the initiative is to increase awareness regarding the coronary artery disease and its symptoms, and the benefit of identification and management for the lay, patients, and doctors. The initiative was participated by Philippine Heart Association accredited training institutions and PHA chapters who conducted angina awareness campaign through angina awareness meeting among the concerned members involved in the campaign, and series of fora about angina and coronary artery disease in 2019 to early 2020, attended by laypersons in their specific areas. The program was initiated based on the concepts that under-recognition of angina will lead to poorer prognosis and early recognition will lead to better care and clinical benefit. Having the program offered an opportunity to gather some metrics regarding the burden of angina among the lay participants, considering that we have a tool, the PHA Angina Questionnaire developed through our association under the Council on Coronary Artery Disease and had been used in the past National Nutrition and Health Surveys. The survey during the awareness campaign was conducted to help PHA better understand the burden of angina and lay awareness about angina, and to guide the association on development of programs and advocacies. The survey was called PHA Angina Awareness Survey. The public fora for the Angina Awareness Campaign provided the occasion to collect information of interest using the questionnaire among the attendees in public meetings. This is the main tool based on PHA Angina Questionnaire. Participants are considered as positive for angina if the answer is yes in 1, presence of chest pain, tightness, or heaviness, and 2A, if the discomfort is experienced during exertion, and 3, relieved with rest, or 4, with sublingual medication. The Angina Awareness Initiative organizers added 2 questions inquiring whether 1, they have consulted with a doctor, and 2, if they were told to have heart disease. Basically, the questions of interest of the survey are the following. First, among the survey participants, what is the proportion of those with symptoms of angina? Second, among those with angina, what is the proportion of those with medical consultation? Third, among those who had medical consultation, how many were told to have heart disease? There were 2,755 participants included in the analysis. I would like to acknowledge Dr. A. Samson, who prepared the analysis. Majority are females with mean age of 41 years. For the question among participants, what is the proportion of those with angina? There were 784 out of 2,755 participants who are considered positive for angina, resulting to a prevalence of 28.5%, almost 30 for every 100 persons. How about the proportion of those with medical consultation among participants with angina? Only half of those who were positive for angina had medical consult. This is very interesting. However, the survey did not ask for the reason why there was no medical consultation. Lack of consult could be due to one, health-seeking behavior, socioeconomic issues, or the respondents did not recognize the discomfort as clinically important. And for the third question of interest, among those who had medical consultation, how many were told to have heart disease? Around 40% of those who sought consult were told to have heart disease. Either there are other alternative diagnoses noted during the consult, or the respondents are still waiting for the diagnostic test results pending the diagnosis, or the symptoms are under-recognized. However, these possibilities were not also part of the data collection and not addressed in the survey. Having said that, it shows that consultation because of recognized angina will pick up patients with condition that will need treatment. The survey showed that for every 100 participants, 30 have clinical manifestations of angina and only 15 of them, or half of those with symptoms, had medical consult, which is very concerning. And those who had medical consult, many were told to have heart disease. Overall, this is the important message that the survey tells us. Angina is common, and a considerable number of those with angina have yet to avail of medical consult. Therefore, a number of them don't know if they have heart disease that may need management with lifestyle modification, medical treatment, or intervention. And lastly, recognition and consultation will lead to better evaluation and opportunity of having treatment. There are some areas where the survey has limitation. It was conducted only among those who were interested to attend the lay fora, and in terms of prevalence estimate, the survey could overestimate the prevalence, since it is possible that the ones who probably have the disease are the ones who are interested with the fora and attended the meeting. Another limitation is the reason for lack of consult among those with symptoms, as well as the specific diagnosis among those with consults were not asked in the survey. Lastly, since the survey is done among the attendees of the angina lay fora, the data cannot be generalized for the Filipino general population. In summary, angina, whether diagnosed or under-recognized, is common in the clinic setting and even in the community. Awareness of angina is important since under-recognition could lead to missed opportunities for diagnosis, medical management, and poor prognosis. Since substantial gap in knowledge and recognition of angina exist, and considering that this manifestation can affect management toward prevention of cardiovascular events and improvement of quality of life, angina questionnaire may be useful in the clinic as a tool in identifying patients for whom treatment or more aggressive medical therapy or additional interventions are indicated. The survey gave us an indication that there's room for improvement in terms of awareness. Continuing the awareness initiative could help spread information and appreciation about the disease and lead to better health status. Lay awareness regarding the symptom and its implication will inform and encourage those with symptoms to seek consult that will allow detection of medical condition and opportunity for treatment. And consistent with the annual convention theme, next level strategies, Angina Awareness Initiative should be one of the next level strategies of the Philippine Heart Association. If training institutions and chapters continue to closely collaborate with each other, we can always rise to a higher level. Let's go to the major stakeholders, our patients. As mentioned, angina is a symptom experienced by the patient and best reported by the patient. Thank you.
Greetings. The next topic is the local experience on the use of novel anti-ischemic agents. I would like to disclose the following and share with you the objectives of this session. I'm going to discuss some of the mechanisms of the novel anti-anginal agents, present data on the utilization rates of anti-anginal agents, and provide concepts on how practice is influenced by beliefs and guidelines. Let me begin to you by describing the discovery and clinical use of the different anti-anginal agents. It all started in 1768, where angina pectoris uh, was introduced as a disease, where in fact it's really a symptom and not a disease. And you can see by side under it are the discoveries of the different types of anti-anginal agents. But down the line in the year 2002, this clinical entity was converted to chronic stable angina. And in 2012, it was converted to stable ischemic heart disease. And after a year, the European Society of Cardiology introduced the word stable coronary artery disease. And much more uh, uh, clarity was developed in 2019, where chronic coronary syndrome was introduced to replace stable coronary artery disease and stable ischemic heart disease, but including, of course, acute coronary syndrome as a component of it, making it a big condition where you see acute and chronic coronary disease. Now, down the line, you will see the different anti-anginal agents. Some may be novel in its mechanism of action, simply because in the discovery of the nitrates, the beta blockers, the calcium channel blockers, they all induce hemodynamic effects, whereas the novel drugs in the form of trimetazidine, ranolazine, and ivabradine, they are neutral hemodynamically. Now, side by side also is the concept that or the understanding of how myocardial ischemia happens. Well, we have structural and what we call obstructive, exemplified by atherosclerotic disease and vasospastic disease. And on the other side, we have what we call microvascular disease. And all of these conditions coexist with each other in any given patient. And it's very important for me right now to describe what is angina and ischemia. Angina is the symptom itself. And when you see angina, they are more predictive of outcomes than what we call ischemia, because ischemia is based on laboratory tests like ECG, uh, treadmill exercise tests, imaging technique like 2D echo and other imaging tests. But the presence of angina is more um, uh, accurate than the presence of ischemia. And when you treat angina, it affects outcome. Whereas when you treat ischemia, it doesn't. Now, I'm moving now to the novel anti-anginal agents. And so far, these are the different anti-anginal drugs that are working on the metabolic pathways, specifically on energy. And you can see here the sites of their action. For example, trimetazine and ranolazine inhibit beta oxidation. The beta blockers and ivabradine has an effect on the CPT1. Thereby, all of them increasing energy expenditure and by the myocardium and reducing the accumulation of some agents that is toxic to the myocardium. So let me discuss one by one the novel one. First, the 3-ketoacyl-CoA thiolase inhibitor exemplified by your trimetazidine. And you know the site of action, it inhibits beta oxidation and causing the activation of the glycolytic pathway and glucose oxidation, thereby increasing the production of ATP more than the production of ATP from beta oxidation, causing an improvement in energy expenditure. The other one is the sodium channel blocker, exemplified by ranolazine. It inhibits the sodium entry into the cell, thereby causing a reduction in the calcium content of the cell. Indirectly, it also inhibits beta oxidation, improving the glucose consumption of energy, improving also the production of ATP. Last but not the least is ivabradine. Of course, you know where the action of ivabradine is. It's in the IF channel, and it inhibits the sodium entry and potassium efflux, and causing a reduction in the depolarization of the sinus node, causing a reduction in heart rate. All of these three important mechanisms were very popular and very novel. However, the use of these three agents failed to reduce outcome in people with chronic coronary syndrome or stable coronary artery disease. That perhaps it brings us to the guidelines where beta blockers and the calcium channel blockers and the nitrates are still the first line treatment for people with angina. And down the line, you will see that you can combine them all together as long as you can improve the quality of life of these patients. And that's the reason why in the ESC guidelines of 2019 for chronic coronary syndrome, almost all of these novel drugs were put but class 2A recommendation. I think all of these factors influence the practice or how cardiologists, generalists, and physicians in the Philippines practice the use or uh, influence the use of the different anti-anginal agents. But look, if you look at the data taken from the IQVIA on the use of anti-anginal agents per molecule in the Philippines, and this is in terms of patient treatment days, the highest achieving almost 900,000, sorry, 90,000 uh, patient treatment days. It is trimetazidine that is the most popular, and the nitrates, the beta blockers, and the calcium channel blockers, which were labeled as first-line anti-anginal agents, were not popular during the time that these data were taken. Why? I'd like to share you possible explanations. Of course, safety profile is very important. If a drug is neutral and it's not causing side effects, of course, it's going to be a priority for many doctors. Drugs that cause hemodynamic effects like drop in blood pressure or lowering of blood pressure causing headache, for example, nitrates, and that drugs that cause some interaction with other drugs and causes some fear among clinicians, and some drugs that cause excessive, for example, heart rate reduction and induction of atrial fibrillation are some of the limiting factors and may uh, um, sway one doctors to use one drug over the others. And so I would like to summarize that the local practice, of course, there is um, what we call uh, disagreement with the guidelines, because the guidelines is recommending the use of first line agent. And these are the beta blockers, the nitrates, and the calcium channel blockers. But when you look at the market, the leading anti-anginal drugs are those which act on the metabolic pathways. And the reason, of course, is that they are hemodynamically neutral agents. Despite being a class 2 recommended drugs, they are now the preferred agents locally. And for all you know, they are being combined. All of these agents are being combined in these patients with angina. Thank you for your attention.
Thank you, PHA, for the invitation to share something in this virtual convention. Thank you for the kind introduction. Good evening and warm greetings to friends and colleagues in the Philippine Heart Association. My topic is about colchicine and coronary artery disease. I occasionally speak for Menarini Philippines, GX International, and LRI TheraPharma, all pharmaceutical companies, but I do not have conflict of interest with respect to the topic at hand, and my primary motivation is nothing more than the delivery of the best relevant medical information to our colleagues that would be useful for clinical decision making to enhance their clinical practice and finally redound to the benefit of patients. What is it that predisposes one to develop angina pectoris, acute coronary syndrome, acute myocardial infarction, heart failure, or even sudden cardiac death? In patients with advancing age, especially if with associated conventional or novel risk factors, it is atherothrombosis, which is a long-standing, gradual, progressive process of degenerative changes, widely believed to be a slow accumulation of lipid substrate within the subintimal layer of the blood vessels until it results in varying degrees of obstruction, and this is known as the lipogenic theory. Or it can become completely occluded by a thrombus and thus impeding the blood flow into the myocardial tissue, and this we call or all know as myocardial ischemia. Approximately about 50 years ago, the process has been further elucidated through the observations of some of the brilliant minds in cardiology, like William Roberts of Harvard Medical School, that acute thrombosis can occur even in an insignificant obstruction of less than 60% in the coronary arteries, which would abruptly and totally occlude the blood vessel coronary artery, resulting in acute index event like unstable angina, acute myocardial infarction, or sudden cardiac death. Further histopathologic characterization by Renu Vermani, a protege of Dr. Roberts and one of the movers of the Armed Forces Institute of Pathology, showed the various appearances of coronary artery lesions with lipid core with or without intraplaque hemorrhage and various thickness of the fibrous cap. Some are thick, which are known as stable plaques, and some are thinned out, which are characteristics of unstable plaques. Still, further studies with the works of Peter Levy showed that there are certain cellular and humoral mechanisms mediated by immunologic processes acting on the endothelium or unstable fibrous cap that alter its integrity, and this is something that gives rise to endothelial injury and causing plaque ruptures, setting off a cascade leading to acute thrombosis. Efforts to reduce or even reverse these processes were the subject of so many investigations. But let me start with one intervention, and that is reduction of the conventional risk factor cholesterol. In the Jupiter trial with rosuvastatin, the reduction of LDL cholesterol was associated with significant 44% reduction in the composite endpoints overall. But if one looks at the various patient subgroups and analyze it, the subgroup at highest risk, which is those with LDL of 130 and HSCRP of greater than 2 milligrams per liter, showed the highest reduction in mortality. And this prompted investigators led by Paul Ridker, who is the Eugene Brownwell Professor in Cardiology at the Brigham and Women's Hospital of the Harvard Medical School, to look further into the mechanisms of the impressive results, which was not only due to LDL reduction with some regression of the atheroma, but also due to stabilization of the atheromatous plaque. But even in the best case scenario, of LDL cholesterol reduction, there remains a residual risk of 1 out of 3, or 33%, arising from not treating optimally to target the cholesterol levels or from concomitant inflammatory mechanisms. These efforts further led to the consideration of the interventions to reduce inflammatory process within the plaque. This slide shows the various mechanisms by which interventions may be carried out to reduce or modulate the immunologic process. We have the NLRP3, which is the coding gene, and the in-microtubular polymerase present in the inflammasome, which could trigger cleavage, activation, and secretion of interleukin 18, interleukin 1, and interleukin 6, commonly known as cytokines, and initiate the process of inflammation. Peripherally, it is detected by the high sensitivity C-reactive protein, and the level of 1 or less than 1 milligram per liter is considered to be of low vascular risk. Inhibitors like tocilizumab, canakinumab, colchicine, and others were substances identified that could attenuate some of these pathways and therefore prevent inflammation. Allow me to go through some of them with some illustrative studies. The canakinumab anti-inflammatory thrombosis outcome study, or CANTOS, looked into 51,731 patients, 18 years and older, of the Stockholm healthcare system, greater than 30 days post-MI, and who had HSCRP testing from January 2007 to December 2011, or a period of about 5 years. After the exclusion criteria were applied, 17,464 patients were eligible for analysis. The major adverse cardiovascular events and MACE plus, which means plus death, were significantly reduced by 15 and 17% respectively with treatment of canakinumab versus placebo associated with a 35 to 40% reduction in HSCRP and interleukin 6, even without significant reduction in LDL cholesterol and blood pressure. If one looks at the subgroup of how much reduction of HSCRP or interleukin 6 was achieved, those with reductions that were still above median levels of 2 milligrams per liter were comparable to placebo-treated group, while those with greater reductions in HSCRP of less than 2 milligrams per liter below median levels were associated with greater reduction of events compared to the above median and placebo groups. Therefore, the CANTOS study showed greater reduction in MACE and with greater cytokine inhibition. Indeed, in a similar cohort by Carrero et al., published in the Journal of American Heart Association, HSCRP levels were elevated in most patients with acute myocardial infarction, with a linear association with subsequent risk of MACE and death of levels from 1 to 5 milligrams per liter, plateauing thereafter to a sustained increased risk. Further, this may identify patient subgroups who may benefit from more aggressive guideline-based treatment of risk factors and changes to reduce inflammation. Now let me move to some studies on colchicine in cardiovascular disease, and I'll start with a study by Nydorf et al. The first is the seminal study published in the Journal of American College of Cardiology in 2013 called LODOCO, or low-dose colchicine, which was a pilot trial in 532 patients with anti-inflammatory drug colchicine given at 0.5 milligrams once daily to show safety and efficacy. It appeared safe and effective for secondary prevention of cardiovascular disease and suggested that if its efficacy can be confirmed in a rigorous trial, repurposing it for secondary prevention of cardiovascular disease would have the potential to impact global burden of cardiovascular disease. The primary reason for using colchicine is for acute gouty attack. The second trial is the LODOCO-2, which is an investigator-initiated coronary artery disease tolerant to colchicine during a 30-day run-in phase, which have been randomized to colchicine 0.5 daily or matching placebo on a background of optimal medical therapy. This study will have a 90% power to detect a 30% reduction in the composite primary endpoint, that is, cardiovascular death, myocardial infarction, ischemic stroke, and ischemia-driven coronary revascularization. This slide shows the demographics of LODOCO, which included, among others, a concomitant treatment with aspirin or clopidogrel, dual antiplatelet therapy, and high-dose statins, which may have some anti-inflammatory effects themselves. Looking at freedom from primary outcome, defined as acute coronary syndrome, out-of-hospital cardiac arrest, or non-cardioembolic ischemic stroke, the hazard ratio was 0.33, meaning the reduction or a reduction in relative risk of 67% after 1,400 days with colchicine treatment, and the NNT was estimated to be 11. If you look at the components of the primary outcome, like freedom from ACS, the odds ratio was 0.33, meaning a reduction in relative risk of 67%. And if you look at the freedom from non-stent related acute myocardial infarction and unstable angina, the odds ratio were 0.25 and 0.27 with a mean of 0.26, meaning a relative risk reduction of 74% with the use of low-dose colchicine of 0.5 milligrams once a day. The LODOCO-2 was published in the New England Journal of Medicine in 2020 and was a sequel of the first using colchicine in chronic coronary artery disease. Enrolling from Australia and the Netherlands, some 5,522 participants who had chronic coronary artery disease or any evidence on invasive or CT angiography or a coronary artery calcium score of greater than 400 Agatston units and had been clinically stable for at least 6 months, randomizing them to colchicine 0.5 milligrams or placebo. The mean age was 66 years and 15.3% were women and 84.4% had a history of acute coronary syndrome. At baseline, 99.7 were taking an antiplatelet or anticoagulant, 96.6 a lipid-lowering agent, and 62.1 a beta blocker, and then finally 71.1 of them a renin-angiotensin-aldosterone system inhibitor. The primary endpoint of cardiovascular death, MI, stroke, or revascularization with colchicine 0.5 milligrams compared to placebo after 60 months or 5 years had a hazard ratio of 0.69 or a reduction of relative risk of 31%, while the secondary endpoints of cardiovascular death, MI, and stroke had a hazard ratio of 0.72 or a relative risk reduction of 28%. Although the hazard ratio of primary and secondary endpoints were quite impressive, with narrow confidence interval, there was a note of wide confidence interval for a stroke of 0.35 to 1.25, and interestingly, no significant reduction or even an increase in overall mortality with an odds ratio of 1.21. Okay, so far so good. Colchicine appears to be effective for those with recent MI and chronic atherosclerosis. But what about those with ACS, acute coronary syndrome, and acute myocardial infarction. The efficacy and safety of low-dose colchicine was looked into by the study called COLCOT, or Colchicine Cardiovascular Outcomes Trial by Tardif et al., published in New England Journal of Medicine. In this study, 4,745 patients with acute myocardial infarction, and they looked into primary outcomes of cardiovascular death, resuscitated cardiac arrest, MI, stroke or coronary revascularization with an overall hazard ratio of 0.77 or a reduction in relative risk of 23% with colchicine versus placebo over a period of 42 months, and the NNT was calculated as 63. This slide shows the breakdown of the significant relative risk reduction in composite primary outcomes with a trend to benefit for the secondary outcomes except stroke and urgent revascularization and a higher incidence of pneumonia for the colchicine-treated group. In the COLCOT trial, there was an overall benefit for cardiovascular outcome in the early treatment initiation group with acute myocardial infarction, but caution is raised when looking at subgroups because benefit might also be because of early hospitalization. In 2020, the Australian COPS study was published in Circulation. This was a multi-center randomized double-blind placebo-controlled trial of 795 patients with acute coronary syndrome given colchicine 0.5 milligrams twice a day for 30 days or 1 month, then once a day thereafter for the next 11 months. The addition of colchicine to standard medical therapy in patients with ACS did not significantly affect cardiovascular outcomes in ACS patients and was associated, in fact, with a slightly higher rate of mortality. Having individual perspective of the different clinical trials on colchicine, let us look at the aggregate data in a meta-analytical way conducted by Samuel et al. And published in the Canadian Journal of Cardiology in 2020. And this slide shows the salient features of the studies which I have described a while back. We have the Lodoco in 2013, COLCOT in 2019, COPS and Lodoco 2 in 2020, and all of them randomized controlled trials looking at respective properly defined endpoints and running for 12 months for COPS and 22 to 28 months for the rest of the other trials. The studies had adequate study population and were sufficiently powered to detect significant differences arising from the intervention. The demographics showed good age and gender distribution, as well as the inclusion criteria and risk factors and exclusion criteria being properly defined. The primary composite endpoints of MACE Plus in this forest plot for Lodoco 2, COPS, and COLCOT showed that the point estimates were to the left of the line of unity with an overall hazard ratio of 0.68, and that is the forest plot on the left side of the screen, or a reduction of relative risk of about 32%. However, the all-cause mortality rate was 1.04. The secondary endpoint, which were the components of the primary endpoints of cardiovascular mortality, myocardial infarction, ischemic stroke, and urgent coronary revascularization, all were to the left of the line of unity, showing benefit of colchicine in these areas, although some of them had the confidence intervals crossing the line of unity going towards the right. In a subsequent publication by PLA et al. In 2021, published in the European Heart Journal, in a systematic review and meta-analysis of 5 randomized controlled trials published up to September 2020 that included a total of 11,816 patients given colchicine and looking at similar composite primary endpoints, it was shown that low-dose colchicine reduce the risk of MACE, as well as that of myocardial infarction, stroke, and need for coronary revascularization in a broad spectrum of coronary disease. The number needed to treat was computed at between 30 to 98. There was no difference in all-cause mortality, and fewer cardiovascular deaths were counterbalanced by more non-cardiovascular deaths. On the right side of these are some of the potential mechanisms of colchicine to inhibit the inflammasome, second, to inhibit neutrophil chemotaxis and adhesion and activation, and third, by inhibiting neutrophil platelet interaction, which contributed to the favorable numbers that they got in this particular meta-analysis. To summarize, even with the scenario of lipid lowering with high-intensity statins, there exists a high residual risk of approximately 33%, which can be further addressed by more aggressive lipid-lowering therapy to much lower cholesterol targets, and, on top of it, an effective anti-inflammatory treatment to provide additional reduction of inflammation. CANTOS proved that the specific anti-inflammatory effect of canakinumab reduced the risk of cardiovascular events in high-risk patients with coronary disease. CALCOT proved that colchicine reduced the risk of cardiovascular events in patients following recent myocardial infarction. LODOCO and LODOCO-2 are evidence to support the routine use of colchicine for secondary prevention in patients with coronary disease, chronic. Overall, in meta-analysis among patients with chronic coronary disease, 0.5 milligrams of colchicine given once daily resulted in a 31% lower relative risk of cardiovascular death, spontaneous MI, ischemic stroke, or ischemia-driven coronary revascularization, primary endpoint, compared to placebo with a hazard ratio of 0.69. Colchicine has been known to have a broad anti-inflammatory effects and is widely available. Paul Ridker, in his address to the Physicians Academy for Cardiovascular Education, said that anti-inflammation heralds the future of cardiovascular medicine. The question is, do you agree that the time has come to give colchicine to patients with stable atherosclerotic disease? Thank you very much for your kind attention.
Thank you, Dr. Felix Eduardo A. Punzalan, Dr. Eugenio B. Reyes, and Dr. Nelson S. Abelardo. Ladies and gentlemen, the floor is now open for your questions. For those who have not sent in their questions, please do so now using the chat box. Our speakers and moderators will now field the questions already sent. Thank you.
Good afternoon. I'm Luigi Segundo, and I'm honored to chair this session on behalf of the current chair, Dr. Iris Garcia. Excellent lectures, doctors. You agree, right, Carl? All the way from Davao. So we heard Dr. Punzalan tell us that there's under surveillance and, more importantly, under treatment of angina in the Philippines. And so we have heard from Dr. Reyes, we have to amp our armamentarium. So he presented the second line agents, what's the so-called second line agents. And from Dr. Abelardo, an old friend, colchicine. It's now the time to ask questions. You can type in your questions in the chat box. Carl, would you like to ask the first question?
Okay, sir. To Dr. Punzalan, actually, it's a simple question, sir. We know that there's really underdiagnosis or under-recognition of the angina. Is there any other way other than the recommendation or other recommendation other than the angina tools that we've done to increase angina awareness?
I think itong angina tools, because these are patient-reported outcomes, assistance sa doctor might help in the clinic. But outside the clinic, I think continuing the awareness campaign, educating the patient that if you're feeling something, chest pain, hindi dapat baliwalain. I think we need to really describe to them that kind of chest pain that they have to be alarmed. And also to tell them the significance and the benefit of seeking consultation, going out from the clinics. And I think that's the challenge sa Philippine Heart Association.
I have a follow-up to that, Dr. Punzalan. You have mentioned this because this is an opportunistic screening, and opportunistic screening actually overestimates the prevalence.
Yes.
There's an important number there. Now, it says there 28.45% with angina. That's a little close to the latest NHES, right? So about 25%. No? But there's an important number there. Only 50% of them has ever sought consult. How does opportunistic screening affect that number, sir? So is 50% still an overestimation, health-seeking behavior of the Filipinos regarding angina?
It could be, no? If we assume that those who attended the lay fora, the awareness initiative, are the ones who are already interested because they have symptoms or they have consulted their doctor. So they will be more interested in listening to the awareness. The prevalence will be increased. No? It's about 28, as you mentioned, 28.5. So the best data that I can quote is the National Nutrition and Health Survey, because they surveyed angina nationally, regardless they are attending the lecture or not. They went to the household. So these are patients who are selected by random stratifying method, and it's 25%. So it's still high. So I think relatively near to sa national prevalence. So that's the burden of the angina in the Philippines. Now, what would be the effect on the percentage on those who had consult? Probably it will markedly reduce, because when you go to the national population, I'm sure not all of them are being consulted. And the best data, again, is in the data on the NS 2013. Those who are diagnosed with coronary artery disease is only 0.9% or 1%. You can say 1%. So, ang laki kasi nung gap. No? So, probably the 50% in the angina awareness survey is also overestimated. But the problem remains. There's a lot of people with angina who have not consulted their doctors, and they haven't started with any medicine or diagnostics. Thank you. Thank you, Mark.
So we doctors, especially cardiologists, should be more proactive and actually ask our patients, do you have chest pain, do you have angina? Yeah. Dr. Reyes, you pointed out earlier robust data actually on the hemodynamic neutral agents, right? Trimetazidine, ranolazine, as opposed to the so-called first-line agents. But they're mostly in combination with the first-line agents. Do we have data about combining the second-line agents or combining the hemodynamically neutral agents, for example, trimetazidine and ranolazine?
Quick answer to that is, of course, we don't have data. The data that I presented to you, the 90,000 patient days, that's based on pills bought by patient. That's a sales. Pills bought by patients, so which means that 90,000 people were taking trimetazidine per day. So I have no data on the combination of which is being combined, but indirectly we can show to them that it's only 1/3 we're using nitrates, and the same numbers we're using beta blockers at the same time. So the beta blockers are underutilized, same with the nitrates, and same with the calcium channel blockers. And the second lines were the ones being utilized as first line. So there's a twist in the recommendations from the guidelines.
Thank you, sir. We have a lot of questions for Dr. Abelardo. First question, sir, from Dr. Rudy Boy Natividad. How long do you recommend giving colchicine for a post-MI patient, sir?
There is no hard and fast rule, but the studies would show that if you have acute myocardial infarction, it can go as high as 5 years. But for example, I've had patients who were taking colchicine for the last maybe 10 years or so. And I think that
Nawala yata si Dr.
debilitating
Belardo.
Yes, sir, you're back. We missed you for the about 10
a low
seconds.
percentage of patients with debilitating angina or has had recurrent myocardial infarction. So the prolonged intake of colchicine, even at a low dose, will promote stability of the clinical course of coronary artery disease.
So can be indefinite as well, sir?
It can be used as a maintenance. My feeling is it can be used as a maintenance. Even Paul Ridker has commented that in the era of in the new era, anti-inflammation will henceforth be the major approach for treatment of cardiovascular disease. I remember some consultants of mine in the 70s or 80s saying that in the next 20 years, immunology will be the in thing that will explain most of our cardiovascular diseases. And this is probably one of them.
Thank you, sir.
Is it in the guideline already?
Colchicine. Yes, sir.
Is colchicine in the guideline already?
They expect that to be incorporated in the guidelines within the next maybe few years.
Maybe the ESC first, right, sir? Because the data was shown at the ESC meeting.
Yes.
2020.
Yes.
Another question, sir, Dr. Abelardo. Will colchicine also work for peripheral artery disease? Can we give colchicine with clopidogrel and cilostazol for patients with angina and post-stroke?
Let me just qualify the whole premise. It can work in blood vessels, whether coronary or peripheral blood vessel. But the problem is it doesn't work in progressive deposition of lipid substances within the blood vessel wall. It works on the stability of the plaque, characterized by inflammatory changes. And we know very well that based on characterization, those that are considered to be the vulnerable plaque or high-risk plaques are those with fine or thin-walled plaque cap. They are considered in the junction. They are considered to be vulnerable if they have a rich lipid core or with intraplaque hemorrhage. And the reason for this is that they will eventually be predisposed to rupture and acute thrombosis.
Thank you, sir. So you mentioned that colchicine, when we use colchicine, we target the inflammatory risk. And you mentioned about the HSCRP initially as a target. In this era of, a lot of us would just like to do ischemic diagnostic tests and rely on revascularization. Would you actually consider up-titrating or adding colchicine as an add-on agent merely on the basis of angina, uncontrolled angina, sir?
I may not have that much evidence to that effect. No, I'm not ready to make any or a committed view on that. But that being said, the pathophysiology of angina, especially going into the so-called instability phase, may be a function of an unstable plaque. So instability probably means an unstable plaque. And an unstable plaque means probably, or there's a greater risk of it being inflamed. And so with that kind of situation, maybe yes. But if you're just referring to the so-called classical angina, where the problem is mostly effort related, it's largely a balance between oxygen supply and demand. And so therefore, the hemodynamically active drugs may be of better use.
Thank you, sir. I'd like to ask everyone in the ESC guidelines, it says there follow-up of 2 weeks on treatment of coronary artery disease or angina. So I'd like to ask each doctor's practice here is, do you also follow the same thing, 2 weeks follow-up, especially during this pandemic? Because we pointed out, Dr. Punzalan, there's under recognition, under surveillance, under treatment. So in your own practices, sir, Dr. Punzalan first, how often do you follow them up from initiation of treatment and maintenance probably?
It depends on the severity of angina. Those who have frequent angina, I think I follow them up like 2 weeks. But those who have already on chronic coronary syndrome phase, wherein the angina is controlled, and you have already evaluated them in terms of the risk of events, and it tend to be low risk, then you may not have to follow up them every 2 weeks. So the more frequent follow-up among those with high-risk features, frequent angina, and those who you are still doing diagnostic and prognostic test, because they might need intensification of medical therapy and need for revascularization.
Thank you. Dr. Reyes, sir.
You are right. I follow them up every 2 weeks upon initiation of treatment, and that's the only visible thing that I have. Using a diary. A diary will help me as well find out if the anti-anginal agents are effective. It's like a scoring system. So they can score themselves per week or per day regarding the number of times they felt angina. And if you are successful, every 2 weeks, then you have a progressive increasing interval of monitoring. A diary is effective.
Thank you, sir. Dr. Abelardo.
Oh, well, let me just backtrack a little bit on detection of angina. Because of the underreporting by the patient, because of the over-reporting of doctors. There is more or less a disconnect there. No? Doctors would consider more angina, pero ang pasyente would not probably consider this as, kaya ko pa ito, it's not angina. So, the only way to pick it up really is to place or put everybody under a protocol where, like for example, in the Kaiser Permanente system, where everybody needs to be followed up by a particular doctor every so often, and a set of questionnaire is filled up.
Yes.
In Sweden, for example, when I was there in the early 80s, everybody is listed in the healthcare system, and everybody gets to be followed up once they enter into a particular protocol. So they have a fantastic database there. But in my practice, it really depends on how grave the situation is. If it's a new onset angina, if it is an angina that is increasing, if it's an angina that goes unstable and so on, then I tend to follow them up more closely and therefore more frequently. But if it's an angina that is just lying there, and sometimes you have it, sometimes you don't, you tend to follow them up in a more lax way. However, when the problem is something which involves adjustment of the dose of the medication or a new medication, I give time for the medication to act. You probably know that there is absorption, there is circulation, distribution, and half-life, and all these things. And there is a steady state concentration. So before the drug achieves steady state concentration and regular or predictable response, you have to allow a certain time before you make a follow-up for your patient. So why not 1 week? Kasi it may be too soon. Maybe 2 weeks is enough time for the drug to achieve steady state concentration and do its thing and have a significant or more or less appreciable effect on the patient.
Luigi, it's good to know that Dr. Eugene and Dr. Nelson are agrees that clinic tools in determining angina and its frequency is very helpful. So that's a good project to pursue.
I totally agree. It's about time that we ask patients to evaluate themselves.
Yeah.
Um, Self-evaluation is the way to go right now. Even the questionnaires that we are offering in heart failure,
Yeah.
for example, the KCCQ self-administered questionnaire, you will know already if the patient is improving when they are the ones answering the
Yeah.
survey, right? The same
Thank
as
you,
with
sir.
diary, with angina diary, they're the ones counting if that is angina or not, right? And you will know if they are improving or not based on their own assessment.
Thank you, sir. Carl is the president of Davao chapter, and the biggest hospital in Mindanao is Southern Philippines Medical Center, right? Can you describe to us your practice there, Carl, in chronic coronary syndrome patients, and whether you use the second line agents or even colchicine?
Yes, sir. In Davao, though, SPMC is not yet a training program for cardiology. We only have internal medicine, but soon, if actually we're planning to have a a cardiology training if this because of the pandemic there's a halt. But as mentioned by our doctors, Dr. Belardo, Dr. Reyes, Dr. Bonsalan, at least almost the same. I think still we're giving those novel anti-anginal drugs, as mentioned by Dr. Eugene Reyes. Most probably, still trimetazidine is the number one because of its neutrally hemodynamically. It will not affect the blood pressure. Almost the same, and most probably, for example, patients who consult for angina, sometimes even though it's not really the angina or ischemia that causes like anxiety, of course, what else do we give? Do we give beta blockers? The most safest way is to give that trimetazidine and then reassess. And of course, same way when to follow up the patient, the same with you doctors, 2 weeks to 1 month probably, let the medication have the effect. And of course, colchicine, it's we give them, but of course, hindi pa siya, there's no guidelines, so only limited doctors would use colchicine for, sa ngayon.
Thank you. Thank you, Carl. And if there are no more questions, we've learned a lot this afternoon. So there's under surveillance and under treatment of angina. So we should be more proactive in treating our patients. Symptom diary is probably more important than any ischemia diagnostic test. And there's a lot of medications, not just the first line agents. We have the hemodynamically neutral agents, and we have colchicine as well. And we eagerly await what the guidelines will say soon. And if there are no more questions, I'd like to close the
Can
session.
I make a comment on that?
Yes, Dr. Abelardo.
Symptom diary is indeed going to be the most useful tool. And the reason for that is most of the tests that we have will probably be limited. You will recall from your school days that angina is a clinical diagnosis.
Yes.
It's not really a lab diagnosis.
Yes.
It is a clinical diagnosis, and therefore it is the patient that is going to tell you that it is so.
Yeah.
It's not even the doctor. The doctor will just compile all the characteristics, but the patient will tell you that it is angina. So the diary would be most helpful in telling the doctor that, hey, this is angina.
Thank you, sir.
We can
Yes,
we
Dr.
can make
Reyes.
an app, a cell phone app, where you can
Yes.
for yourself, right?
Yes.
Very useful.
Uh-uh.
Very useful for telemedicine. In fact,
Yes.
that's one of the
Yes.
projects for Angina Awareness Initiative. We'll
Yes.
follow that up. No? Very productive afternoon. And so, the Philippine Heart Association presents the certificates of appreciation to Doctors Punzalan, Dr.
Thank you.
Reyes, Dr. Abelardo, and to you as well, Carl. In recognition and acknowledgement of their invaluable contribution as speakers and co-chair in the Philippine Heart Association 51st Annual Convention and Scientific Meeting, given this 26th day of May 2021, signed by Dr. Ronald Cueco, Chair of Scientific Committee, Dr. Jude Eric Cinco, Overall Chair, and Dr. Orlando Bugarin, our President. Good afternoon and see you at the dinner symposium.
Thank you, doctors, for your questions. And thank you once again, Dr. Felix Eduardo A. Punzalan, Dr. Eugenio B. Reyes, Dr. Nelson S. Abelardo, Chairman Dr. Iris M. Garcia, and Co-Chairman Dr. Carl Fernand D. Franco. Ladies and gentlemen, we now move on to our dinner symposium. Lecture 1 discusses how can we protect our elderly and high-risk AF patients from stroke, and is presented by Dr. T. Wee Seong, Senior Consultant in Cardiology and Electrophysiology at the Heart Specialist Clinic, member of the Civil Aviation Medical Board from 1998 to 2015, and from 2016 to 2020. International Advisory Board of the Journal of Arrhythmia since 2008. Fellowship and accreditation includes MBBS in Singapore, M.Med in IntMed Singapore, MRCP from the UK, FAMS Cardiology Singapore, FRCP in Edinburgh, FACC in the United States, and FHRS. Lecture 2 states that age is just a number, keeping the heart alive for couples, value-added topic, presented by Dr. Lulu Marquez, graduate of the UST College of Science, B.S. General in 1976, graduate of UERM MMC College of Medicine from the year 1981, Lantern Queen of the 1979 of UERM MMC, life member of the Philippine Medical Association, life member of the Quezon City Medical Society, completed anesthesia training at the Philippine Orthopedic Center, and pain management training at UCLA, a trained anesthesiologist now turned wellness specialist, overall wellness, resource speaker to various medical and non-medical groups. This symposium is brought to you by Bayer and is moderated by Chairman Dr. Myla Gloria Supe, Head of the Section of General Cardiology and Miscellaneous Services of the Philippine Heart Center, Training Officer of the Division of Clinical Cardiology at the Philippine Heart Center, Past President of the Philippine Society of Echocardiography, Fellow of the Philippine College of Physicians, the Philippine College of Cardiology, and the Philippine Society of Echocardiography. Once again, reminding everyone that questions will be entertained when all lectures have been delivered. Thank you.
Good evening. Tonight, Bayer proudly presents superior stroke protection for the elderly and high-risk patients with atrial fibrillation. Here is our moderator. She is a consultant in cardiology and echocardiography, the training officer of the Division of Clinical Cardiology at the Philippine Heart Center, section head of General Cardiology and Miscellaneous Services in the said institution, and past president of the Philippine Society of Echocardiography. Please welcome Dr. Myla Gloria Supe.
Good evening, everyone. My name is Dr. Myla Supe, and I will be your moderator for this webinar. Thank you so much for joining tonight's event, and I wish that everyone is having a great and healthy month so far. Despite the pandemic, I'm glad that we, the healthcare workers, can still get together and continue to learn for the sake of our patients. I take great pleasure in welcoming the doctors from all over the Philippines for this PHA Bayer-sponsored virtual lecture. Protection is a broad term for atrial fibrillation patients. Protection can mean prevention of stroke, reduction of bleeding events, or even preservation of other functions, given that patients are usually multimorbid and have multi-organ involvement. Aside from this, we have practical considerations such as dosing and adherence to medications, aspects that may be especially relevant in these times when patients no longer follow up regularly. Therefore, our experience has shown that treating atrial fibrillation patients is complex and may even require multidisciplinary participation. Given that NOACs have a mechanism of action that naturally inhibits coagulation, it is evident that efficacy and bleeding are at the heart of our decision-making as physicians. The saying goes that we do not see the strokes that we prevent, only the bleeds that occur. Hence, it is very important that we have a discussion on how to best protect our patients by balancing the risk of stroke versus that of bleeding. How can we protect the vulnerable now that our attention is divided between COVID and non-COVID cases? For tonight's event, our speaker will share with you the latest evidence on rivaroxaban for protecting and ensuring the safety of AF patients. The lecture is entitled, How Can We Protect Our Elderly and Our High-Risk Patients from Stroke? Also, we have something new for tonight. We understand times are challenging nowadays and we deserve a little rest for ourselves. We will also have a second lecture with Dr. Lulu Marquez, who will talk about romance in the elderly. Without further ado, I would like to introduce our first speaker for tonight's event. It is my pleasure to call our speaker, Dr. Teo Wee Xiong. He is a senior consultant in cardiology and electrophysiology, the Heart Specialist Clinic, a member of the Civil Aviation Medical Board, and an international advisor for the Journal of Arrhythmia. He is a cardiologist with about 25 years of experience in the field and provides specialized care in electrophysiology and pacing at his clinic at Mount Elizabeth Novena Hospitals. He graduated from the Faculty of Medicine at the National University of Singapore and underwent basic training and obtained his postgraduate qualifications and had a one-year Health Manpower Development Program Fellowship Award. He also trained in cardiac electrophysiology and pacing in Ontario, Canada, and was inducted as a Fellow of the Academy of Medicine, Singapore. Prior to establishing his private practice, Dr. Teo was a senior consultant in the Department of Cardiology at the National Heart Center, Singapore. During his tenure, he served as the Director of Electrophysiology and Pacing and currently remains as a senior consultant and senior advisor for the electrophysiology and pacing at the National Heart Center, Singapore. Dr. Teo's commitment in his field extends beyond his clinic and patients. He has been a member of the Cardiac Electrophysiology Society and was elected Fellow of the Heart Rhythm Society since 2006. He is also the organizing chairman of the first Asia Pacific Heart Rhythm Society Scientific Session. Locally, he chaired the Ministry of Health Singapore Clinical Practice Guidelines Committee for the Management of Atrial Fibrillation and is a member of the Clinical Practice Guidelines Committee for Heart Failure as well as stroke and transient ischemic attacks. He is also the chairman of the Singapore National Resuscitation Council and a chief instructor of the Advanced Life Support Program. He is a widely published cardiologist with over 30 international journals and numerous local journal papers to his name, and has authored more than 10 book chapters. For his dedication, Dr. Teo has received Service Quality Award from Singapore General Hospital, as well as the Public Administration Medal on National Day and the Service Quality Bronze Award from the National Heart Center Singapore. So everyone, please welcome Dr. Teo Shaw.
Welcome. Thank you very much to Dr. Myla Supe for the kind introduction and to the Philippine Heart Association for the invitation to give today's talk this evening. It's nice to see everyone, although it's on Zoom. And today we will be talking about how can we protect our elderly and high-risk AF patients from stroke. As you all well know, stroke is a big problem, especially in our elderly patients. And we have to be very careful about how we manage them. First of all, we'd like to define what exactly are elderly. If we go by the WHO definition, it was 65 years old, but you know, with our rapidly aging population, 65 is no longer considered as old. In fact, it's considered relatively pre-old age by the Japanese Geriatric Society, which, as you all know, have got a very large aging population. And in that definition, they have used 75 years and above as old age and age over 90 years as the super old. Why is it important? Well, as we all know, whether we like it or not, there's always age-related organ changes, and this will affect the drug pharmacokinetics. So there are physiological changes both in the GI tract in terms of decreased mobility, decreased absorption. There is also the body composition. Usually the body mass tends to decrease. Then there's also decrease in the serum albumin. In terms of the liver too, there's decrease in hepatic blood flow. And most importantly, in terms of the kidney, there is decreased renal function, decreased glomerular filtration rate, and hence impaired elimination of the drugs. In terms of the prevalence of atrial fibrillation, is it important? Definitely. In fact, since the late 1990s and the early 2000s, data from the Framingham study clearly shows that atrial fibrillation increases with age. And classically, it is well known by about 80 years old, 10% of the patients would have atrial fibrillation, and the incidence was slightly higher in men compared to women. Is this true in Asia? Well, data from our colleagues in Taiwan clearly shows a very similar pattern. And in fact, they showed that in patients who are 90 and above, the incidence of atrial fibrillation increases significantly. Why is it important? Because, well, it shows that AF is now by far the greatest and the growing challenge for all doctors who look after patients with cardiac arrhythmias. And in fact, it has been estimated that about 1 in 4 to 5 people will develop atrial fibrillation. Importantly, the importance of AF as a causing stroke is very important. So you can see, for example, atrial fibrillation may not be so important in the younger patients, but in the 80 to 90 years old, as much as 1/4 of strokes are due to atrial fibrillation. So this is very, very important. And the mean annual rate of stroke in AF patients not treated with anticoagulation is at least about 4.5 to 5%. Thus, untreated, they present an even greater burden to society in terms of having increased morbidity and morbidity from the stroke. It is clearly shown that the thrombotic risk increases with aging. So in our well-known CHEST-VASc score, once you have a person whose age is more than 75, straight away it is a greater or equals to 2 or greater or equals to 3 for females. And all these patients should be considered for anticoagulation, and it is a class 1A indication. And you can see that beginning with a NOAC is now the default choice as shown by the 2020 ESC guidelines for the management of atrial fibrillation. This slide again is just a reminder of what I've said earlier on, in the sense that the incidence of strokes in the 80 to 90 years old, you can see atrial fibrillation is by far the most important cause of stroke. Is it true too in Asians? Is stroke a very important problem in Asians? This is data collected from both Sweden, Taiwan, and Hong Kong, clearly showing that, in fact, for Asian patients with a similar CHEST-VASc score, the incidence of stroke is in fact much higher in Hong Kong and Taiwan compared to that of Sweden. So I'm not sure why in this particular study from Hong Kong, they have such a high incidence of stroke. What is clearly also very important too is you can see that in patients who have CHEST-VASc1, which in the American guidelines say that, well, you may not straight away start with NOACs, but in this Asian cohort, you can see that the stroke rate was in fact quite high, and hence it is important for us, even in the CHEST-VASc score in our Asian population, to seriously consider these patients to be started on anticoagulation therapy. However, the main problem is that intracranial hemorrhage also increases with age. And you can see in this slide here that, which is an old slide, but you can see that, for example, once you hit 80 to more than 85, incidence of intracranial hemorrhage increases rapidly. And thus, it is important for us to assess the risk of bleeding in this group of patients. Obviously, intracranial hemorrhage is a disaster when we are trying to prevent a stroke in this patient. This slide similarly shows that there's incidence of ischemic stroke, intracranial hemorrhage, major bleeding, mortality, and adverse events are definitely not low in the Asian populations. So clearly, all these problems, which have lots of studies in the West, is also clearly present in our Asian population. However, similar to the experience in the West, you can see that there is a huge problem, because we know clearly that the incidence of stroke increases with age, but because of the problem of bleeding, because of the problem associated with aging, there is the use of warfarin in the past was clearly very, very much reduced of what it should be. So this is now the challenge that we all face. Should we continue with anticoagulation in this high-risk group of patients? And if so, how can we mitigate the risks associated? In the past, people used to think, well, aspirin, well, maybe aspirin is just as good. And this was clearly, however, been shown to be inferior in the BAFTA study, which is the Birmingham study of the aged patients, which clearly showed that even the use of warfarin was better than that of aspirin. There were also trials that were done, the so-called active trials, where a combination of aspirin and Plavix were used. And this again were clearly shown to be inferior. And more recently, with the use of NOACs in the AVROS study, again clearly showing that even in older patients, the use of apixaban, which is one of the NOACs, is clearly superior to that of aspirin. However, as we all clearly know, there are marked problems and disadvantages, and that was the reason why a lot of doctors are unwilling to use warfarin. Why? Because there's a higher rate of bleeding, including intracranial hemorrhage. Multiple relative contraindications. These patients are frail, they tend to fall. Multiple drug interactions, very difficult to maintain the INR. They take an NSAID, they take a traditional medication, and clearly the INR will go crazy. And of course, there are multiple drug interactions, which is well known. Hence, in reality, there was a low percentage of the patients which were started or maintained on warfarin. And this, of course, is clearly shown by the study by Halleck et al., which clearly showed that the cumulative incidence of major bleeding in the 80 years and above was definitely higher in patients who were on warfarin. And again, here too, showing that intracerebral hemorrhage and subdural hemorrhage are clearly higher. Thus, clearly there is a great challenge whenever we want to start anticoagulation in the elderly. And here is an old slide by showing that all sorts of reasons here. Patients are higher fall risk, patients have peptic ulcer because they're staying alone, they have some anemia, they have history of bleeding, dyspepsia, and of course, a large amount of patients, once they find out that warfarin is rat poison, will also says that, no, I don't want to take this rat poison. So this is well known to a lot of the patients. This is also a challenge. This is in fact a patient here, 88 years old, had a sick sinus patient with pacemaker in 1999, had paroxysmal atrial fibrillation, so was on warfarin anticoagulation because this was before the era of NOACs. And in fact, I did discuss with the patient about using NOACs once it became available, but the patient felt comfortable and was using the NOAC. However, he had an episode of illness, his INR became bad, and then he became a little bit confused, and the family did not bring the patient in until he was quite sick, and then we discovered that in fact he had a big cerebellar hemorrhage, and the patient subsequently died. So for about almost 16 years, he was well controlled, but this just shows the challenge that these patients, when they are on prolonged anticoagulation, that significant complications can and do occur. Well, fortunately, there have been the development of NOACs, and all of us were waiting for it in anticipation. It had a much more predictable pharmacological profile, a much more rapid onset of action, so it worked very quickly. Wide therapeutic window, you do not have to monitor very carefully, like the INR, and there was no requirement for that. And they were, of course, initially felt to have far fewer and better defined food and drug interactions. You can see that in the main NOAC trials, and there were 4 of them, the Aristotle, the Engage AF, the Rely, and the Rocket AF studies, all these clearly showed that stroke and systemic embolism were much more reduced. And interestingly, if you look at it, there was a significant number, as much as 40, and in the Rocket AF, 44% of the patients were more than 75 years old. In terms of the efficacy of NOACs versus warfarin in this elderly group of patients, you can see that there was no significant difference in terms of the efficacy of reduction of stroke or systemic embolism. And in terms of major bleeding, there was definitely less, although in the older age group, there was some suggestion that it was not statistically significant, but definitely there was a trend in terms of reduction of major bleeding. So in the meta-analysis of all these various NOACs, there was clearly improvement in the use of NOACs when in preventing stroke or systemic embolism and major bleeding. This is a summary slide, very busy slide, showing that for all the various NOACs that are available, strokes and systemic embolism, major bleeding, and intracranial hemorrhage are generally less. It is very difficult to really compare. There seems to be slight differences, but unfortunately, because there are no head-to-head studies that exist, thus direct comparison is very difficult for us to be made in between. So one has to be careful when you look at the different comparisons, and you have to look at the individual drugs carefully. There have been some specific studies. If you look, for example, at the Rocket AF subgroup of more than 75 years, you can see Definitely stroke and systemic embolism is less. Major bleeding appears to be slightly increased, but this is not statistically significant. Definitely fatal bleeding was much less, and intracranial hemorrhage, there was a tendency for it to be less. Does this exist in the real world? This is a very busy slide, but what I attempt to show is that if you look at the real world and if you look at the randomized controlled studies, they are both trending the same in terms of risk of stroke or TIA, and in terms of risk of major bleeding, there is a suggestion there is a reduction both in the randomized studies and in the real world studies. It's a study looking at anticoagulation. Is a registry in the real world looking at the use of NOACs in the elderly patients, and clearly again showing that major bleeding and ischemic events are reduced. Here you can see major bleeding is less with the NOACs, and here again ischemic events are less. Thus, there is a net clinical benefit of using NOACs in the elderly patients. Looking specifically at the rivaroxaban, there was clearly odds ratio reduced, and in this particular study, it was significantly reduced in terms of the net composite endpoint of major bleeding and ischemic cardiovascular events. In the real world, another real world study too, looking at patients who are aged more than 80 years and above, you can see that stroke and systemic embolism, ischemic stroke, hemorrhagic stroke, intracranial hemorrhage, all were reduced. There will always still be bleeding. I mean, NOAC is still an anticoagulant, and thus we still have to be very careful that these patients may still bleed, and thus it is important to watch out for bleeding in all patients who are on any anticoagulation. This is a paper here, again now from Taiwan, looking at NOAC anticoagulation in patients who are more than 85 years old. This is from the Taiwan National Registry, 15,000 patients, again clearly showing that the NOACs, especially rivaroxaban here, showing reduction in all the events, including mortality and adverse events. What about even in the 90 years old? And this is a nice paper from Dr. Chow from Taipei, and he clearly shows again that even in this very elderly patient, although there's not that much difference in terms of ischemic stroke, intracranial hemorrhage is definitely less, and bleeding appears to be slightly lower, although not significantly lower. In general, older patients have generally significant benefits in terms of ischemic stroke. You can see that this benefit is even seen in the age 90 years old, and major bleeding is also seen in the very elderly patients. Thus, we can see that when we look at NOACs and the disadvantages and the advantages, you can see that the NOACs are effective or better than warfarin for stroke prevention. And this is clearly shown also in the elderly subgroup. Clearly, I think the advantage of reduction in intracranial hemorrhage is demonstrated in all the studies. It is easier to use because we can see an onset of action is very fast, and it is much more predictable response. It has a much more wider therapeutic window. You don't need to monitor these patients so closely, and this is very relevant, especially during this pandemic where the patients have trouble coming to the hospital. In terms of drug interactions, also much less. And of course, there is increased convenience because they do not need to come and monitor the INR closely. Of course, there is some slight disadvantage. We cannot be 100% sure that the patient is compliant because we can't monitor. Of course, it is possible, but not easy in the sense that we can measure the drug level or to measure the anti-factor 10A effect, but these are not readily available and not routinely used. They are still sensitive to changes in renal function, and I will emphasize upon this later on. And of course, as I've emphasized too, these are anticoagulants. We have to inform the patient that they still can bleed, but a lot of this bleeding are not that significant, and there is no that the prevention of stroke far outweighs that of the risk of bleeding. In terms of an antidote, this is no longer true. There is an antidote for rivaroxaban, and there is an antidote for dabigatran, which is now available. There's another patient of mine that which actually was a doctor's mother, and as you all know, doctors' parents are often the most difficult to see. First saw in 2012. At that time, she was already 79 years old, history of hypertension, had paroxysmal AF going into permanent AF, and her CHEST-VAS score is 4, clearly indicating the need for anticoagulation. Subsequently, also found clearly to have some coronary artery disease. But what was interesting was that she also had a history of ischemic colitis with bleeding and also peptic ulcers. One would be, thus, because of those, I started with a low dose of Xarelto, 10 milligrams first, but subsequently found that she remained stable. I did increase it to a 15 milligram since 2013, and I just saw her a couple of months ago, and she remains quite well. So I think, yes, I'm not upset if the doctors start on the lower dose, but they need to titrate the dose and monitor the patient regularly to see if whether the low dose is inappropriate or an appropriate dose for the patient, and then increase it to what is the appropriate dose. Thus, in the anticoagulation of our elderly patients, we need to consider several factors and see how we can protect them from further complications. For example, we need to assess their bleeding. We need to assess their renal function. Of course, concomitant heart failure can affect the status of the patient, frailty, fall prone. Cognitive issues are very important in terms of drug compliance and adherence. And of course, multiple drug interactions remain still important. And we're beginning to realize that there are some drug interactions and we have to be a little bit careful. How do we prevent them? Since preventing stroke remains the primary priority, we need to mitigate the risk of bleeding. We need to monitor the renal function and try to prevent worsening renal function. We need to optimize the dose, and we need to try to make sure that there is good adherence to the drugs. Well, in terms of the factors to consider, generally, if the renal function is really bad, you should avoid it, especially in dabigatran, which is renally excreted. For the renal function, once it is 15 to 49, you have to reduce the renal. You have to reduce the dose slightly when you are using rivaroxaban, but generally for all the drugs, you have to. Here, I would like to say that although this slide suggests that there is no drug interaction with rivaroxaban, be careful for those of you. I'm not sure if Maltec or dronedarone is still available for use in the Philippines, but if you are using dronedarone or Maltec, you may have to be careful and use a lower dose as well, because there is a drug interaction in the sense that the rivaroxaban may have a higher blood levels if that is measured. In terms of weight, generally there is no reduction necessary for rivaroxaban, although for apixaban, if the weight is very low, you may need to consider a lower dose. And if the patient is very old, there is a consideration of a lower dose. Generally, age alone is not that important in rivaroxaban, but of course the renal function will be affected by age. Thus, in our elderly AF patient, we need to very carefully look at the bleeding risk, look at the comorbidities, and try to improve the adherence. And at the same time, look at the cognitive impairment, if any, risk of falls, if any. This slide shows that the incidence of major bleed is not low. But in general, clearly, if you use NOACs, the risk of major bleed is lower when compared to that of warfarin. This is a study called the Sapphire study, where they look specifically at the use of rivaroxaban and bleeding in elderly patients who are more than 80 years old. So you can see that these are very old patients, a mean age of about 86 years versus that of warfarin. And they will follow up for about 12 months you can see that major bleeding was significantly lower, intracranial hemorrhage was significantly lower, stroke was lower, and mortality trended to a bit low, although it was not statistically significant. This is another study just published too, looking at rivaroxaban at 1 year, where in terms of the major bleeding clearly reduced, fatal bleeding clearly reduced, intracerebral hemorrhage clearly reduced, gastrointestinal bleeding slightly reduced, but not a lot more reduced. But definitely, as I've said, patients can be prone of bleeding, and we will have to watch out for GI bleeding in this group of patients. In terms of fatal bleeding, however, you can see that clearly for rivaroxaban, the incidence of major fatal bleeding is much more reduced compared to with similar comparisons to all the other NOACs. In terms of intracranial hemorrhage, I think clearly the studies have shown in all the studies, intracranial hemorrhage is clearly reduced. So if you want the patient to have less risk of intracranial hemorrhage, a NOAC would be a definite choice. As we all know, Asians are particularly prone to NOACs, to intracranial hemorrhage. And this is a study clearly showing that the incidence of intracranial hemorrhage is reduced in patients who are on NOACs, any of the NOACs when compared to warfarin. And in fact, again, a study from Chow et al. From Taipei showing clearly that the intracranial hemorrhage reduction benefit of NOACs was much greater when compared with warfarin. So when we are managing patients, we need to assess what is the patient's bleeding risk. So we need to look at the patient's age, any history of bleeding events in the past, whether the patient is using any antiplatelet agent. This, I find, is a very common problem because a lot of doctors will say, oh, the patient has already had a stent, but if the patient does not require antiplatelet, we should avoid a combination of an anticoagulant plus antiplatelet. The only indication will be patients who have an acute coronary syndrome or just had a stent implanted. Otherwise, especially once they are 6 months to a year further on, they should no longer be on double antiplatelet agents and an anticoagulation. Importantly, the patient's hypertension, we need to monitor to see if they are controlled. We need to monitor if they have any renal impairment. And of course, alcohol needs to be reduced. And this is clearly said in the ERA guidelines. This is just published from the ESC guideline, clearly showing what we call modifiable and potentially modifiable factors. So clearly, by controlling hypertension, by preventing the use of concomitant antiplatelets or NSAIDs, excessive alcohol intake, all these will prevent risk of bleeding. And of course, if the patient have got, and then of course, the important thing is also the appropriate choice of oral anticoagulation and correct dosing. Certain other potentially modifiable factors would be that of renal impairment, extreme frailty, reduced platelet count, then you may want to use a reduced dose of the oral anticoagulant. However, it is clearly emphasized that high bleeding risk alone is not a reason to withhold anticoagulation. I think a lot of times we are all, of course, only very worried that if the patient do get a bleeding, the relatives will be upset with us, but we have to explain to the patients beforehand, before they get any, even mild bleeding, that the aim of the anticoagulation is to prevent stroke and severe morbidity, but mild bleeding is not that uncommon and they can be modified and preventable. Thus, clearly, although we look at the Hasbled score to look at the risk of bleeding, it is not a contraindication to give them anticoagulation, and it is always recommended that the patients should always be considered for oral anticoagulation. So it is important, as I've said earlier on, that we need to monitor the renal function. We should always monitor the renal function before we start any anticoagulation, and especially if there are changes in medications or if the patient have got some recent illnesses. In these cases, we may again need to monitor the renal function, and generally, even in the well patients, I will monitor the renal function at least every 3 to 6 months. This clearly shows that with age, there is a deterioration of the creatinine clearance, and this is just part of the physiology of life. But what is something relatively recent data is that there was some suggestion that the vitamin K antagonist will promote medial and intimal calcification. Well, the mechanism is not completely known, but it is known, however, that when this occurs, this calcification in the arteries, especially in the renal arteries, will result in worsening of the renal function. And studies have shown that patients who have been on long-term anticoagulant, if you follow them up to 3 to 5 years, you will see that they have a significant worsened renal function compared to those who did not have any exposure to vitamin K antagonists. So in this study, that was reported, clearly it shows that the use of drugs such as the rivaroxaban seems to have a little bit of protection in terms of the rapidity of the decline of renal function. So acute injury, kidney failures appear to be slightly lower when we use NOACs. Thus, in the study called rivaroxaban was clearly shown to be associated with a reduction in acute kidney injury and progression to stage 5 CKD on requiring dialysis. And in patients with atrial fibrillation and diabetes mellitus, there was some suggestion that there was a lower risk of renal decline when the patients were on rivaroxaban when they were on warfarin. So clearly, again, showing that we should definitely, if the patient already has got some suggestion of early renal dysfunction, that the use of the NOACs are clearly indicated. What is the possible mechanism? Well, not very sure, but there is a suggestion perhaps there may be an anti-inflammatory effect. Or, of course, the other possibility, it is because actually warfarin is causing more damage than if you did not use any warfarin. Thus, in terms of patients who have elderly, who are more than 75 years old, clearly up to CKD stage 3, there are meta-analysis and randomized controlled trials which shows that the NOACs are useful in terms of prevention of bleeding, and also there is, most importantly, there appears to be a slowing of the deterioration of the renal function. When it comes to CKD stage 4 and CKD stage 5, although there are some guidelines suggesting we may use certain NOACs, there are no clear randomized controlled clinical trial data on this group of patients yet. And here you can see that at this point in time, anyone who has less than 30, dabigatran definitely should not be used. If the creatinine clearance up to 15, then in this group of patients, one would use a lower dose of rivaroxaban, endoxaban, or apixaban in this group of patients. Below 30, I think it is still contraindicated, and unless you have very strong reason, you should be very careful when you are using any of these NOACs. What about the frail patient? I think intuitively, most of us would be very worried when we meet a patient who is quite frail. But this is from the 2021 practical guide on the use of novel or non-vitamin K antagonist anticoagulation. You can see there's a table here that looks at mildly frail, moderately frail, and severely frail. One can also consider the use of oral anticoagulation in this group. And in fact, they have come up with the statement that frailty, comorbidities, and increased risk of falls do not outweigh the benefit of oral anticoagulation, given the small absolute risk of bleeding in this group of patients. And the studies support the use of oral anticoagulation even in this group of patients who are frail. What about patients who tend to fall? And this tends to be the elderly patients. Definitely falls is always something very important. And I do have patients who, once they have had a fall or two, the relatives will say, oh, no anticoagulation. It's very difficult. We have to respect the family's decision. But at the same time, of course, we have to counsel them that actually, unless they have recurrent intracranial hemorrhage, one actually could continue with oral anticoagulation. There is an example of a fall risk assessment published in the practical guidelines where you look at the risks and gives a score and see from there what is the probability these patients will develop falls. And then we'll decide whether these patients can or cannot be continued on anticoagulation. In fact, there was a paper many years ago, this published, which actually stated that one could fall for about 295 times in a year, and yet you can continue warfarin. I find this paper very interesting, but very hard to practice in reality. I don't think any relative will allow you to have the patient fall 250 times and yet allow you to continue warfarin. So this is an interesting paper, but challenging for us to implement. This is a more recent paper that looked at elderly patients with a history of fall. And clearly, yes, if there is recurrent prone to falls, the risk of intracranial hemorrhage is higher, 2.8% in patients at high risk of falls and 1.1% in other patients. However, if the patient's chest VAS score is 2 or higher, and I think here maybe I may even use 4 or 5 or higher, definitely one should argue that these patients will need anticoagulation. And of course, at the same time, make sure that these patients' environment and home care is such that they are less prone to be developing falls. Finally, of course, there's also the problem of adherence. As poor adherence will of course lead to higher stroke rates. And there are many reasons why there may be adherence. One could be that the cost is not, it's not in this slide, but definitely cost is an issue. And even in Singapore, I mean, I have patients who will tell me, oh, you know, I have to take this drug. It costs me about $5 to $6 Singapore dollars a day. Not that high, but still it is not a small sum for the poorer patients. So here, I think it is very useful and important for the government to help subsidize the cost of this medication. The other problem, of course, is also timing of the doses, size of the tablets. These are other frequency of the doses. These are all other things that are important when we look at these patients and ask them to be compliant with medications. And it's a study that shows that clearly, if you have a once daily drug, the compliance is much better. And I have, in fact, patients that told me, oh, I've been taking the patient twice a day, but actually I feel very well, of course, because they haven't had any stroke yet. So, but because I feel very well, I decided I will take it once a day. Clearly, cost was not an issue in this patient, but they felt that, you know, since I feel well, perhaps I should cut it down to once a day. Here, we really have to explain to the patients that this is not how the drugs work. That if you take the drug, in those drugs that need twice a day, the pharmacokinetics is such that you do need to take twice a day. So clearly, you have to use, in this group of patients, a once a day drug, and then the compliance will be much better. This is from the practical guidelines showing how we can try to improve optimal compliance to the drugs. Here, involvement of the family, the caregivers are very important. They need to give the drugs. I often tell my patients, please use a pill box, because no matter how, I'm sure even you and I will tend, when we are taking medications, we may tend to forget a bit. We need to educate our patients. The pharmacists who dispense the drugs will be very useful, because they'll say, how come this patient always never need to buy more of the drug? Obviously, they must not be taking the drug. And perhaps technology in future will help us track whether these patients are truly taking the drugs. And the once a day versus twice a day is always helpful in terms of improving optimal adherence. In terms of dosages, you can see actually there are many different dosages possible with the different drugs. But fortunately for rivaroxaban, you can see that it is fairly simple, mainly looking at just the adjustment is mainly due to that of the creatinine clearance. If the creatinine clearance is low, very low, avoid it. If it is reduced, if it is reduced, then you just adjust the drug to a 15 milligrams dose. And here you can see again summarized here, if there is less than 15, not recommended, 15 to 49, 15 milligrams dose, more than 50, 20 milligrams dose. Here I would like to say that there is some data from the Japanese, however, where they use the J-record data. For them, they have adjusted 10 milligrams and 15 milligrams. But this, of course, you have to look at your patient carefully, whether they are similar to the Japanese cohort. In terms of use of, we have to be very careful because whenever you use a reduced dose of NOAC, although clinically seems to be logical, you have to be careful that if you are not careful, then using an inappropriate low dose may increase the risk of stroke and systemic embolism. So you have to be mindful that inappropriate underdosing is not going to be beneficial. And there have been studies that showed that there was not that much in terms of a bleeding benefit as well. Thus, overall, one has to be careful when one is using reduced dose. So how do we mitigate? In summary, you can see reducing the risk of stroke, reducing the bleeding risk, monitoring the patient, reducing non-adherence, and when you need to reduce the dose, reduce it appropriately are very important when we are dealing with the elderly patients. If we do mitigate all these, modify all these risks, if we do prevent the bleeding, if we do improve compliance, definitely there have been studies to show that this group of patients, there will be a better outcome. But if you do not modify them, then of course there is increased major bleeding, increased risk of complications. But in the ESC 2016 recommendation already clearly they have showed that elderly patients are at higher risk of stroke and thus are more likely to benefit from oral anticoagulation than younger patients. And considering the risk of stroke and the morbidity of stroke, it exceeds the risk of bleeding in this group of patients, even in the elderly patients. And in the 2020 ESC guidelines, the ABC pathway, the most important thing is to avoid stroke. And how do we do that? We look at the thromboembolic risk. The higher the risk, the highest, the more important it is for us to start anticoagulation. Remember to evaluate the bleeding risk and not just evaluate, try to mitigate and reduce the bleeding risk, and also look at the other patients' comorbidities such as their renal function, such as frailty, and try to reduce the risk of complications with the use of anticoagulation. Better symptom control is basically rate rhythm control, but I think in the elderly patients, most of these patients fortunately do not have that much symptoms. And yet it is challenging because they do not have much symptoms. Rate control is easy, but a lot of them may not want to have anticoagulation. So we have to explain to them that. Importantly too, I think this is very important. The prevention and the management of concomitant risk factors is very important to reduce the AF burden if they are still in the paroxysmal phase of atrial fibrillation. Finally, I'd like to talk briefly that we need to screen patients for atrial fibrillation. Too often we see patients who develop atrial fibrillation comes in with a stroke. So opportunistic screening for AF is very important. And this is where patient education of our colleagues to look for atrial fibrillation, such as pulse palpation, short-term ECG monitorings, and of course, importantly, the new use of technology, they are now able to monitor atrial fibrillation much more easy. And in fact, monitoring of atrial fibrillation is a class 1 indication. This, for example, is one of my patients nowadays patients are very smart. They come with smartwatch, they come with the phone, and you can easily document atrial fibrillation in this group of patients. So more and more, I am seeing patients that come to me with wearables, and they are able to show you that they have clearly atrial fibrillation. And this is a pub study that has been just published, screening for atrial fibrillation in the older population. And here they find that 2 weeks continuous ECG monitoring clearly was much better than intermittent monitoring. I think the wearables will definitely revolutionize, and I do encourage those, but of course, cost is a factor, and hopefully there will be cheaper phones and smartwatches so that we can monitor more of our patients. Thus, in summary, there is a greater clinical benefit with rivaroxaban versus warfarin, as demonstrated in the elderly versus a non-elderly in the ROCKET AF study. The ABC pathway can help to reduce the bleeding risk without the need for excluding oral anticoagulation prescription. We need to treat the modifiable risk factors. We need to monitor them. Rivaroxaban appears to be highly effective and provides a reassuring safety profile and kind of convenience of once a daily use in our AF patients in the real world. Thus, I'd like to conclude that clearly elderly patients have a high risk of stroke and major bleeding compared to the younger patients. There's a positive risk benefit of NOAC patient, and this is seen clearly in the elderly patients. And if the data from Taiwan supports it, it's also shown elsewhere, clearly the risk benefit is even higher in this group of patients. Bleeding risk, especially the major bleeding and intracranial hemorrhage, is substantially lower, but I always say that a NOAC will still cause bleeding, so we will often have to tell our patients beforehand that yes, bleeding can occur, but it is not life-threatening and it's not as bad as getting a stroke. NOAC definitely need less monitoring, and there is consistent benefit is seen even in the elderly, but we need to try to mitigate the risk by monitoring the renal function and giving the appropriate dose. Thank you everyone for the attention, and hopefully we will be able to see one another again once the pandemic is over. Thank you.
All right. So, everybody, thank you very much for that wonderful presentation from Dr. Teo. I like the fact that he defined what old age is, what is pre-old, and now the super old. No? And as one of my mentors in cardiology used to define geriatrics, no? Dr. Ramon Abarquez would always say, anybody who is older than him, then that is geriatric. No? That is a super old. So we don't have much time for Q&A. So, but we have a lot of questions coming in our chat box. And let us start by one from one mentee to another. So we have one of the former fellows of Dr. Teo, Dr. Jonna Amora, who's asking, what is the approach for patients who have a bleeding event in one NOAC? Will you reintroduce the same NOAC at a lower dose, or will you switch to a different one?
Oh, thank you for the question. Well, I think the first thing is to see whether is it a major bleed, is it a life-threatening bleed. I mean, a lot of the minor bleeds, we do not need to do anything. We just need to reassure the patient. I may go down to a lower dose for a short while, and then depending on the chest VAS score, go up back to the full dose after we have reassured the patient that this is not life-threatening. If it was a major bleeding, for example, if the patient had a bleeding GI, then the important thing would be to find out what is the cause of the bleeding. In some of these patients, actually, it is the beginning of a gastric malignancy. It's a colon, CA colon we have detected for the first time. Then, of course, they need this to be treated. And in fact, I have quite a few patients, and this has already been reported, that GI malignancies may be detected or even urinary malignancies are detected. So it depends on where the bleeding. The worst case, of course, is the intracranial hemorrhage. There, in that case, you have to decide, can this patient go on a NOAC, or do you go to non-pharmacological therapy such as a left atrial appendage occlusion device. But I think I generally try not to switch one to the other because there's very little difference between one and the other. There are slight reports that maybe rivaroxaban slightly higher GI bleed, but again, these are not really good comparison studies. I will tend to use the lower dose. I sometimes use the lower dose. As you all know, the J-Rocket study of in Japan, they use the 10 milligrams and 15 milligrams. So I do sometimes use the lower dose, especially if there's some minor bleeding in the patients and the chest vest score is not very high. I hope that answers your question.
With that, we also have a lot. We are a very filial country, no? So we love our parents very much. We love our grandparents very much, and we do not want them to suffer. So, however, this is and I think we also see this in your society, in your country. The tendency of doctors not to be scared of giving the full dose because of the frailty or because their grandparents are old. Okay, but you mentioned in your talk that age is actually not a consideration. It's mostly the renal function that matters, no, among these patients. So how do we deal with this? Because it is quite a common practice, no, that patients would actually, so doctors already prescribe the lower dose most of the time. That's actually a very common practice. But patients would actually even lower the dose even more. So how do we deal with this? And will this be actually safe? Is this a safe practice, both from the in its effectivity and in its safety?
I think this is, like you say, a difficult thing, but I think we have to assess the patient as a whole. There are some old patients who may be 90 years old, but they are very fit. Their weight is still not, they're not very, very low body weight. Of course, we have the old grandmothers who are very, very frail. They are like 30, 40 kilograms. Definitely, we should go down on a lower dose. There is some controversy. I mean, the general consensus is that we should use what is the dose that were done in the studies. But there are some papers that suggest that if we use low dose, the stroke and systemic embolism is slightly higher, the bleeding risk is lower. But there are also some papers from the Japanese and from the Koreans that have shown that even at the low dose, they do not seem to have that bad result. And also there's a paper from Jan Staffel in Europe. They also showed that the low dose apixaban did not have that adverse effect. So I think no one really knows at this point in time. We still have to do our clinical judgment. But I would say that do not just use low dose for everybody. You have to get, for some patients where you think that the chest vest score is very high and the bleeding risk is not that high, you could try to go on a slightly higher and conventional dose.
Okay. I hope our audience would take note of that. Now, there's also another question about kidney function. So you mentioned earlier that while age and weight is not really a consideration, but the kidney function is definitely one of the concerns. Is there such a thing as a safe NOAC for patients with kidney disorders or kidney dysfunction? And what can you say about the use of NOACs in patients who are undergoing dialysis?
I think there's some preliminary data. There's no big randomized controlled trial. That's why I stayed out of the controversy. But there are guidelines which are suggesting that you could use apixaban. Rivaroxaban in lower doses have also been suggested. But I think we really need much more data in this group of patients. So until the big studies are done, I think that we have to be very careful. Recently, a meta-analysis of warfarin have showed that there was really no clinical benefit, net clinical benefit in using anticoagulation in this group. These are very frail patients. We have to be very careful about this group of patients. So I
You
think
mentioned
I don't think there's a definite answer yet.
And you mentioned in your presentation about the possible renoprotection of rivaroxaban. Is this something which is a class effect, or is this something that we see specifically for the molecule? Or is it just the reason why we're seeing good results with your Novax is because warfarin is really bad for our kidneys?
Again, I think your point is correct that probably it may be that the warfarin is bad for the kidneys. There is some suggestion that the factor 10A has got some anti-inflammatory effect. We can't be very sure, but that's the hypothesis. But clearly in the patients who have mild renal dysfunction, the NOACs are better than the warfarin in this group of patients.
So, is there any other benefits that rivaroxaban can offer our patients on top of its stroke prevention?
I think the once a day thing is very useful. Compliance is much better in patients with rivaroxaban. And so I find it much more useful. And the other interesting data is that the rivaroxaban has got more in terms of the coronary artery disease group of patients, the rivaroxaban, both in terms of peripheral, but usually, of course, this is a lower dose, but there has been no signs that rivaroxaban has got higher incidence of myocardial infarction or other things. So I may avoid the dabigatran group of drugs in this group of patients because the data in terms of cardiac protections, as you all know, when dabigatran first came out, there was some suggestion that myocardial infarction may be slightly higher. Subsequently, there was no, and subsequently there was yes. So I think the data is a bit murky there. So I tend to avoid that group of drugs. And I tend to go on to the factor 10A, where there seem to be good data consistently across the board. All of them didn't have that much problem. Maybe it's just specific to the dabigatran. We need to have other studies from the direct thrombin inhibitors to see how it goes.
Okay. There's another question here regarding the safety and efficacy of rivaroxaban and their consistency with randomized control trial data, as well as versus that of your real world data. Can you comment on that?
I think I've showed some real world data studies and some of the sub-study analysis of the rocket, and clearly there is consistency. There is clearly consistency that there is much less bleeding in terms of intracranial hemorrhage, and the efficacy for prevention of stroke is at least as good as warfarin. Maybe not superior, but at least as good as good warfarin anticoagulation. So there is really no question that in the Asian population where we have higher incidence of intracranial hemorrhage, the use of NOACs like rivaroxaban is ideal. The only problem is the cost.
There's this last question, and I think you mentioned this already in your presentation. However, because it was the audience is asking for more clarification, so I'm going to ask it again. What are the measures that we can apply to protect our elderly from the risk of bleeding?
I think that we need to do a total assessment. If you have a geriatrician colleague, then get a geriatrician to see him as well. I mean, now you're talking about this multidiscipline approach. But I think in general, we have to look at the patients. How are they prone for falls? You got to find out about the home environment, make sure that they are less likely to fall, make sure they adhere to medications, see whether they have underlying. So I monitor, for example, the hemoglobin very carefully. Whenever I see a slight drop in the hemoglobin, I'll have no hesitation getting the gastro colleagues to have a look. Does the patient have a malignancy? Is there a silent bleeding? So, and then if there's any change in the renal function, you need to maybe reduce your dose. So I think all these things will help to reduce the risk of complications from the use of these drugs. There will always be some minor bleeding. We have to always reassure the patient, reassure the family that stroke prevention is still the most important.
Okay, thank you very much, Dr. Teo. This is the only time we have. I'm sure you can send your questions to Dr. Teo and he would email it back to you. So
Sure.
let me um, award the certificate of appreciation to Dr. Teo. The Philippine Heart Association presents this certificate of appreciation in recognition and acknowledgement of his invaluable contribution as a presenter in the PHA 51st Annual Convention and Scientific Meeting given this day. Signed by Dr. Ronald Cuico, Chair of the Scientific Committee, and Dr. Jude Eric Cinco, Overall Chair, and Dr. Orlando Bugarin, President. So, everyone, let's now move on to our next lecture. Hello, everyone. We now have our surprise lecture next. Now, of course, all of us have loved ones who belong to we all want to keep them healthy, right? On that thought, I would like to welcome to the virtual stage our guest speaker for this evening, who will share her expertise on keeping the romance even during the twilight years as part of a healthy lifestyle. She is a graduate of the University of the East College of Medicine, a trained anesthesiologist who is now a wellness specialist. She has years of experience as a resource speaker for medical and non medical groups on wellness. You may already be familiar with her as she is also the main anchor of DCMM's Private Nights, apart from her numerous TV and radio guestings. Dear doctors, I am very excited to introduce to you our next speaker for her lecture on senior romance. You're never too old for love. The ever energetic Doctora Lourdes Marquez, aka Dr. Lulu.
Good evening to everyone. Magandang gabi po lahat sa aking mga colleagues and of course to Dr. Tio Wee Siong. Good evening. And of course, Dr. Myla Supe, maraming salamat for introducing me. And of course, thank you very much for inviting me to the 51st Annual Convention of the Philippine Heart Association. Marami pong salamat. And of course, thank you to Bayer Philippines. All right. We have to talk about senior citizens because age is just a number. Okay? We have to keep the heart alive for senior couples. So, do we have to talk about this? Of course, we should. Okay? All right. But did you know that there's art and science of aging well? Actually, there's a physician's guide to a healthy body, mind, and spirit, and of course, the heart. Okay? Yeah. First of all, let's talk about the myths. Haka-haka po. Okay? Mga akala. Myths about healthy aging. Okay, get ready. Number one myth. Aging means a declining health and or disability. Is that true or not? No, it is not. That's actually a myth. It is a myth. Okay? Right. Why? There are some diseases that become more common as we age, of course. However, getting older does not automatically mean poor health or that you will be confined to a walker or a wheelchair. Oh, come on. Okay? Plenty of older adults enjoy vigorous health, often better than many younger people. Preventive measures like healthy eating, exercising, and managing stress can help reduce the risk of chronic diseases or injuries later in life. Okay, so aging means declining health and or disability. No, 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 it's a myth. Next, memory loss is an inevitable part of aging. Come on. That is a myth. Okay. Remember that as anyone age, you may eventually notice you don't remember things as easily as in the past, or memories may start to take a little longer to retrieve. However, significant memory loss is not an inevitable result of aging. Why? Because brain training pwede. Learning new skills pwede. Okay? Possible. All right? Number three, you cannot teach an old dog new tricks. Come on. That's actually a myth. That's a myth. Remember that one of the more damaging myths of aging is that after a certain age, you just won't be able to try anything new or contribute to things anymore. No, no, no. The opposite is True. Opposite. Okay? Remember that as senior citizen, you have a better wisdom that comes with life experience, because as senior citizen, we believe we have more confidence in ourselves. Okay? So number one, two, three. Ha ha ha. Those are myths. Okay? Now, aging well is all about habits. Remember that. It's all about habits. Okay? What do I mean by that? All right. I'm talking about the word dose. Dose means daily dose of happy chemicals. Okay? Daily dose of happy chemicals. These are the dopamine, oxytocin, serotonin, and endorphins. These are the brain chemicals that make you really, really happy. Okay? Dopamine is the reward chemical. The oxytocin is the love hormone. The mood stabilizer is the serotonin. And the endorphins is the what? The painkiller. Right? So dopamine, oxytocin, serotonin, and our endorphins. So these are what we call the happy brain chemicals, the happy neurotransmitters. All right? Anyway, be happy and romantic. Be happy and romantic. Be happy and romantic because this is good for the heart. Remember, the heart is very, very important. Be happy and your heart is happy. Okay, senior romance. So what is it? Remember, you are never too old for love. Never, never, never think of that. Okay? Smile. Okay? Even though you're old already, smile. Even Boots Anson Rowa said that. Smile. Get married. Be happy. Okay? In other words, enjoying romantic love in older age is still a big part of most people's lives. And it does not stop at any age. It means for our patients who are already old, okay, tell them enjoying romantic love is really, really good. Remember, companionship and true love exist during the golden years of senior couples. Tell that to your patients, all right? So, but what are the issues of old age? Come on, are there issues? Of course. Number one, number one issue is you think that you have a mindset that is already outdated. Come on, outdated mindset. What does it mean? It means that mention senior romance and you may hear some resistance. Seniors may think that they are too old to be, to be romantic. No, you're not. Okay. Actually, you have much more to offer towards a relationship. Seniors will better know what they like about, and seniors want something really, really good. They know what they like, they know what they want. Okay? They're actually more stable. So you don't have an outdated mindset. Another issue is about what they call safety. Safety. What is it all about? Unfortunately, my dear colleagues, seniors can be easy targets for thieves and scammers. Amorous seniors may be most at risk. Okay? I'm talking about, well, a May to December affair. Sometimes they trust a young person too much. They get in love too quickly, and you wouldn't know they're taken advantage of financially, right? So that's another issue. Another issue is about what? Societal disapproval. Society can also put a huge downer on senior romance. Okay? Senior romance may not be the norm. Okay? But there's no reason to frown. People deserve to feel happy. People deserve to be loved at any age. Okay? All right? So forget about the issues. All right? But I'm going to give you tips on fostering a successful relationship. These are my tips. Number one, communication. Good old communication. Number two, be honest with each other. Tell your patients, be honest with each other, to their partners. Respect each other. Have mutual support with each other. Tell that to your patients, okay? Be fun loving, enjoy life, and of course, unconditional love. Although the patient already had a stroke or any cardiovascular accident, of course, the love is still there. Unconditional love because it's good for the heart. Good for the heart. Yes, 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 yes. Okay, age is just a number. Remember that. Age is just a number. Keep the passion alive. Yes, you have to do that. Okay? Because you will live longer and you will look younger. Okay? We believe in that. Longevity and longevity. So to age with passion, ha, he, ho, hu. So what do I mean by that? Ha, he, ho, hu. It means ha, happy, he, healthy, he, be hip, ha, hot, you, humor. Again, happy, healthy, hip, hot, and full of humor. Okay? To age with passion, ha, he, ho, hu. Okay, so aging well. So what you can do today? What can you actually advise to your patients? Simple, very, very simple. The steps to aging well are the following tips so that your patients will feel great. Number one, tell them to follow a healthy, well balanced diet, meaning to say good carbs, no bad carbs, good fats, no bad fats, lots of essential amino acids, lots of vitamins and minerals through fruits and vegetables, lots of water. No soft drinks, no, not too much coffee, not too much tea, but only water. Okay? Number two, tell them to follow and take the medications you prescribe. Of course, stay physically active for healthy body mind. You cannot walk in the park definitely, but you can do Zumba at home. You can do yoga, Pilates. You can do that with your family. Stay physically active and do not drink so much. You can drink a glass of wine, one bottle of beer. That's okay, but quit smoking if you do. Tell patients, no smoking and stay socially active, stay connected with your friends and relatives. Do the Zoom, meaning to say, do it virtually when we talk about being socially active. So tell your pet, tell your patients who are already senior to, ask the children, grandchildren, to teach them to be techie. Okay, techie. Now, get the sleep that your body needs. If you sleep about 5 hours, that's fine. 4 hours for a senior couple or senior citizen, that's okay. Take a nap para makabawi kayo. Just take a nap. Okay? Okay, tell that to your patients, all right? So don't neglect yourself. Tell them to schedule check-up and stick to them. Follow up via teleconsultation, telemedicine, because the patients cannot go to you, right? Okay? All right. Now, practice good dental hygiene every day. Brush your teeth, brush your dentures. That's what you tell them. Okay, and of course, if any one of your senior couples would like to talk about sexual intimacy, you have to discuss changes in their body or function. Okay, be open to your patients. So you have to keep up with romance among senior couples. Tell that to your patients, all right, please, because romance keeps you young at heart. And definitely it's good for the heart. Definitely. Did you know that there are 8 different types of intimacy? It's not just about the word sex. Did you know that? Okay. Number one, if I talk about intimacy, it's all about liking. Physical intimacy means I like your eyes, I like your nose, I like your hair. Next is aesthetic intimacy, meaning I like your makeup. Okay. Number three, recreational. You share the same sports. I like the sports that you do. I like it too. Number four, intellectual intimacy. I like the book that you read. I like the poem that you read. Okay, that's liking intellectually. Number five, spiritual intimacy means the same religion. Okay. Number six is emotional intimacy, which means you can talk to each other because you have a problem. Number seven is, well, the sexual intimacy. But number eight is the most important among senior citizen, unconditional intimacy. Okay? Now, exercise. Exercise your heart. You cannot go to the park. Yeah? Of course you cannot. COVID, pandemic. Okay? But you can actually exercise at home with your with your children, with your grandchildren. You can do anything. Zumba. Yeah? Okay? You can do what? yoga, Pilates, whatever. You can actually exercise at home, right? Remember that we have 75 trillions of cells. Tell that to your patients. Okay, we have to do some anatomy and physiology to them. Okay, tell them that these 75 trillions of cells has to be nourished. Cellular nutrition is very, very important. They have to be healthy. So, what are we going to do today to create a healthier patient? To create a healthier senior citizen? How? Okay, so talk to them about free radicals and antioxidants. They have to understand the meaning of free radicals. They have to understand the meaning of antioxidants. Okay? As we all know, free radicals are already there from the time you were born. But, pag tumatanda tayo, we age more, we have more free radicals, right? And we have less of the antioxidants. Just to let you know that I always lecture not only to doctors, but to laymen about understanding about free radicals and antioxidants. Okay, now, it's important to re-energize the cells of our patient, to recharge their life, and talk to them. Tell them about the mitochondria and the antioxidant connection. Tell them to eat healthy, sleep well, exercise daily, and drink plenty of water. Okay? It's about the news, NEWS. Nutrition, nourish your cells, exercise, water, sleep, and I will add another letter A. A is for antioxidants, and you only get that through, not only through food, not only through fruits and vegetables, but also through food supplementation. It's important. Okay? There you are. Food supplements is important because not all senior citizens can eat the optimum benefit of just eating fruits and vegetables. I'm sure of that. So give them food supplements. Very, very important. Remember that our cells in the body are constantly dying. So they need the essential amino acid, they need the minerals, the vitamins, because our cells or their cells or cells of our senior citizen really dies. Okay? Remember, there's the word apoptosis, yeah? Okay, so deficiency in essential amino acid, vitamins, minerals can lead to inferior cells. Okay? And then this deficiency can lead to degenerative diseases and aging. And there you are. They are diabetic, they are hypertensive, they are osteoporotic, they have atherosclerosis, they have cancer, and they are, you know, the, the threat of cardiovascular accident is might happen, you know? You know that very well, my dear colleagues. So they need to be supplementing. Okay. My tip for senior citizen, it has to be aging with a plan. Okay? Remember, tip number one, learn to cope with change. What does it mean? Tell them to focus on the things that they are grateful for. Acknowledge and express their feelings. They have to look for the silver lining. Accept the things that they cannot change anymore. Okay? And tip number two is find meaning and joy. Tell that to your patients, okay? Very important. Wag lang magmukmok sa bahay. Okay? They get involved in their community virtually. Learn something new, play a new instrument, learn a new language. Okay, you cannot travel, yeah? Okay, make a book, make a memoir, enjoy the arts, paint, yeah? And tip number three is stay connected with your friends and relatives here and abroad. You can only do that through Zoom, yeah? And you can only do that virtually, okay? Because remember, as we grow old, by doing that, by being staying connected, it's a buffer against loneliness, depression, disability, hardship, and loss. Okay, remember, these are senior citizens, okay? Laging malungkot ang senior citizen. They're always depressed, right? Tip number four, get to active and boost vitality. How can you do that? Okay? Very easy. Easy lang po yan. Remember, they always have discomfort and disability, correct? So tell them to exercise, tell them to eat right and take care of themselves. They have to stay active, they have to sharpen their memory, boost their immune system, they have to manage the health problems and increase their energy. Take lots of vitamin B12. Remember, vitamin B12 is very, very important. Okay? And tip number five, what can you do? Keep your mind really, really, very sharp. Okay, that's very important. How do you do that? Vary your habits. Okay, talk about a new subject, challenge your brain. Okay, do a crossword puzzle. Okay, next. After a stroke, is there a romance or intimacy? Is This is a very good question. What if your patient asks for a romance? It has to be deferred. No, 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 no romantic activity if there is atrial fibrillation and a poorly controlled ventricular rate. Number two, no, 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 no romance, no romantic activity if uncontrolled or symptomatic supraventricular arrhythmias. No spontaneous or exercise-induced ventricular tachycardia. No, cannot do that. Cannot do anything, you know what I mean. Okay? Until the condition is optimally managed, then you can. Okay? Now, stroke can actually change how your body feels. Stroke can work, your stroke can actually make your body, change the body feels, works, and how you feel about yourself. Not only that, even your partner is affected. Okay? Para siyang caregiver na lang. Right? But studies have shown, remember, studies have shown that intimate activity can trigger it cannot trigger a stroke. Studies have not shown that intimate activity can trigger a stroke. Remember that. Okay? Now, but you may need to adapt to any physical changes, address any emotional changes. You have to tell that to your patients. Okay? In other words, the question is there intimacy after a stroke? Now, here comes the conversation. Here comes the approach. Talk to your patients. Screen for interest in sexual health. If your patient will ask you about sexual intimacy, about being romantically involved with your partner, don't close the book. Talk to them. Or if you think your patients are still young and still capable of loving, you know what I mean? Then open up the topic, educate them. Okay, you as a doctor should educate them. Okay, now common concerns of patients. You have to be mindful of this, my dear colleagues. These are the common concerns when becoming intimate after a stroke. Number one, their paralysis. Number two, they're scared that they might have stroke during intimacy. You yourself should correct that. And you have to correct their depression, their incontinence, their impotence. Only you can correct that or manage those problems. The aphasia. Tell your patients that they cannot just talk, just by talking. There are non-verbal ways of being intimate. Hugging, caressing, cuddling, embracing. Yeah? Okay? And then what else? Switching roles. Remember, if the husband has a stroke, then the wife is just the caregiver. Sometimes, it's a turn off already. Now you have to be sensitive with the concerns of your patients, okay? Okay? All right. So what are some other warning signs that you can give to your patients? Simple. This is long. Just give this checklist to them. Abrupt weakness or dizziness, shortness of breath, pressure in their chest area, tingling or numbness, loss of balance or coordination, difficulty speaking, excessive sweating, sudden vision loss, marked swelling, rapid weight loss, prolonged confusion, wounds that never seem to heal. These are the tips that you can give to your patients. Okay? All right. This is all I could say. You don't stop laughing because you grow old.
Hello, everyone. Welcome back. And we now have our Doc Lulu, no, to answer questions today. So I know it's been a long day for all of us. Our convention started at 7:30 in the morning, and it's really good, no, to have something quite light, no, to end the day, no? And then we're going to talk about romance, no, among the elderly patients para may connect. Parang ganon. So, Doc Lulu, gusto ko lang itanong
Yes.
kasi sure, no, that in our among our patients, no, it's kind of actually difficult to initiate conversations like this, no, especially and it doesn't have to be the elderly, no, even among our young patients, it's kind of difficult for doctors, no, to initiate this kind of conversation. Are there any tips that you can give us, no, physicians, no, paano natin tutulungan, or how can we actually help our patients start this conversation?
Of course, I know that. Definitely, that's your problem, right? Okay. First of all, think of it as ilagay niyo po ang paa niyo sa paa nila. Okay? Put yourselves into their shoes. Okay? Other patients who can still, the passion and desire is still there. They may not ask you, but they might give a tip. Somehow, when they visit you, there is some tip, and you should be sensitive about that, my dear colleagues, okay, especially you cardiologists, okay? Just this little tip means that they want to make it, okay? Then you have to start the conversation. You have to tell them, you have to be open to them. Some other patients would tell you, like, doctor, I want to make love, etc. Then don't close the topic. You have to continue the conversation. Never stop a conversation. Remember, your patient can be depressed. Number two, the scare that or the fear that he might have a stroke. Yes, other patients might think that they're already paralyzed, but they cannot do it. Come on, there's ways and means to do that. It's being, they call being creative. Okay? Tell them to communicate, connect, be creative to reach their climax. Okay? Because most patients might not think of the sexual intimacy part because they're so scared. But you have to open the topic, okay? And also, if every time you talk about this senior romance, the partner should be there, especially if he or she is still with the partner, okay? Kasi may tinatawag na switching roles eh. The other one could be just a caregiver or caretaker ng pasyente, tama? So in other words, it boils down to a very, very good communication. Yes.
Okay.
Yes. Okay.
The elderly population, no? Although pag elderly kasi, or our lolos and lolas, usually mga apo eh. So parang it's something which is taboo in the Philippine culture, not to be start talking, even among again, even among younger patients, no? So we have these things, especially for post bypass patients, no? Ang hirap i-initiate yung conversation of intimacy when you have a young patient. How much more yung elder, titingnan ka ng masama ng ako, na parang ano ba yan? Ang tanda-tanda na.
All right, I understand. Okay, so dalawang problema. First would be you're talking about a younger patients na may problema sa puso. And older ones, si talagang lolo, lola, they might not even open up about the topic. Okay? So you can tell the lola and lola, like for example, if there is already impotence and it's really be very difficult, but lola, lola, there's still the non-verbal relationship, or you know what I mean? And non-verbal sexual intimacy, how is that? You hug each other, you kiss, embrace, cuddle. You can tell that to your patients. Wag po kayong mahihiya. And actually, the patients will really love that because you are compassionate to your patients. Now, for younger patients naman, okay, they might not ask you because they are ashamed, okay, or the fear of having a stroke. Then my suggestion would be for you to open up, start a conversation. You wouldn't even actually tell that, okay, you can make love. Don't do that, okay? Of course, slowly but surely tell them that the desire and passion will come back. And then you might think that, ooh, I think I can make it, doctor. Is there a good medication for that? And then they would even say the word letter V. You know what I mean, doc? Okay? So you can actually suggest the right kind of medication for these younger patients. Okay? At least they know that you are compassionate enough that the care is there, doctors, right? You can do that. Don't be scared. Don't be ashamed. Don't just give them up to your psychologist or psychiatrist. Don't. Kayo po muna. Kung hindi mo kaya, then, okay, give them to the psychiatrist or psychologist. But for me, you start it. Oh my God, I'm gonna tell you, your patient's gonna love you. Magkakaroon ka pa ng madaming referral. True to po yan. Okay? Yes.
But there's also the other side of the coin. No? So you mentioned about caregivers. No? So usually after, especially for us cardiologists, so most of your audience are actually cardiologists or at least no working with the heart. So the fear, for example, after bypass, no, so they went through so many things. So they had a heart attack. They had, they went through a roller coaster of emotions. Finally, they were able to bring home their patients. But yun nga, no, naging caregiver na sila, and feeling of being pagod ka na eh, no? So you're tired. You have been, a nanny for quite a long time. How do you feel, yung balik mo yung sexiness and yung feeling na intimacy na pagod ka na eh. Ayaw mo na eh. All you want to do is, have a good rest after going home.
Definitely. Okay? So, yung sinasabi mo, the desire, the passion, yung gusto na wala na. Okay. Of course, it will not start abruptly. Okay, it might take years before the passion will go back. Okay, even the partner. Okay, for example, yung lalaki ang na-stroke or whatever, na CVA siya. And then the wife, of course, is also scared. Pero the wife has to be understanding. Dapat mag-usap silang pareho. Okay, this is what I like. This is what you should not do. It still boils down to a good old-fashioned communication. And if, for example, the patient or the partner will ask you, I give you a little tip about sexual intimacy, please lang po, buksan po ninyo ang kurtina, ang bintana regarding this topic. Okay? Don't give them kaagad to the psychiatrist or psychologist. All right? That's my tip. Pwede po yun, but slowly but surely, they will be able to understand yung kulang nila sa katawan nila. That's true. Okay? And for all those wives, of course, they have the need. Yeah? Okay? I have so many friends who complain, Doc Lulu, oh my God, I feel like into that heat of the night. Okay, what I'm gonna do? Okay, but what I'm gonna tell you is quite sensitive. I'm sorry. Okay, but I have usually a straight talk. Okay, for some wives, I tell them to massage your husband first, start from the neck and then down. And you know what I mean? If there's some stimulation there, then maybe next time there's more to the massage. Okay? Yes? And you can actually guide your patients. You can actually ask them kung may ganun po na mga step by step na nangyayari sa buhay po nila. Yes. It will work. Promise, it will work.
So there's a lot of tips coming from Doc Lulu, no? So hindi natin daw ididiretso kay Doc Lulu yung mga pasyente natin. Dapat kakausapin muna natin bago natin siya ipapasa kay Doc Lulu.
Correct.
And if you have any questions and nahihiya kayo magtanong, you can always go straight to Doc Lulu and I'm sure she will answer your burning questions for all of us. But sinesenyasan na ako, we're going over time, so this is all the time that we have. So I would like to take this time to award the Certificate of Appreciation. The Philippine Heart Association presents this Certificate of Appreciation to Dr. Maria Lourdes Marquez in recognition and acknowledgement of her invaluable contribution as a speaker in the Philippine Heart Association 51st Annual Convention and Scientific Meeting, given this day, May 26, 2021, signed by Dr. Ronald Cuico, Chair of Scientific Committee, Dr. Jude Eric Cinco, Overall Chair, and Dr. Orlando Bugarin, President. So thank you, everyone. That's all the time that we have. We hope to see each other soon, and I hope you all keep safe. Thank you very much, and good night, everyone. Thank you everyone for joining us tonight with Bayer. I would like to congratulate our speaker, Dr. Teo and Dr. Lulu, for those insightful talks. A pleasant evening to everyone, and always keep yourselves and your families safe. Good night, everyone.
Thank you, Dr. T. Wee Seong, Dr. Lulu Marquez, and Chairman Dr. Myla Gloria Supe. That concludes Day 1 of the PHA 51st Annual Convention and Scientific Meeting, Next Level Strategies. Thank you for participating and see you all again tomorrow. Good evening.